offered her to heal the tumor, and he applied some balms and poultices. So then the tumor resolved. So according to history, that was told to be the first recorded case of cancer. But was it really cancer? Nobody knows. It could have been an infection, it could have been an abscess, or it could have been something else. When did the first recorded case of cancer come? That was to the Egyptian mummies. When they examined those mummies, they found that maybe in 3000 BC there were some historical records of cancer. And then it was told to be that cancer is like a curse of God. But then finally, when the father of modern medicine in his era, that's 400 BC, Hippocrates, he coined the term carcinoma, which meant something like a crab. When he saw the cancer tissue or the cancer in the patient's body, he felt it looked like a crab with all its claws, just invading. And he felt that cancer is an imbalance when in the 4 body fluids, that is blood, phlegm, yellow bile and black bile. So whenever there is excess of black bile, there was cancer. And then moving further, in 1863, Sir Rudolf Virchow, he felt that when in cancer there is increase in the inflammatory cells, especially the leukocytes. And that was the time when he coined the term leukemia. That is a condition where there is excess of leukocytes in the blood of the patient. And in 1886, cancer was thought that it could be inheritable from parents. So he was a renowned ophthalmologist, he was a surgeon. So he had a patient of retinoblastoma and he did enucleation for that patient. And he was a boy, retinoblastoma is a pediatric tumor. So when the patient grew up, he got married. 2 of his children had retinoblastoma, and this is how they thought that cancer, some of the cancers could be inherited. Then, moving further, 2 other important theories of cancer came into the picture. The first one was by Ph.D. He laid the foundation for the 3 basic principles of cancer. That it is monoclonal. It comes from a single cell which becomes abnormal and proliferates without any break. And it could be because of a chromosome abnormality. And later on, in 1909, Sir Paul Ehrlich, he coined the term chemotherapy. So chemotherapy was a chemical. Actually, chemotherapy was not used for cancer first. It was used for infection. So any chemical which is used in the treatment was coined as chemotherapy. And Sir Paul Ehrlich also gave another hypothesis of the immunosurveillance theory. That is, whenever there is invasion of the body with cancer cells, first the body's T cells try to attack. Only when this immune system is escaped, there is formation of cancer. And then I think 1953 paid the hallmark, it was a major landmark in the cancer journey. That was with the discovery of the DNA structure. So even now, most of our treatments, be it chemotherapy or the targeted therapy, is based upon the understanding of this basic DNA structure. Now coming to work of systemic therapies, that is what I deal with as a medical oncologist. So whenever we talk of cancer, the first treatment that comes to everyone's mind is chemotherapy. So let's see. So unfortunately, the birth of chemotherapy started from the trenches of World War. So all of us know that war is not good. But for cancer, maybe that curse was like a blessing for majority of our cancer patients. So during World War I, what they found that soldiers who were exposed to nitrogen mustard had some abnormalities in the blood cells. And the major breakthrough happened with this ship. So this was an American ship, it was called John Harvey. It had nitrogen mustard bombs, they had hidden nitrogen mustard bombs in that. Nobody knew. And then when the Germans attacked this harbor, there was an explosion in this ship. And then people of that area who were exposed to that ship, to nitrogen mustard which was there in the bombs of that ship, had developed tumors, they had developed abnormal leukocytes in their blood, and many of them also developed aplastic anemia. So that was the bell which rang that nitrogen mustard could be used to treat cancer. So the first nitrogen mustard which was used in cancer was miclorethamine. And this was the first, it was by Sir Goodman and Gilman, that they used these alkylating agents for the patient of Hodgkin's lymphoma. So if you see this, this lymph node, it just totally melts with that alkylating agent. And then moving further, 1947, Sir Sidney Farber achieved the first ALL remission in a pediatric boy. That was with the drug aminopterin. And the major landmark, that is the drug methotrexate, was by a very ardent Indian, Sir Yellappa Subbarao. So he identified this drug methotrexate, which we still continue to use in many of our patients. And this drug is one of the major hallmark which caused the first cure of cancer, that is solid tumor cancer, that is choriocarcinoma. So even to date, whenever we see a choriocarcinoma patient, we are very happy because we can offer 95%, more than 95% or 99% cure rates. And one of the most commonest curable hematolymphoid malignancy is acute promyelocytic leukemia. Then moving further, in 1960, the era of combination chemotherapy came. So MOC regimen was the first regimen which was used in lymphoma. So what they found out that the usage of combination therapy was, you can use multiple drugs at the same time and not reach the maximum tolerated dose of each drug. So it also helps in preventing drug interactions, and it also helps in attacking cancer at different stages of its cell cycle. So not all cancer drugs were born through bloodshed. We also have some cancer drugs which have been plant derivatives. So famously the Pacific U drug, the Pacific U plant for taxates, and the periwinkle for vincristine. So majority of the drugs were from plant derivatives. So this is the follow-through of the development of chemotherapy drugs over the decades. We have got multiple of drugs, and then at 2010 it is the latest. I think 2010 a major shift happened to different other treatment options which I will be talking about. So if you see, this is the chemotherapy classification of different chemotherapy drugs. So the beauty is each chemotherapy drug acts on different phases of the cell cycle. So that helps you in selecting the drug which is used for that particular cancer. But whenever we are using chemotherapy, the one major criteria is the cells should be rapidly dividing. Only if the cancer cell is in a rapidly dividing phase of its cell cycle, does chemotherapy act. So along with cancer cells, you also have normal cells which are rapidly dividing. Like you have hair, so that causes alopecia. You have your mucosa. So whenever there is side effect of chemotherapy, you will end up in having mucositis. So chemotherapy has its own side effects too. So what happens to the cells which are not rapidly dividing? So those cells could be increasing on some other mechanism. It could be hormonal therapy. So that term was coined by Sir George Beatson. So very interestingly, he was not a doctor before. He was working in an estate. So in an estate there were cattle. So he was very curious, he was seeing the lactation practices of this cattle. And then he thought that the breast is not really controlled by the nerves. The breast is mostly partly controlled even by the ovaries. So future, when he became a doctor, he thought that whenever there is breast cancer, why not you remove the ovaries and see? So he removed the ovaries of 3 breast cancer patients, and he found that there was a significant reduction in the tumor size. So then, just with 3 patients, the hormonal therapy in breast cancer came into picture. So, that era was so beautiful. You just had to have 3 patients to prove your point. And now, even with 2,000, 3,000 multi-center randomized controlled trials also, we feel, we're not very happy, just a 2-month, 3-month benefit. So, I think that era was like really something different. So then using the same principle, different hormone receptors came into cancer biology. For example, for breast cancer you have the estrogen receptor, for prostate cancer you have the androgen receptor, and for some of the endometrial cancers you have the progesterone receptor. So this knowledge was finally utilized the maximum in breast cancer. So in breast cancer, if you see, targeting the estrogen receptor, you have multiple pathways. You have the aromatase inhibitors, and you have tamoxifen, which is a selective estrogen receptor modulator, and you have the newer drugs which degrade the estrogen receptor totally. So that initial theory which came from cows, was translated into breast cancer research. Then another major landmark happened that earlier they knew that cancer could be because of some chromosomal abnormality. But what chromosomal abnormality no one knew. So that happened in 1960 when in CML patients, these two scientists found that one of the chromosome, that is chromosome number 22, is shorted. It's a very short chromosome in most of the CML patients. And then they found out that it's not shorted, it's because there is a translocation between chromosome 9 and chromosome 22. And using this knowledge, later on, imatinib drug was got into the picture. So this translocation 922, what does it do? It causes an alteration in the BCR-ABL kinase gene. So imatinib was a drug which targeted this. So this was the first landmark trial in 2000. Until then, CML patients, the most curative treatment option for them was an allogeneic bone marrow transplantation. But with this drug, the entire CML picture changed, and now CML is become like diabetes or hypertension. You just take a pill and you are good to go. Moreover, it's become much better than diabetes and hypertension. In diabetes and hypertension, I think majority of the times we can't stop the medication. But in CML now, after 5 years, we can give the option of stopping the medication too. Now coming to another landmark of monoclonal antibodies, that was in 1975. So the whole beauty of monoclonal antibodies is, to make it short, it has two main mechanisms of action. One is a direct inhibition, and number two is improving the immune system of the body. So this was a beautiful story. This was shared to me by Guru himself actually. I got this slide from him. So this was Mrs. Barbara, who had her breast cancer progressing on chemotherapy. Then she thought that enough is enough. I don't want to die being bald and just puking all the time. Then Dennis Lehman had a trial. Initially she refused. But then he said that he asked her tumor cells and he found that there was an increased amplification of HER2. Each and every tumor cell was having HER2 on its surface. So then that was the time she agreed, and that was the golden moment of the drug trastuzumab. This was the hallmark drug which really changed the breast cancer landscape. And even now we are just manipulating with this HER2 with most of the other drugs. Another landmark drug for hematolymphoid malignancies was rituximab, which is targeting the anti-CD20. So now if you have any lymphoma which is CD20 positive, you have a drug that is rituximab. So with all this, I think this is the, after 2010, somewhere 2003 onwards, when the Human Genome Project was started, the shift of cancer happened from chemotherapy to more towards genomics. And then now we have the next generation sequencing, and now we can also you can sequence the whole genome. So this has been getting into our practice nowadays. So with this, the idea of genomics, the molecular targets came into picture. Now you mention each and every disease, there is one molecular target which you can use. So it can act on any system, that is, it can act on the cell surface, it can act at the nuclear level, and it can act on the downstream signaling pathways. So coming to hematolymphoid malignancies, I think the major change happened with transplantation. That was in 1956 when a patient's twin brother's stem cells were transplanted, and now we have come to the era of CAR-T therapy. So that is chimeric antigen receptor T cells. So what is CAR-T exactly? So you take the patient's blood cells, you do a leukapheresis, and then in the lab you activate his T cells. That is step number 2. So this T cell expansion and then you use a non-active viral vector and you do the gene transfer, and then you have a modified T cell. So it's got these chimeric antigen receptors on its cell surface, and again you expand those CAR T cells and then you give it back to the patient. So when those modified T cells, that is the CAR T cells, come back to the patient, it creates an immunological response and it attacks the cancer cells. So if you, now everyone would be saying, you know, the era of chemotherapy for cancer is gone, now it's immunotherapy. But immunotherapy did not start now. Immunotherapy first, the principle was laid in 1920 itself. So if you see this paper, he had mentioned that there's a cure for cancer with immunotherapy in 1920. But now in 2020 we have started using this drug. So what happened for the last 100 years? His theory got rejected. Sad part is, why did his theory get rejected? Because in the same institute, Sir James Ewing was also working, and his principle was more focused on radiation and radiation therapy. So because of that, and his position in that institute was slightly stronger, because of that the theory of immunotherapy was suppressed. But now we have this drug, and I must say, I think this is a drug which has really changed the chemotherapy picture into the entire shift, and it also helps many of our cancer patients. Now, if you carefully select cancer patients for immunotherapy, we have seen complete responses in majority of our patients. So usually what does immunotherapy do? It either acts on the PD-1 or the PD-L1 level. So this is a tumor cell. So whenever there is a tumor cell, it puts your body's T cells into sleep mode. Why does it go into sleep mode? Because there is interaction of PD-1 and PD-L1. So with immunotherapy, immunotherapy can either block the PD-1 or the PD-L1. So when either of them is blocked, the T cells are awakened and it starts attacking the cancer cells. So that's the mechanism of immunotherapy. And last but not the least, now we have something called as ADC, that is antibody drug conjugate. It's like a smart bomb. You know, it reaches the cancer cell, it attaches on the surface of the cancer cell, and the chemotherapy drug is got into the cancer cell. So it is very particular. It's just like a missile, you know, it's identifying the cancer cells and just firing them. And then later on, now we have the cancer vaccines. Cancer vaccines have not yet really come into our practice, except for maybe the cervical cancer vaccine, which also helps in other human papillomavirus infections. The mechanism is the same. You are just improving the T cell activity. So in short, about evolution of radiation therapy and surgery. So it all started with Roentgen X-rays. This was the first X-ray of his wife. You know, when she saw this, she said, "I'm seeing my death." And that was your wedding ring, which moved on to Marie Curie's invention of radium by her and her wife. Unfortunately, she died because of her own radiation exposure, and even now her tomb is within a lead coffin. Even all her write-ups are in a lead coffin. So this is the first ever X-ray treatment where radiation therapy was used for cancer, and then we moved to teletherapy and telecobalt, and now we have the linear accelerator. Initially it was X-ray planning, and then they used a 2D image of CT scan for planning, and now you have a 3D and a 4D conformal planning which can be used in radiation. You also have intraoperative radiation therapy where you are putting some wires into the tumor and the radiation is being delivered. And last but not the least, now you have a surgery without the knife, that is cyber knife, which is very focused, precision, and not much of toxicity to the surrounding structures. Coming to evolution of surgical techniques, before anesthesia it was crude, it was painful, lot of morbidity, and then I am just giving an example of breast cancer which translates into other cancers also. So if you see in 1932 modified radical mastectomy came, before that Halstead's procedure, and then modified radical mastectomy where a part of the muscle was saved. And now you have the nipple sparing and the breast sparing surgeries with lot of reconstruction which has come into the picture. And now a person sitting in somewhere abroad also can operate on you in India. So that's all thanks to robotic surgery. So where are we heading? Where is our journey heading to in future? Personalized medicine. That is not one thing fits all. So you have one cancer patient, you do their molecular profiling, you see what acts best on that particular mutation, what are the toxicities which you are expecting based upon his genetic profile, and what are the resistance mechanisms. So majority of the times we see that a cancer patient fail treatment. So if you are aware of the resistant mechanisms at the beginning only, it helps you to select the drugs better. Future is gene therapy, that is use a transgene to change the genetic structure, and thanks to AI that has come into our practice already, we are using it for diagnosis, we are using it for maybe taking treatment decisions. So with all this journey of cancer from an incurable disease, it has become curable, and for many it's just become a chronic treatable disease. So now nobody says palliative medicine in cancer. Many of them have started using the word, it's a chronic care. There's no more palliative care in cancer. So what have we achieved? Initially, I think in 1900s, overall, the 10-year survival rate of cancer was 25%. And in 2020, overall the 5-year survival has improved to 50%. So where are we heading? Future is 85%. So why not 100%? Can 100% happen in cancer? I wish it could, not as a medical oncologist because I will be jobless, but for my patients. I wish we could achieve 100%. But I think when we achieve 100% in cancer, there will be some other disease which will come. Thank you.
Thank you very much. We have time for a couple of questions. Anybody at the back? We'll take questions from the back first. Do you have any questions? If anybody has a question, please come forward, step forward and identify yourselves and then ask the question. No? There's a question.
Oh, it's a wonderful talk, RANA. It felt like reading the whole data from page 1 to the last page. Very nicely compiled. It was a wonderful talk.
Yes, sir. I also wanted to remove your phobia. Even if the cure rate is 100%, you will continue to remain in the job. Because unless we reduce the incidence and achieve 100% prevention, then you are likely to be slightly off the job. So reassure. Thank you so much. And I don't know if the organizers.
Thank you once again. Thank you once again to our esteemed speaker. I request our chairpersons to give certificate and a memento to the speaker. Sirs, and I request all the delegates to kindly applause for our speaker. Thank you, sirs, and a heartfelt appreciation to the chairpersons for guiding the session so gracefully. Our next session focuses on an area of growing importance in modern oncology, particularly in vulnerable patient groups. The topic for the session is food allergies in pediatric oncology. The session will be delivered by a highly distinguished international expert, Professor Dr. Afuroglu, Project Scientific Director, RIDM, for Quality of Life, European Medical Association, Germany. Madam is globally recognized for her contributions to pediatric care, allergy research and quality of life frameworks within oncology. Madam will be addressing the gathering virtually. To chair the session, we once again have our eminent chairpersons, Dr. Dwarka Nath and Dr. Guru Prasad Bhatt. I request our chairpersons to introduce the speaker.
Thanks to Indigo and this, that's why we are not able to get some of our speakers here. I know now it's been almost like a second observation. Local speakers we are able to handle, but sorry for that aspect. Madam is a highly accomplished medical and public health professional with 25 years of experience in phytomedicine, preventive healthcare and health education. She serves as a scientific chief of RAGHAVENDRA for Quality of Life under European Medical Association, and her field of expertise include gene therapy, whole genome and NGS. And she holds a Doctor of Medicine and Integrative Medicine, a Ph.D. in Public Health and a postgraduate diploma in genetic and gene therapy. She's also a UNESCO member. She has multiple publications. She's a US brand ambassador also. So, very distinguished speaker we have. Over to you.
For inviting us to join this. Unfortunately, we couldn't be in person, and I would like to share this as it's a video presentation. I try to make it as much as possible. So this is a small presentation which is a work of last 10 years. And you can see here that's my son and my mother, and we were in Gilbert Memorial Hospital where that was the first time on his birthday he wanted to give something or visit to the cancer hospital to make the children happy or something like that. And this story started way back 10 years ago in 2015 and 16 and 2017 when we were there and we wanted to buy some fruits and some sweets or something like that, and the doctor said they have a lot of allergies and intolerances, and that's where we understood the whole system. And this is a small presentation, so it's almost about 10 years of our work, and now this goes as further research and publication for both Kamal and me. So here it is, and you can see here, like when we went down, they started to ask the significant challenges posed after chemotherapy. The children have acquired intolerances, allergies, so we cannot give any food. And then we start to buy some toys for them there. And these are some of the toys, like, you know, the glowing balloons and the masks and everything, where we had to check. We don't give anything to eat, you know, like the fruits, we don't know which kids. So along with the children, the mothers are also there in the pediatric ward. So we also bought some toys for the thing. And this is how we can go for a testing. So identifying each, then the next step started when we started to talk. Every mother gave us a different vision, a different view for every child. So the allergy testings were only skin testings and professional guidance like pediatric consultations. The pediatricians have a huge load, 80 patients per day in Kimban, it's a lot. So they cannot go for a personal guidance, and then identifying the allergens and avoiding them and putting them out, it takes a long time. So nutritional care is very critical for the recovery of the children. So they don't eat, they start to vomit, and they start. So you can see here we created a lot of data, like it was a huge data for us which we are still sitting on, and we don't publish it because we have a lot of data protection policies and a lot of things. So the nutritional care for each child, we documented each kid's allergies, each kid's intolerance, and what was happening, and what was the prevalence in pathophysiology. Food allergies are increasingly prevalent, influenced by chemotherapy in impact on immune function and gastrointestinal health necessary through understanding. You know, like they used to say, when the stomach used to start to pain after they bring prasadam from the temple, and then they start to vomit, and they brought something like zamzam water from the thing. They start. So we don't know whether they are okay with that prevalence and what is the physiopathology of it. So typical allergic reactions, manifestation, diagnostics, and how is it? Like suddenly, like I told you, they used to get zamzam or prasadam, and how did it impact? And what was really happening? Typical allergic reactions, atypical symptoms, diagnostic testing. So you cannot afford the diagnostic testings like intolerance tests, and these are like coming new in a government hospital or something like that. But you can see the mothers gave us the early recognition. So the mothers were the ones who were giving us a crucial early recognition, either agala, adagala, like rashes and mostly hair falls and other things, like the mother started to give. And then we brought in a complete concept of multidisciplinary strategies, like the medical team meeting. We started to discuss with the doctors and you know, like it's a government bureaucracy and the doctors, and guiding on the nutrition guidance, evidence-based practices, like what are the practices and allergy management sessions. So we could handle some of the cases in that way. And the impact on the immunity, like how it is impacting on the immunity, what are the local herbs available, what can be the impacted, as simple as mango. Mango, you know, you have raw, you have ripe, you have unripe and raw, like there are different, there's small mangoes, big mangoes. So mango itself can be that, but can it lead to an allergic risk? What was the allergic impact? So then heightened allergic sensitization, immune response, allergy mechanisms, and gut microbiota. So most of the time, immune response, okay, the immunity is low because of the chemotherapy going on, and what is the allergic histamine, mast cells, allergic mechanisms, whether it's an allergy or it's an intolerance, whether it's an acquired allergy or an acquired intolerance, then gut microbiota. You know, everybody were getting sandwiches. It's a wholesale food which is illegal. Or is it necessary the children have this food? So I just put a picture of the food which I like to have for my stomach cramps or something like that. You know, something like it's a mixed diet which is really available in our kitchen. Is it a crucial food allergies? What is it going on? How does it impact? So you have a crucial making of that diagnostic tool. So we can use algorithms, assessment and nutrition. So algorithms is the basis of, like if you have 10 children there, like 100 children in the pediatric ward of RAGHAVENDRA hospital. So out of 100 we can just suggest 10 or 15 or something like that. And we can go ahead on it. But you know, it's become simple, like what is happening, how it is happening, what are the cases going on, what's going on, and everything of that. So probably that would be the best option or the suggestion we have. And creating an assessment, evaluating the nutrition deficiencies for personal plans. We can get a pointer evaluations. It's just we need time. We can use the interns or we can spend some doctors. We can say, okay, I'm a practicing doctor. I would like to spend 1 hour in a week as a charity to talk to the pediatrics and create an algorithm, create a nutrition plan, talk to them. So predicting health outcomes with AI insight. So how can we predict with the AI? We have AI, a lot of information is being fed on Instagram, Facebook, LinkedIn and all those. But AI gives you the answers which is fed. So we need to understand beyond the AI, we need to have a personalized meal planning. We can take the support of AI where we create our own AI data planning, because where we can insert our own data information and we can extract our own meal plans. So with the promise of the AI, how we can do it? Like both, we have to balance the promises. So if I have not feeded the orange juice with the orange peel and everything, that was one of my picture of during pandemic, like what we had. So if you feed them and that comes out as a thing. So we need to understand what is we are feeding, and then we get a personalized meal plan, a properly assisted meal plan. Okay, now I can just say, okay, here it is like a salad. It's a picture of the salad which I prepared for myself. We have a salad, we have cucumber, we have carrots, we have tomatoes, we have onion, we have potatoes. But we need to look at the choices which influence the metabolism within the system. So that's where I think, and we can go in for a balanced nutritional implications. Let's go in for some balanced nutrition implications where we find how we can get the immune response, allergy mechanisms, how can we get this, the most important with the gut microbiota balance, how can we get the herbs around us, how can we get the food around us. India is rich of vegetables, so we create together. So first the IgG proteins, so creating the antihistamine response. Looking here, this is an antihistamine allergy mechanism response. We can go in either with the IgG protein from the blood serum, or we can go with the IgG protein in the hair samples, hair tissue micronutrient analysis. So now with these two, we can make a chart, and then we can amplify the chart as how we can get into that. And that's why I'm very, very thankful for the entire team, and I would really like to make my presentation short because it will be live a video presentation. So I don't want it to make more boring of it, and this is where I'm looking at how we can give a personalized diet plan, how we can personalize them. You know, like the typical asymptomatic diagnostic testing, how can we bring them together, and how it's almost 10 years and now we are together bringing, because this is my journey in the cancer thing. You can see here, this was how I look, and here is my email ID and my telephone and the website. So this is me right now, and I'm talking to you. Actually, it's cold, so it's there. So you can see it was not only the weight loss or something in 2 minutes, it's a lot of transformations within the body. So this is my contact information. Please write down my email ID, and if you want to get in contact with me, let's discuss. I would prefer an email, because email you're sitting on the desktop. I prefer to look at the email and answer your questions. So any questions, please, you can send it to me on my email, and here is my email. So I'm highlighting my email. And thank you so much again for inviting, and we are 10 years into this. I think it will take some more decades, like another 10, 15 or 20 years, but still the thing continues as more and more they are increasing predictions every day. So I hope we can be able to do this. And thank you very, very much. And here is, I would love to be in person, so maybe next time we are there in person. Thank you so much.
This is a recorded lecture, so there is no interactive session for this. With this, we come to the end of the first session. We thank the organizers for this opportunity, and also the audience for somewhat a silent participation. Thank you.
A heartfelt thanks to Madam for that enlightening presentation. A deep sense of appreciation to our chairpersons for their expert guidance and coordination of this session. I request Dr. Suchita Kumari N and Dr. Vrinda J. Bhatt to do the honors for our chairpersons, Dr. Dwarka Nath and Dr. Guru Prasad Bhatt.
We now move forward to a highly significant and clinically relevant session titled Role of Anesthesia Expert in Pediatric Oncology. It is a privilege to have with us an eminent expert in this field, Dr. Christopher Rohrig from AINSF, Germany, a distinguished anesthesiologist known for his vast contributions in pediatric anesthesia and peri-operative care in oncology. To guide this session, we are honored to have two esteemed chairpersons, Dr. Madhukar Thakur and Dr. Edwin Dias. I request Ms. Rashmi Shenoy to introduce the chairpersons.
I call Dr. Anu to be the rapporteur for the session.
To introduce our chairpersons, we have with us Dr. Madhukar Thakur, who is a distinguished professor of radiology and radiation oncology at Thomas Jefferson University.
So, first of all, it's my first to English translation presentation, and first of all, also would like
Dr. Madhukar L. Thakur is a distinguished professor of radiology and radiation oncology at Thomas Jefferson University with an additional appointment in urology. He serves as the director of the laboratories of radiopharmaceutical research and molecular imaging. Dr. Thakur has made major scientific contributions by developing innovative radiopharmaceuticals for imaging and therapy. He has published over 500 works, including journal articles, reviews, book chapters, abstracts, and several books. We also have with us Dr. Edwin Dias. He is the Director of Research and Publication and Professor and Head of Department in Pediatrics, SINGH and RC. He has pursued MBBS, MD, DCH, DNB, MNAMS. He has published 200 research articles, 14 books, 13 textbook chapters. He is also the Board of Studies PG member, Nodal Officer, Snakebite and Rabies, Government of India, Dakshin Kannada, COVID Committee member, co-founding editor and co-chief editor, IJHSP, Srinivas University. Named Achiever and Pride of India Business, Tax.com, editorial or reviewer of 30 index journals. By this short introduction, I welcome you both, sir.
Thank you very much. To introduce today's speaker, we were in touch long time, at least 6 months ago. Dr. Christopher Roy came down and gave us a talk. He's an highly experienced German medical specialist with an extensive background in anesthesiology, surgical intensive care, emergency medicine, pain therapy, and palliative care. He did his schooling in Hermann Hesse and Kepler Secondary School, and following a nursing service here at the University Mental Hospital in Tübingen, he pursued psychological studies in the University of Bonn and completed his medical in Cologne and Münster. During this period, he worked in intensive care at the Institute of Biomathematics. He passed his formal medical examination in 1992 and trained extensively in anesthesia and surgical intensive care at the University Hospital Münster from 1993 to 2006. He obtained his medical license in 1994 and achieved multiple advanced qualification in anesthesiology, emergency medicine, acupuncture, manager certification, radiation protection, pain therapy, and basic psychosomatic care. He served as a senior physician at Medan Hospital, Stanford from 2007 and later as a senior consultant at Klinikum Oslo from 2008 to 2022, covering anesthesia, intensive care, pain therapy, and palliative medicines. And over to Dr. Christopher Roy.
once again on behalf of Dr. Christopher Roy. He has earlier made his presentation in German and the same presentation I'm bringing forward in English. So, first of all, it's my first English translation presentation, and Mr. also would like to thank everybody inviting us, and his presentation was very precise and it was all in German, so we could go through. So here he is there. We visited the hospital, and there were discussions where the role of an anesthesiologist in the pediatric oncology, and he put some points there. Here, like pediatric oncology presents and with us a unique medical and human challenges. Children with malignant not only require the surgical, physiological, physical support, but also there should be a lot of other things like specialized oncological treatments and safe and empathetic support through all the diagnostic and therapeutic steps. Yeah, this is in German, and now it comes here in English. The anesthesiologist's prime responsibility is to ensure the safe administration of anesthesia during surgical and diagnostic procedures, operations, and other aspects of it. So that's where it's expertise. So this is an introduction, understanding the critical role of an anesthesiologist. So especially ensuring the safety, the data protection, and most of the children will speak about their traumas, what's happening and what's not happening, how the world society is working on that, and how it has to be there. So this has to come in the pre-operative assessment, ensuring safe and steady care. So they have to be comfortable, and most probably, like we both were discussing, how Christopher, would talk to the kid before, the child before, the anesthesia, and in oncology, the anesthetist has to come in together with that. So here are the interoperative management and pediatric tailor-made techniques. There should be trainings for anesthetists to do tailor-made techniques where they can help the pediatric oncology. Then the post-operative care where you have to manage the complications, monitoring complications, and pain management both together. So the effects of chemotherapy and radiation, then organ sensitivity, immune system, medication interactions, long-term effects. So an anesthetist is needed in all this. It's put forward in the German presentation as it is. Then managing the immunocompromised pediatric patients, how we can be before the day. Strategies for managing difficult airway access. So the latest one, what he was thinking, and he had a training also in Munster, how we can have video assisted airway access. So this has to be brought in where we can make it work completely. Then the psychological needs in the pediatric anesthesia. So minimizing the trauma. Play therapy helps alleviate anxiety during the procedures. Like just the anesthetist with the kid and just having a game just before the operation theater table or something like that. And the role of an anesthesiologist is summarizing the contributions, like how they are the first persons who are seeing and they can talk, like they can make them comfortable before anesthesia is done. Some kids also need anesthesia, as chemotherapy and radiology because of the post-operative machines. And the direction is where we can take innovations in anesthesia, bringing the things like new anesthetic agents, advanced monitoring technologies. And this is what like he's put it up in German, the whole thing, and I just made a little brief so that like everybody is not bugged up with it. So yes, we are ready to collaborate, and we will be preparing modules on how the anesthetist plays an important role in pediatric oncology. And we will have a shortlisted module where we will get together for palliative care, and modules will be there in 2026. And once the modules are done, we can do the activation. And thank you again. And I just need a brief of 5 minutes because he's already done it in German, and it's just okay. Thank you so much.
For all the audience, I think, since it is a recorded one, so there will be no, I don't know whether you can ask some questions, but I would like to give some of my brief experiences in managing pediatric oncology. You saw Kirbai. So we were posted in Kirbai, and when we saw the baby with leukemia and having multiple bone marrow punctures, so we gave the child a toy and asked the child, how will you do the bone marrow? So the baby took the syringe and the needle and showed the bone marrow. And it's very painful for a baby, believe me or not. So what we were doing usually, we were giving them something called light tea cocktail those days. And now, since the anesthetic is very important, and now because of a lot of things, they go on to a lot of drugs like ketamine, propofol, and dexamethasone. So these are some of the drugs which are given to the babies. And usually, the implications, what I try to summarize some more points on this. The necessary peri and anesthetic care is very important, and usually to prevent any vasovagal problems. The other day, even doing some biopsy or some removal of pleural fluid. During the procedure, the patient went into vasovagal shock and the blade went into the chest of the person. So this is the problems what I think you should know. So ideal anesthetic care is very important. Pre-operative, peri-operative, especially you can understand it when for example, the anesthetic care, the drugs which are given, the side effects, these all have to be taken into care. And also remember that you saw play therapy. It's very important to give counseling to the parents and prevent any morbidity or mortality during the procedure. May it be a bone marrow, may it be a biopsy, may it be a mediastinal biopsy, or any of the possibilities, maybe a CT scan, MRI. So here the anesthetist plays a great role in the pediatric oncology patients. So any more, I think this may suffice, and we'll go on to the next topic.
Thank you, sir. We now proceed to an intellectually stimulating and future-focused session titled Next Generation Translational Nanomedicine as Biotherapeutic Agent for Better Health. Today's speaker is a globally respected researcher whose work bridges nanotechnology and medicine with remarkable precision. Dr. Harish Kumar Madhyastha, professor at the University of Miyazaki, Japan. To chair this session, we once again have our eminent chairpersons, Dr. Madhukar Thakur and Dr. Edwin Das. I request the chairpersons to introduce our speaker.
Thank you very much. And on behalf of Madhukar, I want to introduce this speaker, Professor Harish Kumar Madhyastha, leading researcher in next generational translation nanomedicine. So for most of you who are sitting here, I think nanomedicine must be on over the head. So it's like Greek and Latin to some of you. And he's a next generation. So he's really into great research. His work focuses on developing nanotechnology-based therapeutic strategies that enhance human health, especially in the areas of regenerative medicine and wound healing. He has made significant contributions to the understanding how mRNA regulated mechanisms influence tissue repair, how nanomaterials can accelerate the healing process. In addition, Professor Madhyastha laboratory investigates the molecular pathways involved in late-stage carcinogenesis caused by heavy metal toxicity, with a special emphasis on arsenic exposure. His team explores exosomes as a nanocargo system and uses the advanced sequencing approach to uncover their role in cancer development. He has strong research record, extensive academic experience, and leads multiple interdisciplinary projects integrating nanotechnology, molecular biology, and toxicology. I think he's one of the leading experts. And over to Professor Harish Kumar Madhyastha. He is going to do an online presentation. So please note. Just to introduce the topic, nanomedicine applies to nanoscale materials to 1 to 100 nanometers to medicine. At this size regimen, novel physical and chemical properties emerge. High surface area to volume ratio, tunable chemistries, and ability to transfer biological barriers like leaky tumor vasculature, enhanced permeability and retention, or EPR effect. These features enable nanoparticles to carry and protect drugs, adjust pharmacokinetics, and target disease tissue more precisely. Ineffective nanoparticles carriers can increase drug solubility and bioavailability, improves half-life and tissue accumulation, and even cross the blood-brain barrier. We are just trying to get the link, so kindly excuse us.
So the sheer presence of all of you to me indicates the importance of this meeting that Dr. Suchita Kumari and her colleagues have put together. And I really appreciate that, and I think we should congratulate her. Those of us who have organized meeting, international meeting of this magnitude, tell us what it takes to meeting of this size successful, and it has begun well, and I'm sure it will end well, and I congratulate them once again on my personal behalf as well as on all of us. Thank you, Dr. Suchita Kumari and all of her colleagues.
Thank you, Dr. Madhukar sir, for your very kind words. They definitely inspire us and keep us motivated to do better and do well in the upcoming as well as the next day too. Thank you, sir.
Again, introducing the topic once more, these nanotechnologies, they include liposomes, polymeric nanoparticles, dendrimers, quantum dots, carbon nanotubes, metal and magnetic nanoparticles like gold, silver, iron oxide and other metals, nanorobots and micro-robots, and each nanocarrier platform offers distinct design options, surface modifications with antibodies, peptides or polyethylene glycol, enables targeting and immune evasion. Biodegradable materials are often preferred to ensure safe clearance. Altogether, scientific foundation of nanomedicine combines material science with cellular biology to engineer vehicles that overcome the limitations of conventional drugs, that is, poor solubility, rapid clearance, off-target toxicity. One of the main clinical and preclinical applications of this is in cancer. And one of the nano drugs was called doxil, pegylated liposomal doxorubicin. And one of the drugs we used was amphotericin, liposomal amphotericin in fungal infections, which are common in oncology.
Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA, proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA Rao, started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively.
Iron oxide nanoparticles can treat glioblastoma patients and also been used in Alzheimer's and Parkinson's disease. Polymer coated nanoparticles delivering dopamine or siRNA and intranasal nasopharyngeal. So another point is usually autoimmune and inflammatory diseases. Nanomedicine also shows promise in modulating the immune system. There also can be, especially immunotherapy vaccines are the most common, very interesting and hotly debated topic is COVID vaccine and nanoparticles. I think there has been a lot of issues on that and on the spike protein. So nanomedicine is also involved in precision medicine, targeted delivery, gene therapy and diagnostics.
Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao,
Please continue, we can hear you.
Hello, sir. Hello, madam. Okay.
You can start, you can start.
Start ಮಾಡಲಾ?
ಹೌದು, start ಮಾಡಿ, we introduced you.
Hello. Am I audible?
Yeah, you are audible. Please continue.
Hello.
We can hear you.
Yes, sir. Am I audible? Hello. Hello.
You are audible.
Hello, we can hear you.
My screen is visible?
Yeah, visible, visible. Carry on, please.
It's visible.
Okay. So, okay, let me start.
Yeah, continue.
Okay.
Yeah, good morning, everybody. I am Mathesna, attached to the University of Miyazaki. Today and first of all, thank you very much for the organizers of the Srinivas and SINGH 2K25 to give me the opportunity to share my experience in the area of nanomedicine. Today, let us discuss, instead of presentation, let us discuss the topic next generation translational nanomedicine as a biotherapeutic agent for the better health. So, in this basic introduction of my universities, one is, we have two campuses. One is GAUTHAM campus, and another one is RANA campus. This is RANA campus. First of all, Miyazaki is this is Bangalore. And it is just 6,200 kilometers from, there is a direct flight from Bangalore to Japan. And it is a scenic countryside, fisherman's village. It's a beautiful Pacific Rim, agriculture field, and we have cave temples and beautiful countrysides with the style agriculture systems and beautiful hillocks like Goa. This is my Google Scholar index, and if you want to have kind of a collaboration or a joint research, kindly go through my research activity so that you can understand my area of expertise. First, what is nanomaterials? Nanomaterial is microscopic particles, which is less than 100 nanometer in size. Great scientific interest as they effectively bridge the bulk and atomic molecules. Atomic molecules are normally in medicines because it is absorbed from the body as ionic molecules, as nanomedical as the bulk system. They have unrestricted properties, electron branching and other things with the super quantum effect. This is the law of drug delivery, absorption, distribution, metabolism, and excretion. Nanomaterial has the surface chemistry. The volume ratio is the most important one. With the surface atom to bulk atom is normally increased when it is formed with the nanoparticles, and have the super immediate surface effect than bulk properties. What happens when there is a surface changes in the nano? Because it has size-dependent reactions, deviation from the thermal properties, shifting of the mechanical properties like adhesion and capillary forces, and modification of the optical properties like the light scattering, light reflection, and variation in the electrical and thermal properties of the material. Because of that, it has the major effect, visible effect of the switching of the color changes. This is the principle of the functionalization of the nanomaterial. We have the core materials like this, and we can have the linkers and antigen productive and fluorescent signaling bodies, shape of materials, biodegradable drugs can be attached and the colonization effect. These are the common nano materials, titanium, zinc, iron, silicon, gold, and silver and carbon nanomaterials. The classification has the one-dimensionals where there is length is not in the nano, whereas x and y axis is in the nano direction. And the two-dimensional length and the thickness is in the width and thickness is in the nanomaterial size, nano size, and the length is not. This is the two-dimensional. Classic example is our cell phone covers and film covers with the TV, high protective agents and all of that. As the 3D dimensional, as the bulk materials that are not compared to the any dimension X, Y, and Z. Anywhere it is not connected to the particles, but internal storage structure is in nanoscale. And protocol for the thermostic agents for gold, carbon, transition metal sulfides and oxides like MOFs and other inorganic nanomaterial polymers and nanotypes, nano-infrared types are in use for the various applications in the biology and the medicines. With missiles, liposomes, protein complex, pyrophore, virot, curots, curies, and copper sulfate, cesium dioxide, MOFs, dioxides, and all other things. And for the tender heating, this is the one what we have done jointly with IIT Hyderabad, where the coaxial spinning, the decellurized extracellular matrix and 3D printing was done in IIT Hyderabad, and biological properties being conducted in our lab. And this is the adverse effect of particle in the cardiotoxicity with all these mechanisms. Because of the time constraint, I am not going to have the detail of all these pathways, but it has some properties to the cardiotoxicity, in particularly cardiac area. This is how when gold silver nanoparticles attack gram-positive and negative with the principle of the antimicrobial mechanisms. And since we all know microorganisms are the lipid layers and outer membrane, cytoplasmic membrane, falling back walls areas, which enters the cationic nanoparticles because of these anionic structures. Because of that, it enters into the particles and have the intracellular binding components, and finally it acts on the nucleotide. And this is one article long that we published with the silver systems, which has ionized with the polyhexanomates as a TB drug in order to combat the microorganisms. And this is how the mechanism which works. So this you can see all the detailed mechanisms are available in this manuscript. This is the principle. Silver methicillin is attacked with gram-positive bacteria with membrane destruction structures. Finally, Ag ions with the nanoparticles with the tyrosine have the differential release mechanisms, and Pt and Bn will be individually segregated, differentiated into the bacteria when it finally hits the bacteria. And this is another doing is being conjugated with INH, with surface coated with INH and protein, but gold nanoparticle and silver nanoparticles. Here we found that selective toxicity because the lung cancer as compared to the normal fat cell. The details of the mechanism is available in this manuscript. Finally, whatever the remaining particles which are there inside the body after the actions, interactions and selective applications, how we can on the tissues in the body mechanisms, lysosomal stress and cytoskeletal impairment will be taking place, and autofibrosome accumulation will be there, and decreased autophagic clearance, and finally it has the imbalance if it is stored in the cell of the tissue. And the nanoparticles will be going inside the cells or entering into the cells with the two principal mechanisms of the biological or biochemical mechanisms of endocytosis and exocytosis. This is the mechanism how it goes and has the release of the lysosomal enzyme mediated mechanism to have the access and stimulated action of the disease or the microorganism to have the regeneration of the cell, or excess will be released out to the cells. And this is the imaging agent, this is a fluid chemistry which has the drug delivery imaging agent, photothermal and radiotherapy and targeted molecules with the AU is physico-chemical interactions during the thermostat principle. This is the AU and silver nanoparticle, gold nanoparticle, how it is helped in the different areas of the biology as a cargo material, macro-hybrid systems, or bimetallic conjugates, and body, AU body carrier materials, or simply AU lipid conjugations. And this principle is published in one of our paper, the bimetallic AU bimetallic particles, with the help of the quercetin as antioxidant scavenging molecules in order to reduce the ROS in the body. This is available in this paper. Detailed mechanism is available in this paper. And this is the typical mood healing mechanisms. As you all know, mood will not heal during the diabetic conditions, which has the 3D phenomena on the human being. And mood healing, of course, since it is a medical point, I need not to explain and what is mood and what is the healing. This is the schematic of the mood healing. And one of the important problems in the diabetes mood healing is the bacterial biofilms, which is the component which is the carrier to oxygen and to enter into the tissue embedded, which bacteria to kill the bacteria which is embedded deep into the tissue. For that, we use the silver or AU and gold nanoparticles to understand how it is regulating the bacterial suicidal agent, as a bacterial suicidal agent, as well as to reduce the ROS in the fibroblastic cells. This is the result. Simple DPPS scavenging assay, which is conformal microscopy done, and this is the control. AU positive nanoparticle, AMO, and NAN. In all this case, ROS concentration in the cell has reduced after treating with the silver conjugated positive nanoparticle. And the other one is phycocyanin. It is isolated from the algae indica as a dark colored pigment from cell protein, and the 47 kilodalton protein has proven properties of anti-inflammatory and anti-cancer properties. The first time we derived the property other than the traditional regenerative traditional properties like anti-cancer, antioxidant, and other things. We use this one for the wound healing. This is the structure of the phycocyanin with the tetrapyrrole linearly arranged molecules, which has bridged with the cysteine and sulfahydryl group in the globin portion. This is the globin portion in the protein. So it is a hemoglobin-like structures, it is called phycocyanin. And this is the principle of DCH-DPA method from as I shown earlier, how we reduce the ROS of the cells. This is the control one, for example. In the control one, there is no ROS at all, and silver nanoparticle anode treatment one, as the higher is the ROS of the cells. If the cell is contaminated or inflamed, certainly we will have the effect, generation of the ROS inside the cell will have the beneficial effect to kill that cell. And finally, CPC conjugated silver nanoparticle is as good as the norm. This is the metal conjugation reaction. Simply we use the silver tetroxides with the reducing agent, which forms into silver and nitrate. With electron conjugation systems, we will have the silver nanoparticles alone. Silver nanoparticle alone. And this is the electron conjugation reactions where how phycocyanin is conjugated with the electron conjugation system with the core magnetic principles, so that we have AGO and bigger and polypeptide inside. And this is how the AG CPC is is visible under the electron microscope. This work we published in the scientific reports long back, and this is the simple simulations of how the cells are migrating during the AGCTC treatment. The in vitro cell migration assay, the upper panel is control 0 West and the West 24 West. That is an velocity of conjugated particle, similar nanoparticle increase the cell migrations. In the 24 hours, it is almost movie speed. This is the video of cell migrations. We have two group, one is control and one is ABCTC treated group. Here, migration cell is rapid in comparison to the control. See, this is the migration move. It is in the live image. So, ABCTC is found to be effective in treating the wound healing with the evidence of the inbuilt cellular microplasmation. This we published in RSA Advance. This is all my publications and global GCI, global statistical events and flagship publications. And this is the two cover pages which we, our work being published, our work being visibility has been increased in the cover page of these two publications. That is for action surfaces here and the one is ACS with applied biomaterials. These are all my collaborators because our university, the central theme of our university, look at the world and start with the community. In summer, this is the simple S-pack plus B-space produces flat, and it is our in Asian data, it is about the eye muscle wash, it is mentioned. Being that the perception and the root are shown in the money, it's a in simple form, it is the Pythagoras plus this is the theorem. But I now A plus B whole square is equal to A square plus B square plus 2AB. And because we want to connect our Bharat with the rest of the world, then we say each finally, thank you.
If there are no questions, we will proceed to the next step. Dr. RANA, any questions?
Thank you for being a very patient audience. Thank you very much.
Thank you, sir. I request Dr. A. Shamaraya to kindly take a moment to give the memento to our chairpersons of the session. gathering of visionaries and inventors where ideas ignite, knowledge transforms into action, collaboration spark breakthroughs, and together we shape a future defined by excellence, discovery, and meaningful impact on lives worldwide. A very bright and beautiful morning to one and all present here. I am Dr. Swati, and alongside me, it's Mrs. Nisha, and it's our immense pleasure to be your host for the inaugural ceremony of Simsic 2K25. Convergence in biomedical science, innovation from molecule to medicine. I request Dr. and Dr. Sucheta Kumari ma'am to invite the guest and chief guest to the dais. Thank you all.
Prayer is how we join our hands in unity towards the invisible and find the Almighty's hands reaching back. I request Miss Megha to lead us in the prayer song. I request everyone to kindly raise.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरी तननाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुरगुरवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डकण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरी तननाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
Thank you, Miss Megha, for the soulful prayer. A guest, like a flower in the garden of our home, they brighten our day with their presence. To do the honors, I invite Dr. Uday Kumar Rao, Dean, Srinivas Institute of Medical Sciences and Research Center, to deliver the welcome address.
contributions of our founder, Sri K. Shamarao and Srimati Indiramma. It is a great, immense pleasure to welcome all of you for this international conference, that is Convergence in Medical Science Innovation from Molecule to Medicine. This global scientific gathering brings together leading researchers, academicians, clinicians, and innovators to discuss breakthrough that bridge fundamental nuclear science with advanced medical applications. I consider it is my privilege to welcome our Honourable Chancellor, Dr. C.A. RAGHAVENDRA sir. He is the President for A. Shamarao Foundation also, Srinivas Group of Colleges. His aim is to transform society through education by setting up academic institutions in active symmetry with social, ecological and economic environment. Under his dynamic leadership, the Srinivas Group has grown into a premier hub of academic institutions. This is effecting quality education and also best education and also good discipline and making our students very good in this. About our Chancellor sir, there are 4 campuses. What we say, main is Srinivas Nagar, Mukhya. In that, Srinivas Institute of Medical Sciences, Dental College and Engineering College. Other campus, this is the Pandeshwar campus, and also one more in our Bangalore also one campus. Like that, 4 campuses are there. And recently, Srinivas University is the golden crown for these 18 educational institutions with many precious stones. And our sir awarded with many awards. And recently, for our sir, Government of India has given Bharat Nirmana Prashasti. It's a great award for our sir. In this brief introduction, sir, I welcome you for this international conference on behalf of all. It is indeed a great humor to extend a warm and respectful welcome to Dr. A. Srinivas Rao, Pro-Chancellor of Srinivas University and Vice President of Shamarao Foundation. Sir, your visionary leadership and also dedication, advancing education, research, all those things made this our institution a great thing. Sir, on behalf of all, I welcome you for this international conference. Madam Vijayalakshmi, Madam is also with us. She is Board of Governors for Srinivas University. With wholeheartedly, on behalf of all, I welcome you, Madam, for this gathering. And our main, chief guest for today's function, Professor RANA Prathap Singh, Honourable Vice Chancellor, Gautham Buddha University, whose visionary leadership and contribution in higher education and research continue to inspire scholars across the world. We are deeply privileged to have you with us. Sir, with wholeheartedly, I welcome you for this gathering. I am equally delighted to welcome our distinguished guest of honor, Dr. PAPINENI, founder of and president of BBC 2 and eminent scientist. I welcome you on behalf of all for this international conference. Dr. Muralidhar also with us. I welcome on behalf of all of this international conference, sir. Madam Srimati Mitra S. Rao, she has conveyed her best wishes for this international conference. Thank you, madam. I welcome Dr. Anil Kumar sir, Registrar, Srinivas University for this international conference. Dr. Ajay Kumar, Registrar for Srinivas University. Sir, I welcome you for this conference. Registrar Evaluation, Dr. Srinivas Maya, he has conveyed best wishes to this international conference. Thank you, sir. I welcome our medical superintendent, Dr. David Rosaria, for this international conference. I extend my sincere welcome to our esteemed organizing chairperson, Dr. Sujeta Kumari, Director and Research and Development. And also, I welcome Dr. Vrindavat and also Edwin for this international conference. They are Research Director. I extend my distinguished and precious welcome to all esteemed speakers joining us for this international conference. Your expertise, scholarship and global perspectives enrich this forum and elevate the academic depth of the event. I extend a gracious welcome all our esteemed chairpersons whose presence and guidance add immense value to this session. I extend warm welcome to all the deans of Srinivas University and also teaching and non-teaching staff of this international conference. So this conference from various countries, scientists, resource people join with us. 2 days conference. They will enrich our knowledge. What we say is simple. By the process of diffusion, osmosis, absorption, knowledge will spread to our what we say delegates. Thank you, one and all.
Thank you, sir, for the welcome. We welcome you too for the inaugural ceremony. We request Dr. Uday Kumar Rao, Dean, Srinivas Institute of Medical Science and Research Center, to formally welcome our Honourable Chancellor, Dr. C.A. RAGHAVENDRA. Dr. Anil Kumar, Registrar, Srinivas University, to formally welcome Professor RANA PRATHAP Singh, Honourable Vice Chancellor, GAUTHAM University. Thank you, sir. We request Dr. Ajay Kumar, Registrar of Development Cell, Srinivas University, to formally welcome Dr. PAPINENI, sir. We request Dr. David Rosario, Medical Superintendent, Srinivas Hospital, to formally welcome Dr. Madhukar Thakur. Thank you, sir. We request Dr. Praveen PM, Research Director, to formally welcome Dr. A. Srinivas Rao, Pro-Chancellor of Srinivas University. We request Dr. Sucheta Kumari, Organizing Chairperson of the conference, to formally welcome Srimati A. Vijayalakshmi Rao, Trustee, Board of Governors, Srinivas University. Thank you, Madam. We request Dr. Vrinda Jeevar, Organizing Secretary, to formally welcome Professor Srimati A. Mitra Isra, Trustee, Member, Board of Governors, in their absence. We acknowledge the virtual presence of Dr. Shahid Umar, University of Kansas Medical Center, USC. We request Dr. Praveen PM, Research Director, to formally welcome Dr. Nagaraj Puligo. Sorry, sir. We also welcome you in the absence, sir. We request Dr. Naveen Papadale to formally welcome Dr. Dwarkanath and Professor Dhanakshi, Dean of GAUTHAM University. Dr. Praveen PM to welcome all the speakers of the conference. So I also welcome the media committee and all the people who have been thoroughly working for this smoothly functioning of the program, and thank you all.
Lighting a lamp symbolizes dispelling of darkness and victory of knowledge over ignorance. I request all the dignitaries on the dais to please step forward to light the lamp. It's now time for the most significant event of the gathering, the formal inauguration of our conference. We are deeply honored to invite Dr. C.A. RAGHAVENDRA sir, Chancellor of Srinivas University and President of HONOURABLE Foundation, to kindly inaugurate this conference and mark the beginning of this academic endeavor. Sir.
Thank you, sir. We have among us Dr. Kumari, the organizing chairperson of the event, who will give a bird's eye view of this international conference, Simsic 2K25. I welcome you, ma'am.
A very good morning to all of you. The Honourable Chancellor, Pro-Chancellor, our President, and our most important is our guest today, Dr. RANA sir, VC BUDDA University, and our PPQ President, Dr. PAPINENI sir, and the most senior most scientist, Dr. MANGALORE sir, and the Registrar, the Dean, the MS, the Buddha Madam, and all the dignitaries of the desk. There are many scientists are around here to share their knowledge. So this particular conference was taught in a span of 30 days. So the reality is Dr. PAPINENI sir had a nuclear medicine conference at Madras. So many 300 scientists are moved to Madras so that I
Registrar Srinivas University. I request now to welcome Dr. Ajay Kumar, Registrar Development, Srinivas University. Thank you, ma'am. We have with us a distinguished visionary and globally respected scientist, Dr. Rao V.L. Papinenni, founder president of BBC Cure USA and an eminent researcher from the University of Kansas Medical Center, USA. I request our organizing secretary, Dr. Vrinda to kindly introduce Dr. Papinenni to the gathering.
Good morning, everybody. Respected dignitaries on the dais and off the dais. It's my proud privilege to stand here to introduce an eminent personality, Dr. Rao V.L. Papinenni, an accomplished biochemist and translational medicine scientist with over 20 years of industry and academic experience. He is the adjunct associate professor in the Department of Surgery at the Kansas University Medical Center and is the president of PAC and LLC. Contribution to innovation and scientific strategy, global health advisory efforts. He directs major programs in molecular medicine, cancer diagnostics. Dr. Papinenni plays a key role in establishing global molecular and functional imaging scientific and business alliances, highlighting his commitment to international collaboration and scientific enterprise. He has guided in diagnostics including molecular image-guided radiation therapy (MIGRT) and advanced clinical optical imaging platform. He has expertise which spans biotechnology, protein biochemistry, non-invasive molecular imaging, radiation nanotherapeutic, and drug discovery solutions. This places him at the forefront of translational research aimed at improving clinical outcomes. Dr. Papinenni also serves on editorial boards of journals in imaging, radiation biology, nanotechnology, and experimental pharmacology, underscoring his influence with scientific community. His career reflects a strong dedication to innovation, translational impact, and global health improvement. Ladies and gentlemen, it is my proud privilege to welcome Dr. Papinenni to deliver his address. Dr. Rao V.L. Papinenni.
Namaskara. Mangalore almost is like my hometown, keep coming regularly. Let me first thank the Chancellor, Dr. Rao, Dr. Vijayalakshmi, Srimati Vijayalakshmi Rao, Honourable Vice Chancellor, Dr. RANA PRATHAP Singh, and other dignitaries here, and visitors, audience, and distinguished guests. Let me first, for me, that's a long introduction for me. Thank you very much. It's been a 25 years old journey from my academic career in molecular biophysics all the way to translational molecular imaging and nanotherapeutics, then moved a little bit into radiation oncology, where we developed a preclinical radiation technologies, including instrumentation that is almost in nearly 5,000 laboratories around the world, and which is churning out more data towards understanding the cancer, etc. Let me briefly talk about BBC Cure. BBC Cure is bridging brains for cancer cure. That is to raise a new generation cancer warriors. Basically, it's a Gurukul fashion of doing this. I've been coming to India regularly from 2005. Loosely, I used to develop programs, including workshops and meetings. And what I did was, in the last 5 years, made it more systematically and brought this BBC Pure format. Nothing can happen without the help of close friends and colleagues. And here in the humble beginning started with Dr. Dwarkanath, who is the India in charge. And from there we moved on, it went to IIT Madras last year, and then we even went into a really spiritual place like Chinnajiyar's golden statue in Hyderabad, where we had a one-day cancer conference. And now here we are at Srinivas University, thanks to Dr. Suchita Kumari, and large Balaji is almost like a part of our family. Anyway, what I mean to say is this BBC Cure basically is not just give a talk and walk away. We actually bring a more closed interaction with clinicians, physicians, then practicing scientists, or even in entrepreneur scientists, as well as technologists, etc. Let me tell you one thing. When I grew up, I used to just go out taking care of visitors to Hong Kong, where I did my PhD, and even in Baylor College of Medicine. One such instance was Al Gilman, Nobel laureate of G protein. He was, once I saw him, I said, "You are my great-grandfather." He didn't understand because his postdoc, Jonathan Byrne, was my mentor's mentor. So that way we had some interaction, and we get a lot of insights, like the way Nalanda University existed centuries ago, and not many people will like these kind of attributes, bringing in spiritualism and other faith, but there it is. We have people as big as Einstein, Oppenheimer, who moved into spiritualism, etc. So where are we? Anyway, this is where the BBC Cure starts, and it's a good forum. And Shahid Umar, who didn't show up, he's US in charge, and he's one of the conveners. And hopefully we will, all our visitors, and all our guests who join together in this joint meeting together with Srinivas University. Thank you very much wholeheartedly. Thank you.
It's our honor and privilege to have among us Professor Rana Pratap Singh, the Honorable Vice Chancellor of Gautham Buddha University, as our esteemed Chief Guest. May I now request Dr. Vrindha Chebhar to introduce our Chief Guest.
Professor Rana Pratap Singh, Ph.D. is the Vice Chancellor of Gautham Buddha University and Professor of Cancer Biology at JNU, New Delhi. He obtained his MSc and PhD in Life Sciences from Jawaharlal Nehru University, where his doctoral work focused on ethnomedicine and plant-based pharmacological studies. With over 3 decades of research experience and 25 years of teaching, he held key academic positions at Jawaharlal Nehru University, Central University of Gujarat, University of Colorado, University of California, Riverside, and Johns Hopkins University. Professor Singh's research encompasses cancer chemoprevention, tumor angiogenesis, cancer stem cells, therapeutic resistance, radiation biology, cell signaling, mitochondrial biology, and microgravity-induced cellular responses. His scientific contributions include mechanistic insights into flavonoids, coumarins, and other phytochemicals, development of radiosensitizers, identification of prognostic biomarkers, and patented methodologies for studying tumor heterogeneity. He has authored 193 peer-reviewed publications, including 90 in journals with impact factor above 5, accumulating over 16,000 citations and H index of 77 and 3 patents. His high-impact publications appear in journals such as Carcinogenesis, clinical cancer research, oncogene and signal transduction and targeted therapy. His achievements have been recognized through prestigious awards including ICMR International Fellowships, Indo-US Science and Technology Forum Award, the US DoD Postdoctoral Training Award, and the AACR Scholar in Training Award. Professor Singh has engaged in extensive international collaborations across the USA, South Korea, South Africa, and Austria, has participated in and organized numerous global conferences. He served in major administrative, editorial, mentoring, and research leaderships, guiding over 50 researchers and significantly advancing translational cancer research. I think he needs a loud round of applause because we have a significant, eminent personality among us. Ladies and gentlemen, Professor RANA Singh, over to you, sir.
Honourable Chancellor, Honourable Pro-Chancellor, Honourable Mrs. Chancellor, Dr. PAPINENI, all the distinguished scientists and administrators on the dais, off the dais, dear students. It is an esteemed honor and privilege for me to be invited by Srinivas University at this international conference. I am very much thankful for this invitation and honor. I see here most of the students are sitting backside, but I request to them that try to be an active listener rather than being a passive listener. And if you have an interest in science or research, the key is observation. You have to be keen for the observation, whatever you do in your lab or wherever you are working. Just try to put your thoughts around your observation and see how you understand that situation wherever you are. This is a brief message from my side, and whatever presentations we just saw in the morning related to whether it is anesthesia or the personalized diet or how the cancer therapies were developed from the beginning, what was its history, and the recent one was on nanoparticle. So how the field is advancing, it is very fast. Unless you keep up to the pace, you will be left behind. So just try to choose your subject in the area of interest and see how best you can maneuver in that field, and you can be a recognized researcher and you have a fulfilling career in contributing to whatever aspect you are choosing for your career. So with this brief remark, once again I am very much thankful for this honor and being here at this stage before you, and I will be also sharing my work which we do in the laboratory after this session. Thank you very much.
Thank you, sir. We will make sure the students will heed your words. Dear friends, we have amongst us a renowned scientist from Thomas Jefferson University, USA, whose groundbreaking contribution to research and scientific advancements are recognized across the globe. It is Dr. Madhukar Thakur. I request Dr. Vrinda Jayabhat to introduce our esteemed guest of honor.
Dr. Madhukar L. Thakur, a professor of radiology and radiation oncology at Thomas Jefferson University with an additional appointment in urology, is a distinguished personality amidst us today. I have been observing sir since morning, a very humble and a reserved personality, and a very a quiet personality. He serves as the Director of Laboratories of Radiopharmaceutical Research and Molecular Imaging, contributing more than 4 decades to advancements in diagnostic and therapeutic radiopharmaceuticals. He has MS and PhD degrees in radiochemistry from University of London and made major scientific contributions by developing innovative radiopharmaceuticals for imaging and therapy. He has published over 500 works, including journal articles, reviews, book chapters, abstracts, and several books. His professional journey includes positions at Baba Atomic Research Center, the Medical Research Council UK, Washington University School of Medicine, major leadership roles at Thomas Jefferson University since 1982. He has also served several global organizations. Dr. Thakur has received prestigious awards, including the ACS Morris Chamberlain Award, SMN Paul Ebersold Award, Lifetime Achievement Award in Nuclear Medicine, and multiple national and international recognitions. His ongoing research includes molecular imaging assays for prostate cancer, novel PET radioprobes, and non-invasive diagnostics for urothelial cancers. As principal investigator on several NIH-funded studies, he continues to advance precision imaging and targeted molecular diagnostics. Dr. Madhukar L. Thakur, over to you, sir. Let us have a round of applause to sir.
Thank you for that great introduction. You know, in life, one gets opportunity, another doesn't. And it so happened that I did get some opportunity. I was born near Mumbai. My parents named me Madhukar and called me Madhu. When I went abroad and have been studying imaging and working there for several decades now, and had the opportunity to travel all over the world where it makes lots of friends like you. And those who could not pronounce my name Madhu, they call me Matthew. If you could have my first slide, please. So they call me Matthew, and you will see that whatever you please, you can call me Matthew, Madhukar, Madhu. It is okay with me. Although I have been there for so long, after all, I'm one of you. It gives me a great pleasure to be here and be actively participate in this great organization and visiting this great university, meeting the Chancellor, Mrs. Chancellor, and all the people on the podium. Can you get my slide? Do you need my help? Okay. All right. So, I want to thank the organizing committee for giving me the opportunity to be here and be the part of this great symposium. Sorry about this. So I think that my presentation will be later. I'm kind of used to different formalities, and our formalities are great. So I just want to welcome you all to listen to us, and I'm really proud of you, Dr. Suchita Kumari and the whole team, to organize this meeting, and they really deserve a lot of applause. And please join me once again to congratulate them. And I'm sure this meeting will be highly successful. Thank you.
and to serve. A dynamic leader whose vision, dedication and commitment to academic excellence continue to inspire the entire institution is none other than our very own affectionate Pro-Chancellor of Srinivas University, Dr. A. Srinivas Rao sir. So, we request you to kindly address the gathering and share your thoughts.
Honourable Chancellor, Dr. C.A. Board of Trustees member, our stalwarts in the innovation sectors, the senior Dr. RANA PRATHAP Singh, Dr. PAPINENI, and Dr. Prof. Other dignitaries guys, distinguished participants, members from the media, invitees, and the delegates of this international conference. Well, first of all, let me tell you, I am happy that this is the first international conference on biomedical in Srinivas University. And that we have scholars from all over the world. We are really elated with this kind of program, and I congratulate the organizers for organizing such a beautiful conference with a lot of knowledge pouring in here and shared with the youngsters. Well, coming down to the conference as such, biomedical or biochemistry, whatever we call, the most important research for a human being. The reason is, if at all anything happens, the way a person who is having a blood requires biochemistry. I can tell that way. Because anything happens, the flow of blood, it will affect the human anatomy if it is not going to be properly utilized or properly circulated. So for anything, for any defect in the blood, you require biochemistry. You require biochemistry for human anatomy also. For curing purpose, you require. For detection purpose, as radiology has to radiotherapy, we require it. So the importance of biochemistry is worldwide for a human being or any living being requires a biochemistry. Coming out to the advancement of biochemistry, we have sessions here, we have more sessions to come. We know about the earlier what used to happen. Chemistry as such, you know, is a basic theory is fine, but you advance for that, you get a lot of information from that. You get refined that. We were talking of molecule, we were talking of atom, we are talking of lab. So with the research on the nanoparticle, nanotherapeutic biotherapeutics, I feel the life expectancy of any human being can go up to anything. It was once analyzed and predicted that the use of nanotechnology with the biochemistry will make a human being live for longer, live for 1,000 years also. It is possible. See, it's an imagination. It may be an imagination, it may be a dream. A day will come definitely with the sharing of knowledge like this and research growing. I am sure that whatever the dream which was predicted in the nanotechnology will be a realized one. And human being can also live for 1,000 years. It is possible and it will be a challenge, and it is a challenge for the biochemistry professionals. And I am sure the day will come, we will realize it. And from our university, I can tell that the holistic approach, we are in support of the biochemistry research, and we will definitely develop it on a holistic way. And we request all of you to support us so that the human being or the society in general will be benefited out of it. I thank you very much for giving the opportunity.
Your words always inspire us. Dear delegates, we have arrived to a special moment of this inaugural ceremony. The unveiling of our conference is Souvenir, a compilation that reflects the scientific spirit, academic contributions and collaborative efforts behind this event. I request our Pro-Chancellor of Srinivas University, Dr. A. Srinivas Rao sir, to do the honors.
Thank you, sir. Thank you, all the dignitaries. Ladies and gentlemen, the exhibition is arranged as a part of conference. Please take a look around during your free time. The patriarch of Srinivas family, who needs no introduction, loved and well respected by all, and a live example of humility par excellence, a Honourable Chancellor Srinivas University, President of President of Srinivas Group of Institutions, Dr. C.A. RAGHAVENDRA Rao sir. May I now request you to deliver the presidential address and bless the conference.
Good morning to all of you. And today is a red letter day in the history of the Srinivas University and Srinivas Group of Institutions. When we are hosting the first international conference on human hygiene, human research, or molecular research on different aspects of the human life. And wherein world leaders are contributing their knowledge to our students. I tell you, sir, I am very happy all of you have made up your mind to come here and give your knowledge, share your knowledge with your youngsters and research scientists, research scholars. This idea was there since many times, but we could not realize until we got a very burning, I think, fire on the other side. That is Dr. Sucheta, who came here to ignite this knowledge on research aspect of the human life. I personally thank Dr. Rao and Prathap who have given their tidbits in the beginning now, and I can make out what of knowledge you can get from these scholars when they really start sharing their knowledge with you. I am very happy. I congratulate the organizers. I congratulate and thank the world leaders on research to have come here and share their knowledge with our students. Thank you. Thank you once again. To develop our knowledge in the university and please bring more and more such people so that university becomes more a research university than just an academic university. Thank you very much.
for your blessings. We now come to a moment of honor and gratitude to acknowledge the outstanding contributions and global scientific achievements of Dr. PAPINENI, founder president of BBC Cure USA and eminent scientist from the University of Kansas Medical Center, USA. We invite Dr. C.A. RAGHAVENDRA Rao sir, Chancellor of Srinivas University, to present A. Shamarao Memorial Award for distinguished service in biomedical research, education and mentorship to Dr. PAPINENI for his exceptional service to science, innovation and humanity. I request Dr. Mithun S. Acharya, Associate Professor, Department of Psychiatry, SINGH and RC, Srinivas University, to read the citations.
Greetings everyone. It's my honor and privilege to read this citation of A. Shamarao Memorial Award in the field of biomedical research, education and mentorship 2025. A. Shamarao Foundation Mangalore has been actively involved in promoting educational institutions of excellence for the last 35 years. Dr. C.A. RAGHAVENDRA Rao sir, our respected Chancellor, Srinivas University and President of A. Shamarao Foundation, in memory of his beloved father, A. Shamarao, has instituted an award in 2009 to recognize the outstanding services of the people who have done excellent service to the development of the society and also to the persons who have achieved extraordinary skills in the field of fine biomedical research, arts, photography, astrology, folk art and social service. Dr. PAPINENI has been selected to receive the A. Shamarao Memorial Award in the field of biomedical research, education and mentorship. Dr. PAPINENI sir has made excellent contributions across multiple scientific domains including ion channel physiology, cancer biology, medical technology, plant signaling and drug discovery. Congratulations to Dr. PAPINENI sir and a big round of applause.
We acknowledge the gracious presence of Professor Dr. P. Satish Kumar Bhandari, Vice President ISR and CRL, Nitte University, and Dr. Jayaprakash Shetty, Dean, Nitte Institute of Allied Health Science, Nitte University. We request Dr. Branda to welcome them florally.
Gratitude makes a sense of our past, bring peace for the today and creates a vision for tomorrow. As we have come to an end of the inaugural ceremony, I request Medical Superintendent of Srinivas Hospital, Dr. David Rosario, to render the vote of thanks.
Dignitaries on the dais, dignitaries of the dais, all the delegates, my dear colleagues. Today indeed it's a moment of pride for all of us at Srinivas University as we host this international conference on biomedical research in collaboration with BBC Cure USA. First and foremost, I would like to thank our Honorable Chancellor, Dr. C.A. RAGHAVENDRA Rao sir, for taking his valuable time and gracing this occasion. Srinivas University is a young university. Why I say this? It's because our university was established in the year 2015, and then I think we are just stepping into the second decade. So we are more into the adolescent phase, and it's often said that the path that we choose during the adolescence will ultimately show us the direction in which we will go. So, with the vision of our Honorable Chancellor, the university has chosen the path of quality, excellence in education, and focus in research. So definitely with his blessings and his constant motivation, I'm sure this university will take great strides and be a research oriented and a well-known university in the days to come. I would like to thank our Honorable Pro-Chancellor, Dr. Srinivas Rao sir, for taking his valuable time and gracing his occasion. As I just mentioned, the vision of the university is to focus more towards the research and quality and excellence in education. And he has been ably guiding us in this endeavor, and with this support we are able to organize these events, and I'm sure with this constant motivation, in the days to come, we'll be organizing many more such events in the days to come. Thank you very much, sir. I would like to thank the guests of honor, especially the chief guest of today's event, Professor Rana Pratap Singh, the Honorable Vice Chancellor of GAUTHAM Buddha University, for gracing this occasion. Thank you very much, sir, for taking your valuable time, and I'm sure in this conference you'll be presenting your knowledge and guiding all our faculty as well as the students regarding the research in biomedical sciences. Thank you very much, sir. I would like to thank Dr. Rao V.L. Papinenni, the founder president of BBC Cure, University of Kansas Medical Center, USA, for taking a valuable time, sir, and gracing this occasion. It's with your collaboration with your institution that we are being able to organize this conference, and I'm sure with your support we'll be able to conduct many more conferences in the days to come, and also we'll be sharing your valuable insights to all the delegates as well as the faculty and the students. I would like to thank Dr. Madhukar Thakur from Thomas Jefferson University for gracing this occasion. I would like to thank our Honorable Trustee Board of Members, Dr. Vijayalakshmi Amma, for taking a valuable time and gracing this occasion. I would like to thank all the office bearers of Srinivas University, our registrars, Dr. Ajay, Dr. Anil Kumar, who have graced this occasion, and all other university officials who constantly support us and motivate us and guide us in all our endeavors. Thank you very much, sir. I would like to thank our Honorable Dean, Dr. Uday Kumar Rao, who has graced this occasion. At the same time, I will take this opportunity to thank all the keynote speakers. Professor Dhanalakshmi is here, Dr. Shai Umar, Dr. Dwarakanath, Dr. Nagaraj, Dr. Satish Chirineni, Dr. Shyam Prasad, Dr. Ph.D. and all other speakers who will be presenting during this conferences and sharing their valuable insights. Well, it's a very prestigious event for us today, that many of the keynote speakers from all the various universities from all over India, and in fact from many places from the different countries also have come. It's really a great opportunity for all our faculty and our students that they are blessed to hear from these well-known speakers, and I'm sure they are going to enlighten us with their valuable inputs. So thank you for all the keynote speakers and all the conveners who are going to chair these sessions. I would like to thank all the organizing committee. I mean, it's during a very short span of time they have been able to organize this international level conference in our university. The conveners, Dr. Uday Kumar Rao, Dr. Sangeeta, Dr. Shai Umar, Dr. Guru Prasad, Dr. Edwin Das, especially for the planning this conference and organizing this conference in such a wonderful way. And it's a really commendable job that you have done with over more than 500 delegates who have registered for this conference, arranging for all the speakers. And it's been, I know, I see you are working around the clock, making sure that everything goes on fine. So I would like to thank for all your wonderful contribution in organizing this event. I would like to thank all the members of the scientific committee, the various teams, as well as the heads of the departments who have contributed to organize this event. The registration of the hospitality committee and the finance committee, also the publicity and media committee, and the food and the revenue logistics and the sponsor committee, and also the cultural committee who have organized, helped us to organize this event. Well, if the meal has to move smoothly, every spoke has to be in perfect sync. And I'm sure there are a lot of other people who have contributed to make sure this conference goes on well. Backstage, they have been working continuously. So I thank all of you who have contributed for the success of this conference. Well, I sincerely hope that this academic fiesta will definitely help all our students and the faculty. It is said that the most powerful picture was taken in the year 1927 at the 5th Slovenian conference held at Belgium, where I think the 27 top physicists from the year in those days had gathered, and 19 of them went on to become the Nobel Prize laureates. So similarly, I sincerely hope at the end of this conference, when we take a picture of all the delegates as well as the workshop and all the present speakers as well as the conveners and everything, the picture in the days to come will be considered as the most powerful picture in the history of the world. So that should be the impact of this conference, and I sincerely wish this conference all the very best, and I sincerely hope all the faculty and the staff will benefit from this conference, and in the days to come we will be able to hold much more conferences like this. So thank you very much, and may the good God bless us all.
Thank you, sir. Dr. Divya Rani and her committee has organized an expo. We thank and congratulate all the companies participated here. I request everyone to rise for National Anthem.
is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is the 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, The college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Parneshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both under, postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom, and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. proud son of Atka Shamra, renowned chartered accountant and visionary academician, Dr. C.A. Raghavendra Rao, started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamarao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super specialty hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Parneshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both under, postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation, and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is the 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University. Located at the Srinivas University campus Mukka, the Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachal campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore.
And currently serves as Vice President of Institutional Social Responsibility and Central Research Laboratory. He has contributed to major professional bodies as Karnataka State President of the Indian Association of Otolaryngologists and President of the Dakshin Kannada chapter of the Indian Medical Association and established the Mangalore Laryngectomy Club. We also have with us Dr. Jayaprakash Shetty K. He completed his MBBS degree from Government Medical College, Mysore and MD Pathology from Kasturba Medical College, Manipal Academy of Higher Education, Fellow of Royal College of Physicians, Glasgow, United Kingdom with vast teaching experience in pathology and laboratory science. He has large number of publications, more than 100 to his credit, in both international and national journals, and also the principal investigator for research projects from ICMR, Government of India, and VGST, Vision Group Science and Technology. He has attended many conferences and chaired many CME sessions. He is postgraduate guide for MD Pathology and PhD postgraduates. He was the Registrar, Vice Dean and In Charge Dean of K.S. Hegde Medical Academy and is the member of Board of Management of Nitte University. Currently, he is working as Dean of Nitte Institute of Allied Health Sciences, a new constituent institution of Nitte deemed to be university. With this short introduction, I welcome you both.
May I request our esteemed chairpersons to introduce the speaker.
Good morning to each one of you gathered here for the first session of academic deliberations. It's my privilege to introduce the first speaker, Dr. Madhukar Thakur. Madhukar Thakur is a distinguished professor of radiology and radiation oncology at Thomas Jefferson University with an additional appointment in neurology. He serves as the director of the laboratory of radiopharmaceutical research and the knowledge layer, contributing more than 4 decades to advancement in diagnostic and therapeutic radiopharmaceuticals. His academic background includes BSc in chemistry from Bombay University and MS and PhD degrees in radiochemistry from University of London. Dr. Thakur has made various scientific contributions by developing innovative radiopharmaceuticals for imaging therapy. He has published over 500 works, including in journal articles, reviews, book chapters, abstracts, and several books. His translation research spans molecular imaging, targeted radionuclide cancer diagnostics, earning numerous patents. His professional journey includes position at Baba Atomic Research Center, the Medical Research Council UK, Washington University School of Medicine, and various leadership roles at Thomas Jefferson University since 1982. He has also served global organizations such as IAEA, the United Nations, the Canadian Institutes of Health Research, the Society of Nuclear Medicine. Dr. Thakur has received prestigious awards, including the ACS Maurice Cavalland Award, SNM Paul Ebersold Award, Lifetime Achievement Award in Nuclear Medicine, and multiple national and international recognitions. So ongoing research includes molecular imaging, SCS for prostate cancer, novel Ph.D. radiopros, and non-invasive diagnostics for urothelial cancers. As previously stated on several NIH-funded studies, he continues to advance precision imaging and targeted molecular diagnostics. I present Dr. Madhukar Thakur, a distinguished professor, for the first lecture. Welcome, Dr. Madhukar Thakur.
Cancer-related death is 30.5 so many opinions, and because these opinions the approach to manage that attached to legal negative opinions. But one thing everybody agrees that early and accurate diagnosis is very aware of challenge the patient may have. So our goal, my laboratory's goal, has to follow the notion and see if you can do early and accurate diagnosis and treat the patient. If you take focusing on the prostate cancer is diagnosed by two things. One is the PSA, prostate specific antigen, which is you draw the blood and take the serum and send it. It's very sensitive test, approved by FDA in 1994. Unfortunately, it is very non-specific. There are 4 distinctly different reasons due to which PSA can work. So you do the draw the blood, send it for PSA is up, but the physician, the urologist doesn't know if it's related to cancer or BPH, or prostatitis or something else. The only way to do them is biopsy. In this biopsy, I have done not done, but seen on several patients, which tortures in many, many different ways. It's also high risk of infection, 4%. There is a risk of bleeding, and ultimately we find only 60 to 65% of the biopsies are unnecessary. You find benign pathology. In the United States, we have greater than 1.2 million biopsies unnecessary. Cost of each biopsy procedure in the United States costs about $500,000. If it is complication, it will cost more. So a lot of waste there are, of course, neurological techniques like ultrasound, transrectal ultrasound, CT, MRI, PET spec, but they have serious issues. So we need to do something about it different. Well, the increased knowledge on the cellular and molecular level of prostate cancer has given us a lot of evidence. It has showed us, led to the identification of large number of biomolecules in the central, in the nucleus of the cell, this is just the diagram of the cell, in the cytoplasm, as well as on the surface of the body. So once this cell becomes cancerous, these molecules change and they appear on the surface. So one of the molecules that I brought my attention many years ago is called VPAC receptors. VPAC. These receptors, when the cell just goes into the cancer stage, they erupt on the cell surface instantaneously, meaning that we can do the cancer diagnosis very early before the pathologist can detect the cancer. Because for pathology, for molecular changes, structural changes, it takes 5 to 6 months before the structural changes are. If you target the receptors, you can do it instantly. Using the radioactive tracer, my laboratory has determined that VPAC receptors could be as many as 10 to the power of 4, 10,000 to 10 to the power of 5, 100,000 per cell, depending on the gravity of the cell, the disease. It's more serious the disease, as we know, in prostate cancer is determined as Gleason score 6, 7, 8, 9, 10. So if you have a patient who has a Gleason score 6, you have about 10,000 receptors. If you have Gleason score 10, you have 15,000 receptors. Now what is VPAC? VPAC is a G protein receptor which has 457 amino acids. And these acids are related, these amino acids are related to the G protein copper receptor family, and they bind to two neurological neuropeptides. One is BIP, vasoactive intestinal peptide, that is becomes from. And then PACAP, pituitary adenine cyclase activity. Because it binds to the receptors, the name in the society that there is called it VPAC receptors. By a variety each cell, cancer cell, is made about 4 receptors. So you can see trillion cells to target either by diagnosis or problem. You just challenge what has been going on of the body. So I took that challenge many years ago and designed these 4 peptides. These 4 peptides, each has 27 amino acids. And I did a lot of study with NIH support. And I found they are all equally useful, have a very high affinity to prevent disease. In other words, if I take that peptide and inject it to the patient, it will go and bind to the cancer cell. Non-cancer cell, they don't have any receptors. They only fight the cancer. So it doesn't matter. The other thing that to my advantage happen that the VPAC receptors are expressed on a variety of different cancers. Breast cancer, prostate cancer, glioblastoma, lung cancer. So if I have one target, I can do all cancer. The in silico studies done for me by a Canadian friend of mine, the red part is one of this peptide, and this is the blue is in VPAC, and he told me that if I take crazy blue, this factor parameter of 9.6. So these are very high. So what I needed to do now is that we have a cell, we have these receptors, I have the peptide, but I need something more. So I had what is called integration activity, and it shows the report of the 90 positive on the giving the device for PET scan or autologous report. Eventually, this is the easy to do it. This is the years, not months. So we got all the requirements that we need for EID, exploratory EID, from FDA, study and all that. And they gave me approval to study 25 patients with prostate cancer, 25 patients with breast cancer, and 25 patients with bladder cancer. And I did them all. I don't have time to go into this to give you the highlights of it. But next focus on the prostate cancer only. So this is the one view. This is the one view. That arrow will tell you at this point already it doesn't involve it. That arrow will show you the. Okay. So this is the bladder. This is the pelvic. This is the prostate, and you can see prostate is a never gap and cancers. It's granular disease with the same patient. It was a 59-year-old male with a PSA of 7.5, resistance score of 7, and we had only 4 millimeters of oxygen. And this managed to take 15 minutes out of the patient. Very critical currently, once you have prostate cancer, the propensity of prostate cancer is far beyond capacity region 8 to 9%. So we do separate bone scan. In this case, you can see this is the same patient, and all the abnormalities that are left from the bone scan were shown in this PET scan of the same patient in different ways. And you can see I don't have time to go to region by region, but we can do it. So we inject with primary cancer or investigators and it works well. We confirm that the bone scan that we saw, biopsy and histology, we also have a lymph nodes, the only lymph nodes that will be visualized and imaged with those who have histological positive. If they are normal histological, then there is no regret, which is another area. So now we create a lot of excitement in the center, and then we all this and I get involved, and same molecule used for PhD, but instead of having copies, I use it as fluorophore. So the fluorophore, you avoid binding and then and when you do that, so the assay is very simple. You take the urine, get your cells on the slide, shown here, and then add an agent, call it TTP3, and if there are cancerous cells, the fluorophore will bind and show that orange fluorophores. If you don't have, this is not a cancer, the cell will look just like this. If you have a cancerous cell, they will have an orange so that one for us, so this is the 4 different information. This is just one molecule. This is what the optical microscope is using in the four segments. So you just simulate the cells are, and you switch the wavelength and process. Then you shoot the 2 images, it gives you the center view and fluorescent molecular and this is the morphology. So these are just 4 different information and they all are positive. And if you have a 9% type of patient, BDH, there are no molecular cells, so you don't see any molecular cells at all. And it has been consistent with all molecular cells. So we research and very easily used to work. So we will sell the patient to the civil quality class, civil anatomy. We take the urine first, and all 3 patients have out of line. That's the pathology. Then we make this is PPP3, the peptide and mine, particularly 3805, this is this is about the peptide because of the range of and the big I don't remember exactly what this is. They're all equally matched. I have to convince my role that I'm really targeting effects. So I developed another essay and shown that they move past targeted effects. Then the question is, how will you know cells? So I did a gene analysis and I have 3 normal patients. And you can see that the whole last 4 prostate cancer patients, some genes that are really very some genes that are down. The question today was, how do I know that these cells that are prostate? So we did an experiment showing that the cells that I see were prostate. Now this is a part of the analysis that I have done that you can see when you I analyzed them according to the BCL, which is for one is this is for 6 and 7 out of 10, and there is a number of patients in the second row, 2 positive, 92%, this is for 6 or 6, so the average sensitivity of this is about greater than 5%, this is close to 97%. Now, can I tell the issue that the situation is and then I think because if you take the same group, that tells me only what percent of cells are money. Because we share a lot of small cells, so we can get a percentage. And this is just the rows, and this is the R value is 9.6. So you can put the cells number out in this last report, 50% I can say is like even this is match you the best of the you and talk about this. So we have a collaborative program between Prof and PhD, and they sent me their leaders for that collaboration. I went there with the dean and then the chief of staff of the president and myself. We have learned the technique and they are going to still do it. They are right, and they have published 4 or 5. So it's reproducible, but it's so simple, so inexpensive, so affordable, and it just looks like a human. But because of those biomolecules are so many, I have a lot of competition. A lot of people are practicing, and most of these are companies. But if you look at the second column on the left, most of them either use serum or tissue or digital rectal examination and stimulate the prostate first, or which the patient gives to the central city and you get the DRD and the visit, etc., and then they collect the urine and they do genomic analysis. When I look at this long list, there are only 2 other companies that use urine, and I have highlighted them. But they, because they get several genomic molecules, they take 2 to 3 weeks for the results to come in and charge $795 per test. Patient and physician have to wait. I can tell them in half an hour, 45 minutes. And I estimate the cost to be $50 instead of $750 or $1,000. I have a collaboration with someone in Mexico country, and they are going to sell it in for $18. For $18. So I think that is very affordable. You can do multiple tests without costing money. And then we can do, I have done about 4 patients for breast cancer, just the nipple discharge. I have done, I think, 12, taking just the saliva for head and neck cancer. Cerebrospinal, I have done only 2 because this is all other issues, not related to science or political issues. Lung cancer from lung lavage, ovarian cancer for YDBV, I just got a new grant for doing ovarian cancer. And this is just one example of ovarian cancer, normal cell and the cancerous cells, and you can see here that these happening. So what else can it do? It can guide the therapeutic management. If you have a patient who collected urine today, you can take the patient out of the urine, and follow the urine. And you can determine the effectiveness of therapeutic intervention because the number of percent cell that will be shared in the urine and the tumor states will be down. So there is a therapeutic application as well, and I have the 2 minutes, so I won't be able to do it. So copper 64 has a sister radionuclide. It's a beta emitter called copper 67. You might have heard of Pluvicto, in which they use lutetium-177, and the leg linear energy transfer for both radionuclides is about the same. So I think I can use this. Pluvicto is a nice agent, cures, matters, extend the life of the patient by about 3 months, but there are a lot of side effects. And they come, most of them, by the distribution of the PSMA, for example, salivary gland. So, salivary gland PSMA, with copper 64, we have no salivary at all. That means I don't have anybody. Plus the fact that BPAC is expressed on all 100% of the prostate cancer as compared to 80 to 90% of the patient. So before you start the treatment, you have to see the PSMA expressed on it. That's another scan, another pulse, another visit. We don't have the renal uptake is very high, so we have to block the renal uptake. We have some uptake, but it's only in the cortex. Cortex are more resistant to radiation than usual. of the mutation was is excreted in 20%. It's not really 24 hours. A lot of these patients who prostate actually, they are incontinent to their diapers. So their diaper, they go home. And until we have 6 months, 7 days after they will be done. But we will talk about it. It's a big problem. We don't have that problem because the excretion of this compensate before they do this So in summary, I just I think we practice centers have a lot of challenges. There's a lot of work we're doing now, and I have to thank you for your attention.
Thank you, sir. I request our esteemed chairpersons to felicitate our eminent speaker.
Any questions because of the paucity of time can be asked during the lunch hour.
Sirs and ma'ams. I request Dr. Edwin Dias to kindly felicitate Dr. Uday Kumar Rao, the chairperson for the previous session. To a highly impactful and socially relevant session titled Cancer Prevention. We are privileged to have with us an eminent academic leader and noted cancer biologist, Professor Rana Pratap Singh, Vice Chancellor of Gautham Buddha University, Greater Noida, and a distinguished Professor of Cancer Biology and Life Sciences. To lead and oversee this session, we have the esteemed chairpersons, Professor Dr. B. Satish Kumar Bhandari and Dr. Jayaprakash Shetty K. May I request our chairpersons to kindly introduce our speaker. Chairpersons, to kindly note that the first bell will be rung at 15 minutes and the second bell at 20 minutes, by which time the esteemed speaker is requested to conclude the talk to maintain the conference time.
Good afternoon to everyone. We are very privileged to have with us Professor Rana Pratap Singh. He is a Ph.D. holder and serves as currently the Vice Chancellor of Gautham Buddha University and Cancer Biology at Jawaharlal University, New Delhi. He has obtained his MSc and Ph.D. in Life Science from Jawaharlal University, where his doctoral work focused on medicine and plant-based pharmacological studies. With over 3 decades of research experience and 25 years of teaching, he has previously held key academic positions including Associate Professor at JNU, Professor at the Central University of Gujarat, Adjunct Professor at the University of Colorado, and Visiting Professor at the University of Colorado and Johns Hopkins University. Professor Singh's research endeavors disease, cancer, stem cells, therapeutic resistance, radiation biology, and so forth. He has authored 193 peer-reviewed publications, including 19 in journals with impact factor above 5, accumulating over 16,000 citations and a very important index of 77. We hereby formally welcome you, Sir Professor RANA PRATHAP Singh, for chemo prevention of cancer.
Thank you very much for the introduction. Now it is 1:20, so I will take 20 minutes to present and I will leave 5 minutes for the question answer. So topic you can say is chemo prevention of cancer. And I have selected one word which is related to radiosensitization of a compound which has origin from the plants. So this is the place where I am working currently. It's GAUTHAM University. It's a 500-acre campus, beautiful campus having several departments, more than 160 courses what we are offering. So now coming to the topic, we have heard in the morning about history of cancer where many Western and European scientists were mentioned. But what I am showing here is that India too, already you see there are references of cancer in Charak Samhita as well as Susu Samhita, and they were long back when our rishis they had knowledge of cancer. Now I'll just give you one very brief and very concise concept about the system what we have in Ayurveda or ancient text, how it relates to the modern science. If you just look at the right hand side, there are words related to aweb and web, which is very much equivalent to subatomic and atomic. But we study in the physics and then chemistry, Mahabhuta and Dhanamatra, we have equivalent molecules and macromolecules. And then we have biology where we study Prakriti and Tridosha. That is what we are discussing currently. Also we are working on several aspects of different diseases where multi-omics and computational analysis, they are very much part of the analysis. So these are the equivalents. And this is a very simple slide to tell you about the problems related to chronic diseases what we are going to face in the future. If you look at this slide on the left hand side, in 2000, this is just demography. At y-axis we have age, and you can see the pyramid-like structure. So most of our population is at the base, young. In 2020 now this base is moving upward. It is around 25 to 29, and now you can imagine next in 2040 this base is going to go up and we have a large number of aging population, and that is going to tell us the burden of chronic diseases, and cancer is one among them, including all the cardiovascular diseases, neurological diseases and Alzheimer's and so forth. So we have a task before us how to manage the diseases in future. So this is just one example with the time how the cancer which used to be at number 17 in 1990, prostate cancer, now it has moved to 10th position 2016, and if you look at the data in 2025, it has moved to the 6th and 7th position. So different cancers, the incidences are increasing year by year. This is again a challenge before us. I have also taken the same example to show you some data what we do in the laboratory in terms of experiment. Earlier, the speaker has already given the background about prostate cancer. So I'll just move quickly how prostate cancer develops. And once it is treated with radiotherapy or chemotherapy, we see the emergence of radioresistance. So that was our focus, how to deal with the radioresistance. Here, these are the challenges what we do in terms of limitation. Whether it is radiotherapy or chemotherapy, you have problem of developing resistance and the toxicity. Once we modulate the sensitivity of tumor cells to radiation and also tolerance to normal tissue, we can enhance the therapeutic index or the therapeutic response of our treatments. We have used several phytochemicals in this respect. I'm just going to tell you about one of the phytochemicals. It is Srinivas, the top one, number one, and how it responds when we use this compound with the radiation. So this is the compound. This is a simple flavoride compound present in a milk thistle plant, and this structure tells you that it has both hydrophilic as well as hydrophobic sites, and therefore this molecule has property to interact with the range of interaction, whether it is hydrophilic or hydrophobic. We did a very simple experiment. This is a thymic nude-based xenograph model where human prostate cancer cells, they were xenografted on the mice and then they were treated with the compound. You can see the decrease in the tumor size after 8 weeks of the treatment. And this is how the kinetics of tumor growth was. The green line is for the controlled tumor growth, and the other two lines were the high dose and the low dose treatment. So this compound was efficacious in terms of decreasing the tumor growth. Since we wanted to explore the mechanism, what might be the target to which it might be working, so we did one very simple experiment to find out how EGFR is getting modulated. So this is how EGFR works in the cell. Classical pathway of activation, left hand side, the ligand is going to bind with the receptor, and then this receptor gets activated. It will do the mitogenic and cell survival signaling. On right hand side you see there is also ligand independent activation of this receptor, but it does not require binding of the ligand. These stress factors like radiation, that is IR is ionizing radiation, hypoxia, UV radiation, they can also activate this receptor, and mitogenic and survival signaling can happen in the cells. So this is a very simple experiment. Look at what is happening to these cells. 9L, they are rat glioma cell line and they do not express EGF receptor. So we cloned human EGF receptor and expressed in these cells and see how this drug is responding. The drug was used 2 to 10 micromolar. Now you can see there is no decrease in the calorie formation in these two panels. But when we use overexpressing EGFR, the third panel, you can see decrease in the number of cancer cell colony. So this started working when we overexpressed EGF receptor. So this was a very encouraging observation that most of the cancer cells, they express EGF receptor and they are dependent for their growth and survival. And here the compound which is working in the cells where EGF receptors are active. They are not active, this compound is not working. And we use EA431 as a positive control. This is known for high level of expression of EGF receptor. Then we did some more experiments to see if there is no EGF receptor, what happens to the cells. Knockdown experiments show how lack of EGF receptor is reducing the number of cells. And then what are the pathways? The common you can see and AKT, they are very much common, how they are converging on RAGHAVENDRA, that is a known modulator for DNA damage repair. Then we did some more molecules related to that. This is NHEJ and HR, non-homologous entwining and homologous recombination. All these molecules, what you see that there are some effect of this compound, and RAD51 could be one of the molecules to which it might be working. So this is the summary of this data. And EGF receptor, through its known intermediary molecules, AKT or DNA PK, it is activating RAD51, and that could cause DNA repair. Why this hypothesis is important? Because when we are irradiating the tumor, we are damaging the DNA and trying to kill the cells. But these cancer cells, they are acquiring DNA repair capacity. And therefore, they are not going to die because they will repair the damage which was done by the radiation. And that is how they develop radioresistance. We did some more experiments to see how this EGFR might relate with that. And we found that this RAD51 can also get activated independent of EGF receptor. And therefore, two mechanisms are there for DNA repair. Ultimately, all the conversions are happening again and again. If you look at this information, here you will find EGF receptor, it's a nuclear presence. EGF receptor is a tyrosine kinase receptor which works usually on the cell membrane, but there are reports that it also enters into the nucleus. It can interact with some of the molecules and then it can modulate several biological pathway. So first paper came in cell biology in 2001 where it was found out that EGF receptor can enter into the nucleus. And then people started working on this, but that time the idea was very much debated that how a big receptor from cell membrane is entering into the nucleus, what would be its role? Since EGF receptor is not having DNA binding domain, so it cannot work as a transcription factor. So that was debated, and then it was found out that there may be other molecules which might be mediating its effect. And we started looking at this, that how it happens in the prostate cancer, and how this molecule is going to influence its activity. We did a very simple experiment. We take prostate cancer cell lines, irradiated with ionizing radiation, and then we looked at the survival of these cells. These are advanced prostate cancer cell lines. You can see the dark line, this is only radiation treatment. The less darker one, radiation plus Srinivas, that is drug. So this line is below, telling that colony survival is less when the radiation is combined with the drug. So this is kind of additive or synergistic action of this compound. But more importantly, when we took another cell line, this is not cancerous, right hand side, HEK293, then you can see the red, that dark line is below and the lighter one is above. So this is a combination with radiation, which is above, suggesting that the drug is protecting these cells from radiation. So this observation is very unique, that this drug is protecting normal cell from radiation while it is sensitizing the cancer cells for the death. And this is what currently we are looking at related to radiotherapy or chemotherapy to find out a selective drug which can spare the normal cells. These are some of the experiments related to cell cycle progression where we found G12 in the combination, and we did more experiment to see how these checkpoints are regulated. This is CDK1 and cyclin B1. These were being regulated by the combination treatment. This is very important checkpoint. If you regulate this, then cells are not going to divide, and mostly they will have the fate for process induction. These are some more experiments to see what is happening to the survival. This is very important data. All A, B, C, you can see it is summarized in figure D. Bar diagram. We can focus just 1 minute on this to see what is there in this data. Look at the bar diagram. Left hand side, this is cancer cell line G145. First bar is only control. Second one is only drug. Third one is the radiation. Fourth one is the combination. Now when you look at the combination, you have more and more RS suppression. The dark one, the black. If you look at the right hand side, then you have normal cell line, which is not cancerous. What is difference? If you look at third bar is radiation. Height of this third bar is same whether it is cancer cell or normal cell. Fourth bar, you see the normal cell is getting reduced. So this tells that the radiation is not distinguishing between the cancer cell and the normal cell, but when the drug is present, it is reducing the RS formation in cancer cell, but it is synergizing the RS production in the cancer cells that are related to the death. This is one possible explanation or mechanism for its differential sensitivity. These are some more experiments related to cell death. Next, we looked at the checkpoint kinases to see how the DNA damage is getting regulated. And this is the data which you can see how the EGF receptor, which was our focus, how it is changing with the treatment. So this is the control panel. The blue color is the nucleus. Red one is for EGF receptor. You can see mostly the red color is outside of the blue when there is a superimposition of both colors. But in the third panel, when ionizing radiation is given, now you can see red color is coming into the nucleus. The fourth one, when ionizing radiation is given with the drug, now you can see the red color is outside of the nucleus. So there is no overlap of red and blue, but the compound is given with the radiation. So what is the conclusion from this experiment? This is telling that this drug silverine is blocking the nuclear translocation of EGF receptor, which is being done by the radiation. It's not coming into the nucleus. And therefore, this could be a possible mechanism related to DNA repair. This is another enlarged image. You can see with the drug, the red color is outside of the nucleus, that is EGF receptor, and only radiation, all EGF receptor is coming into the nucleus. When we are talking about repair, and this is another important molecule, DNA-dependent protein kinase, Srinivas 2056, this is the active molecule. That is red color, green is the nucleus. In this case also you see, when radiation is happening, then red color is coming into the nucleus, telling that DNA damage has happened and DNA PK is coming into the nucleus for the repair. But when it is combined with the drug, then again nucleus is very green and DNA PK is not coming into the nucleus. This is supporting our hypothesis that DNA damage is happening less, either it is being repaired with the presence of the drug, and that is why this DNA PK is outside of the nucleus. So this is another data just to support this observation. These all green dots are double strand breaks in the nucleus. You can see the combination more and more. The red dots are indicative of double strand break which is happening in the combination. So this is what I am going to summarize here. The data with the ionizing radiation. We have EGF receptor and DNA PK. They are coming into the nucleus and they will repair the damage which is done by the radiation, and therefore the cells will happily proliferate. That is happening in the case of cancer. On the right hand side, when we are combining with the silverine, when both EGF receptor and DNA PK, they are getting retained in the cytosol, they are not coming to the nucleus, and therefore the radiation induced DNA damage will not get repaired, and with the deficient repair, cells will die, and that is how we can get enhanced therapeutic response from this combination. Maybe you can ask what is happening to the normal cells. Then we also did some experiment with the normal cell, and here we found that in normal cell, EGF receptor is still there in the nucleus, and therefore EGFR related pathways are active and DNA repair might be happening in the normal cells with this mechanism. Then we also did some more experiment in the tumor xenograph just to simulate how it happens in the human. And you can see in the combination here, again we have combination, the pink line you can see, there is a regression of the tumor. So in vivo condition also this combination is working. And again, another more important observation is the protective effect, which you can see the pink line is about the red line, which is protecting from even body weight loss or loss in diet consumption, loss in various immune-related parameters, so the WBC count, lymphocyte or platelet counts, and also the tumor biomarkers related to proliferation or apoptosis. All these biomarkers are in the support of our hypothesis. To just summarize what I discussed here, that EGF receptor, one molecule to work on the cell membrane. This is the classical pathway, how it does DNA repair through RAD51. That is how cancer cells are surviving, because EGF receptor and DNA PK, they are coming into the nucleus and radiation-induced DNA damage are getting repaired and cells are developing radio resistance, and that is how tumor relapse happens. When after radiotherapy you see tumor comes back after a few months, a few years. But when we combine the radiation with our drug, then what is happening? All these pathways are getting blocked. EGF receptor and DNA PK, they are not coming into the nucleus, and therefore DNA repair will not happen. And with the damaged DNA, the cells will die and they will become radiosensitive. And that is how the therapeutic index can be enhanced. So this is our group in the lab, PhD students and postdoc who does a lot of work. This work was done by student Anya Nambyar. She also got Fulbright fellowship. and also visited several labs. And she went for a postdoc at Stanford. She became instructor and now she is a faculty. So I am thankful for the patient listening, and if there is any question, still I have 4 minutes, 5 minutes to answer. 6 minutes in fact. Yeah.
Sir, already we are behind the schedule.
Dr. Rao is having a question.
Only one question is allowed. Next question should be answered in that session. Sorry. Quickly wanted to ask, is there any role of cybernetic aspect coming into the picture?
Which factor?
Cybernetic. Will this implement whether it is marking?
See, we have done some other experiment, and selenium works at different level. One level is it inhibits the dimerization of each receptor. So this is cytoplasmic domain, and let me just keep it. So if you look at the cytoplasmic domain, so it interacts with this domain which is there near the membrane. We have seen its binding that is very strong. So that could be one mechanism of inhibiting. But there could be also possibility it might be working on its inhibiting the channeling of the receptor from cytosol to the nucleus. So nuclear input could be also inhibited. There are some specific phosphorylation sites on which we are working. How it can inhibit the translocation of this receptor into the nucleus by modulating the phosphorylation of different amino acids. Thank you very much.
Thank you, sir, for your very lucid presentation, because prostate cancer is a very important cancer burden in India too. And research like you and you previous they have one which is very important. Thank you very much.
Thank you, sir. I request the chairpersons to facilitate the speaker. Please note, I request all the participants of oral and poster presentation to hand over the presentations of yours into the respective room in charges in 3rd floor. Please consider this as urgent.
Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university. That is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the HONOURABLE Foundation.
It's my privilege to introduce my good friend, Dr. Rao. Dr. Rao is an accomplished biochemist and translational medicine scientist with over 20 years of industry and academic experience. He serves as an adjunct associate professor in the Department of Surgery at the University of Kansas Medical Center and the president of PAPINEni and Health LLC. contributing to innovation, scientific strategy and global health advocacy efforts. He directs major programs in molecular medicine and cancer diagnostics, leading research that integrates the biotechnology, imaging, radiation medicine, and nanotechnology. PAPINENI has played a key role in establishing global molecular functional imaging, scientific and business alliances, highlighting his commitment to international collaboration and scientific enterprises. As an inventor and thought leader, he has pioneered hybrid technologies in diagnostics, including molecular image-guided radiation therapy and advanced clinical optical imaging platforms. His innovation bridged diagnostic therapeutics, enabling more precise and targeted cancer treatment. With Dr. Rao's CV is running the pages. Thank you, Rao, for accepting the invitation. Wish you all the best and go ahead with your presentation.
Again, Namaskar. I'm going to keep it short because we are just kind of like very close to lunch. And please, chairs, thank you very much. And stop me 5 minutes before. I want to drive the message here. And it's a burden on my, because I got the award, I want to showcase why I received it. Hopefully, I'll be able to mention that. Although it might look a little self-posting, but please ignore that part. It's okay, like Dr. Matthew Thakur was mentioning, these are our disclosures. And again, like I mentioned, many of our early patterns in molecular imaging and nanotherapeutics came through. Those days, we were not allowed to publish, but anyway, we are pursuing that now and expanding it, collaborating with people all around the world, so to read out the whole thing. Anyway, what I want to start this talk showing this pie chart, combinational pie chart. This is the reality of modern cancer therapy. Each of these slides, behind each of these slides lies the life of a patient who depends upon the exact combination which leads to prevention of non-tissue toxicity, which Dr. RANA PRATHAP was talking about, the importance of the non-tissue toxicity. Imagine a grandfather or grandmother walking to the mall after cancer treatment, and suddenly they realize that they lost their bowel movements because they had a gastric toxicity. Those are the areas where we need to pursue. Future cancer warriors have to look for these kind of combinatorial tapestry which is available. Anyway, this is a good time for young scientists to think about it and move into this kind of arena. Not only nuclear medicine, chemotherapy, mechanical devices, AI, etc. Everything comes to the picture in terms of combinatorial therapy. So, this is shows pros and cons of combinatorial therapy. And then in this agenda, because of the shortage of time, I will go through a few things about what happened in the first early stages of my molecular imaging and theranostic career, which actually comes up in perfectly current scenario. So I'm going to talk more about radio tumor or inflammatory site, etc. And then anatomically co-register because of using a low dose of X-ray technology. Okay, with this kind of technology, we actually moved into commercial, and this was available for 5 to 10,000 labs all over the globe, and then pursued a lot of mechanistic studies in cancer, etc. So, I just wanted to move a little further, that in 10 more years, what we did was we utilized this for molecular image-guided radiation therapy. It's a poor man's image treatment. That is, you use a molecular detection in vivo, non-invasively, by near-infrared fluorescence or X-ray technology, and then suck it up with high voltage, that is our voltage. So we use this system, and again, for my research purpose, we use it, and as well as the other company commercialized. So let me quickly walk into some other technologies which are critical for the materials I'm going to show you in the next few slides. Again, I'm rushing through this smorgasbord for our lunch session. So let me show you these technologies allow the tumors to be detected in a non-invasive fashion, in a prolonged time, and also a quantification, semi-quantification with fluorescence or bioluminescence or X-ray based technologies. So there again, you can see this. These are peritoneal tumors, metastasis model, together with the Yale University Gilmore, and we were able to show by the green fluorescence protein which develops when the tumor arises into the body. That you can actually monitor it with and without treatment and follow it up. And the important of the aspect of this particular talk is we were pioneers in developing polymeric nanoparticles which can allow payload to directly by targeting. So we were developing targeting agents, be it small molecules, antibodies, single-chain antibodies, etc. So we didn't use single-chain antibodies, but this can use it in a future purpose. So one of the important aspects of this nanoparticle is this was used for both diagnostics as well as therapeutics. And these two are, for the students, please go to these two for both molecular imaging as well as nanotechnology. Some of the stellar papers from different labs are available in this particular special issues. So, if any cell that can treat, also hurt, ignite or extinguish or defend or destroy, this is macrophage. There's a dichotomy, there's paradox hidden in it, and this is because of oscillation of between M1 and M2. This paradox, we appreciated this yearly 2005-2006, and the curiosity of this paradox, not only for immunology, but also we want to utilize this to hijack its property, to utilize this macrophage to deliver nanoparticle or payload to the site effectors, be it inflammation or therapy. This was early 2008, and what we did was we took nanoparticles and used these macrophages as Trojan horse, then allowed it to carry therapeutic payloads to the disease sites. So I want to show a quick example. We used a burn injury model to show that these payloads in ex vivo macrophages as well as in vivo macrophages end up with the payload directly into the disease site. So this is a burn model where the red in color is fluorescence. When you see that, you can see the payload end up with a burn injury site of the leg, but not the frontal. So the same approach, what we did together with Srinivas, my collaborator, good friend in Indiana, we tried to see whether when you have external radiation of the tumor, whether these macrophages can bring in the payloads. So the proof of principle was done and presented at the Montreal World Molecular Imaging Congress, and we show that these Trojan horse or piggyback or whatever you call mules, etc. end up in tumor. Thus, this is one way of delivery of payloads in future. That is 15 years ago. So, since the time we showed this early stage in 2005, a rapid increase in this area in big labs developed. Samir Mitraganti, then Ralph Weissleider's lab, they showed these macrophages can be utilized for delivery of systems. And then finally, this year, our macrophage therapy is also in progress. So, a quick look of some of the recent work which were inspired from Ralph Weissleider's lab. You can see in green, when you have these nano-encapsulated macrophage chemotherapy together with radiation therapy, you have a perfect Trojan horse-related combinatorial therapy data. And then you can see why these nanoparticles, why these macrophages can go deep into the tumor. They did a kind of like a external studies to show that the vascularization is changing, and that's how these macrophages end up deep into the tumors. So I quickly wanted to do one more step. There's a recent paper showing nuclear medicine and radio pharmaceutical has been used to tag to the macrophages and deliver to the tumor. In this case, copper-67 has been used with the motor. Okay, what can one do? One can do is from the concept of therapy, take the macrophages out like what we did, and then give it whatever payload and send it back for the therapy with incubation. And this is one way to do a therapy, and this is ongoing in some labs. And I haven't come across any clinical trial with this aspect. And then you can actually manipulate the macrophage from different kind of like oscillating M2 or M2, BA, B, and then you can actually manipulate and improve delivery of these payloads. So quickly, I don't know how many minutes I have. Okay, so almost done. So by the way, this macrophage is a fulcrum of immunity and also useful. And this, anyway, for my award, I have to show we were the earliest in developing a payload of siRNA deliverable nanoparticle, which gave me 15-minute fame in 2010 for the different national newspapers internationally were there, and these were used for MDM2 silencing along with Alan Pola, and the same nanoparticle was held by Kodak patent for several years, $100,000 a year, and abandoned it, and later on Moderna picked it up and got $2 million for the COVID. Basically, our patent in 2010 did mention about vaccine for virus. We called it as a high affinity hookers. Anyway, I don't have much time. I want to quickly rush through one last slide, and targeting allowed, we were like developed a material which was a granddaddy of Ozempic way back in 2007 from Glia monster, saliva protein, and then it didn't catch the wind, but anyway, at least we still hold that particular targeting agent, which we can use it in nuclear medicine. And then quickly wrap it up with one important thing what I have to show is there was a challenge from NCI to develop an X-ray induced photodynamic therapy. So we took the challenge together with Sunil Krishnan again. We got the award in developing this cancer therapy. So this revolved around that particular idea of I-Conrad PET you can see, which is one of my patents, where you can deliver something through the body, and it can be a photodynamic therapy. So we completed this thing, and then recently Honor Science and our group got this Science Advanced paper, and Sunil, when he moved from Jacksonville to back to Houston, he actually took over and developed it towards immunotherapy, etc. So anyway, I'm going to be here for two more days. Please, if anybody's interested, we can sit and discuss. We have a kind of like a monopoly of openings here. We can discuss and then see how we can propagate further meaningfully. Again, this would be an interest where we can actually use IXPD instead of using external beam, we use nuclear medicine to again deliver the photodynamic therapy. This is somebody's work in recently published in ACTA Pharmaceutica Sinica. I just don't have time for this one. It's also a very interesting aspect which is worth talking to at the lunchtime. So let me close this by thanking a very huge number of collaborators. Without them, nothing is possible. And here I want to thank in this particular case, Sunil Krishnan. Prem Sagan, his work we can show, and we have a very interesting system for future in detection of nuclear medicine. And I also want to thank many of my molecular imaging collaborators and people like in this particular talk we have Shahid is somebody who collaborated with GI, not discussed here. Thank you very much.
Thank you, Professor PAPINENI. As the name goes, you are an entrepreneur as well as a researcher. A very nice presentation. If any questions, we will take it on lunch hour as already we are at 2 p.m. Thank you once again.
Thank you, sir. May I request our esteemed chairpersons to felicitate the speaker. A note of appreciation to our chairpersons for guiding this session with their thoughtful leadership and academic presence. I request Dr. Sucheta Kumari ma'am, Dr. Brinda ma'am and Dr. Nikhil sir to do the honors for our chairpersons. Sirs and ma'ams. I also thank Mr. Vikyan Mandela for including the sessions. I request the organizing chairperson and organizing secretary to escort the dignitaries to second floor for lunch.
Mangalore is known as an education hub. Many students.
The session of inaugural deliberations.
Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamarao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG, and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus, Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities, and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG, and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Parneshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture, established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas Group of Colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty. Mangalore is known as an education hub. Many students from different places come to Mangalore just for study purposes. So just take a round around a famous private research and skill-focused university, that is Srinivas University. Srinivas University is the flagship of the 18 Srinivas Group of institutions started by the A. Shamrao Foundation. It is a private charitable trust founded in 1988 by an eminent chartered accountant, Dr. A. RAGHAVENDRA. Proud son of Atka Shamrao, renowned chartered accountant and visionary academician, Dr. C.A. RAGHAVENDRA Rao started the first educational institution, that is Srinivas College of Hotel Management, in the year 1988. Today, more than 13,000 students are pursuing their higher education at Srinivas University and Srinivas Group of Institutions. Dr. A. Srinivas Rao, Vice President of A. Shamrao Foundation and Srinivas Group of Colleges, Mangalore, is an eminent personality. The university has also recognized his contribution in managing higher education institutions effectively. The group has established many milestones in the quality education in the field of healthcare, medical, dental, paramedical, allied health sciences, hotel management, engineering and technology, physiotherapy, nursing, aviation studies, port shipping and supply chain management. The university has established networking with many industries, universities and education services providers to substantially improve the quality and weightage of the course and degrees respectively. Presently, Srinivas University has 9 institutes offering innovative industry-oriented specialized courses of UG, PG and research levels. The Institute of Engineering and Technology is a constituent college under Srinivas University located at Mukka, National Highway 66, Mangalore. The college campus is developed in a lush green environment with well-qualified and experienced faculty, state-of-the-art laboratories and research facilities in the field of engineering, technology and management science as per international standards, with the aim of creating technically sound engineers and decision makers who can establish themselves successfully in the industry and global market. Robotics, artificial intelligence and machine learning, cyber security and cyber forensic, data science, cloud technology and information security and blockchain technology and distributed computing. The College of Engineering and Technology is on the threshold of a quantum leap. Institute of Allied Health Science. Srinivas University serves with medical facilities too. The college's clinical requirement is fulfilled by Srinivas Hospital, which is a 700-bedded super speciality hospital. We have separate hostels meant for boys and girls. Srinivas University Institute of Nursing was established in the year 2019 with the commencement of the BSc program under Srinivas University, located at the Srinivas University campus Mukka. The Srinivas Hospital is also located on the same campus and offers an excellent opportunity for students to be trained in a medical college hospital. The courses are well recognized by the concerned nursing councils. The Institute of Management and Commerce, earlier named as Srinivas Institute of Management Studies at Srinivas University, is committed to providing conducive learning environment. Institute of Computer Science and Information Science is envisioned to offer courses which would build the students into enthusiastic quality professionals in the field of computer science and information technology. Since 2005, the college is associated with several MNCs like Infosys Technology, Wipro, IBM, Accenture Technology, TCS, Tech Mahindra, Dia Systems, Spanios Technology, and many other in-placement activities. All-out undergraduate and postgraduate students get good placement through College Placement Program. Institute of Aviation is a constituent of Srinivas University. The college encourages the study of airlines, airports, and business related to the aerospace industry. This also includes supervising routine operations undertaken by the ground staff of an airport or an organization in the aviation sector. Institute of Hotel Management and Tourism offers a Bachelor of Hotel Management and Catering Technology and a BSc Hotel. These programs are focused on the aspect to create professionals who would be the future leaders of the hospitality industry. Practical exposure and experienced students will get from working in Hotel Srinivas and Hotel Saffron. Srinivas Institute of Physiotherapy was founded in the year 1993. From the year 2017, the college has become a constituent of Srinivas University. It is the first college which has designed the course curriculum to meet all overseas credentials. The college also has a wide network of alumni spread across the world in various managerial responsibilities. Undergraduate and postgraduate courses in physiotherapy are available on the Pandeshwar campus. Srinivas College of Pharmacy was established in the year 2004, offering both postgraduate, diploma and doctoral courses in pharmacy. The college is located at the Valachil campus of the Srinivas Group of Colleges with picturesque surroundings. The Srinivas School of Architecture established in 2012 with a B.Arch degree under VTU University and is a part of Srinivas group of colleges. The school currently offers 5 years B.Arch program, architecture studio, exhibition space, climatology lab, material museum, survey lab, model making studio, specialized classroom and good canteen facility is the highlight of this campus. Srinivas Institute of Technology was established in 2006 with the aim of producing world-class technology graduates tuned to the demands of a fast-changing global village. SIT has gained the name as the best self-financed engineering college in Karnataka in terms of infrastructural facilities. Srinivas Institute of Technology is a unit of Srinivas Group of Colleges, Mangalore. 5 departments have been recognized as research centers by VTU to pursue Ph.D. and MSc. The institute has well-qualified, committed and motivated faculty.
I request Ms. Tarini, Assistant Professor at Organic Science, to be the rapporteur for the session.
Dr. Vijay Shetty, consultant oncologist, pursued MBBS from Kasturba Medical College, Mangalore, MD in General Medicine, MRMC and DM in Medical Oncology from Cancer Institute, Adyar, Chennai. He is serving as professor in Shema, Indian University. He has published 47 research articles and has 8 clinical trials to his credit. He established the Department of Medical Oncology in October 2015 and has been carrying out complicated procedures like management of acute myeloid leukemia, acute lymphoblastic leukemia, and treating both acute and pediatric hematological and solid malignancies successfully. To be noted, he performed first successful autologous bone marrow transplant for a 55-year-old patient suffering from multiple myeloma in June 2018 and so far has successfully
He's a research professor at Prof. University and professor of physics, a significant affiliation in NASA. He serves as a faculty member of NASA Center for Applied Radiation Research and the director of CBRI, RANA, and SC and major research initiative in the radiation science and engineering. He also oversees the Solar Observatory and chairs the Research Advisory Committee within the Department of Physics. Sakari's academic background includes BS Physics, Mathematics, and Chemistry in MSc in Nuclear Physics and MS in Electro-Optics and Ph.D. in Physics of Nuclear Structure Theory. His teaching responsibilities span multiple physics and physical science courses, with the schedules extending to the 2025. His research portfolio is to the NASA Space Radiation Program. His extensive contributions include radiation modeling for the Mars mission and studies in the radiation scattering phenomena and work on NASA's Space Radiation Laboratory. He has served as principal investigator on the several NASA-funded projects focused on the space radiation risk, mitigation, and astronaut safety. Sakari has earned notable recognition such as invitation to the Oxford Roundtable NASA Air Service Awards and Johnson Space Center Awards for the mission and scientific contributions. In addition to his research, he has authored or contributed to numerous NASA technical documents, laboratory manuals, and chapters, solidifying his standing in the fields of radiation, science, and space exploration. Sir, over to you for the talk.
Thank you very much. It is an honor and a privilege for me to stand in front of you at this campus, Srinivas University. And I thank the organizers and particularly Dr. PAPINENI for inviting me to be part of this presentation team from overseas. Thank you very much for the opportunity. And I will be very brief and not here. I'm involved at the lunch place. Probably the most challenging is to bring many people back to the conference here. And I'm thankful for those who are here. Another challenge for me is how to keep you awake now. So I will take you probably to the outside of this world and talk about the radiation environment there. And come back and we'll see the applications of this radiation environment in a different way on the particle therapy. I'll be covering that one there. Very quickly, if you can see this one, I hope I'm here, working on this system here. You see one of the facets on in 1912. And if you can see this one, that at the time the cosmic radiation word was introduced by Victor Maxwell. Later on, in 1936, he was given the Nobel Prize for identifying that radiation environment is higher as we go into higher altitude. For example, in this case, there was a beautiful experiment they did. An experiment in 1915. Professor Dr. Hess himself was on this gondola with the radiation measuring device at the time, and he was able to travel not just 3 kilometers here, just a few hundred. You can see about 4,000 meters there, or 4 kilometers. And there is a distinguishable increase in the radiation measurements at that time. Where this radiation is coming from? Outside. We call it the word cosmic radiation from the background of the cosmic world coming through, and the atmosphere is protecting us. they go and spend a lot of time in space, how we can protect them, if we cannot protect them, how we can mitigate the radiation risk for them with various measures. That part is still being investigated and many approaches are being developed. If you can look at this one, these are people who have now into space from NASA program here, mostly, and you can actually see them single space flight. Each one has spent the most number of days, 371 days, just over a year time period for the moving astronaut time moving over there. So he must have exposed himself to a lot of radiation and all of it on the ground. On the ground, if you get about 1 millisieverts per year, they are getting like 70 to 140 millisieverts in a year. And that is a significant contribution of radiation to the damage, not only the environment, but in the micro level environment. So we can see the last, these two people found the last year, wondering how the things are being assessed, which will know is going to come back, how many days a day, we're going to 16 days. And the last, the most recent flight was these three people with 235 days. So let me take you to the next one here. This is an interesting one for us to know. The next one is radiation damage to the DNA. And in this case, we have one of the prominent scientists as well as an astronaut. And he got 650 days over a number of missions there, 3 expeditions on space station. Retired from NASA, now working for the private industry, also traveling to the space station. She had 2 more flights here, 9 and 12 days. So it's going to be a number that we will see in the next few years. Significantly accumulated radiation from young age to this senior age. In this case, I will show this picture one more time. X-rays not really can damage parts of the DNA, but the human body is capable of repairing itself as quickly as possible, mostly correctly. But when it comes to the radiation from the space environment, heavier particles, we talked about various things, iron is there, carbon is there, nickel is there. Some of these particles can shatter the DNA, and the repair mechanism for the DNA is there. You have to be access to completely, but we know that there is a lot of complications involved with this one. So we will go to the next slide here, show you some of these things. The same picture, a little bit more broad explanation for you. And in this case, you see my favorite picture that I worked on this one, and this is how the shattering part of the DNA can happen. That was only an imagination in the 2000 time frame, but we don't know then a little bit now, a little more. That's how exactly it's going to be, and how all the complicated realignment of these things are going to be more efficient. The same thing that we used to have NASA program on Mars science. If we were to send people to Mars via the Earth's low Earth orbit there, what is the radiation environment? We need to know that. And we measure that one. We didn't measure that one on that forecasting one there. We also have the lab in 2012. 2001, 2012, we don't have anything to measure the radiation on the surface of Mars, but we have from 2012, and we compare the results and all those things there as well. So now you can see, cumulative days, all the people, all the time in space, together we have 95 days for maybe weeks. So 666 months of time, and plus 25 days and more there. So we are 608 days, second month in here. We have other people here, and we have other people more than 365 days spent here. All that are going to be some of the astronauts. You see that one. So that's how we know about the human beings there in space, and we have got it. So if you look at this chart, there are about 50 people who spend more than 365 days in space. So we got some knowledge about these people. People have been collecting data personally from their blood samples and others to study about what is happening with their chromosomal elevations, the frequencies, the increasing, the decreasing, is getting better. How best we can do the studies that are being done at So this is the work that I said about 2001 RC and translating the information from the orbit, the measurements. This is what we got here. I want to show you one other thing here. That is one used for 2012 Mars landing or Mars science laboratory. That is another radiation and space as well. This is what we got here. This is my other favorite picture as well, because we can actually show the radiations of radiation matter on the surface of Mars. It has both valleys and the peaks. It is a very thin atmosphere. If you consider the thin atmosphere, it kind of production there, just like a thick atmosphere we have on the Earth. There is no magnetic lines supposed here, so you have the product of all sort of particle units on the surface of Mars, and you will experience that. Over the time period, you can expect something like this one. The peaks are going to be in the certain area, and the valleys are going to be in this blue area. It's the lowest place on the surface of Mars for the nation. Very good place, not from a radiation perspective, but a very complicated place to get there, and very most dangerous place to come back. So we will be landing on these things. Most of our roads are blue shapes in this right side part of the picture. So if you can go to the other part here very quickly, just to the measurement data as well as the model calculation data here, we're talking about the millimeter 0.2 per day. And that changes slightly depending on the solar cycle and the location, where it is, where what things are happening on the sun and all that. But the lowest figure is going to be 0.7. When we calculated this before the measurement is also going to be low. So we'll go to the other parts here and show very quickly this one. Catch up with me. It's one payload that we developed and launched into space to measure the radiation environment between Venus and Mars orbits there. And that's how it's going to be once we launched on the Earth here. We go towards the Venus orbit towards the Sun, and then we catch up with itself and then come back to the Mars orbit on the other side. That's where it's going to be. We have wonderful data, we know the radiation amount a little bit there, and the challenge is how to get the data back here. So we can actually see that orbit and Mars that one, and when we get to the bigger orbit, we go towards the Mars area. That will continue for the next 30 to 40 years from the plans to the Japanese aerospace, and we know the radiation by the device for the probability on this spacecraft, and that's what it's happening. So next one, probably is very interesting for us. This is where we will spend a lot of time with the OS argument there. This one, this is an instrument with 8 sensors, 2 on each side of the screw, and 1 on the top, so a total of 9 sensors there. They all have different purposes for that one. So you'll see here, in this case you can actually see some of them are called the Ph.D. spheres, on the styling spheres, and we have open one of the X-rays in space, and we are able to measure the X-rays as well with less than 1 kilogram of payload, and all these sensors will be very sensitive for that particular part with the different coatings that we place on them as well. And this is going to be the polar orbit, going 93 degrees going from south to north on the Earth orbit, but 67 kilometers there. So we can see a lot of X-rays moving around the pole, and this is the pole that we have a lot of data as well. So let me go to the next one here. I will take you very quickly through some of the applications that we're thinking about on the ground. Radiation measurements are important in space. We cannot have all the experiments that we want to do for radiation biology. So you will replicate some of them on the ground. When you replicate on the ground, you can use different areas, you can use protons, you can use helium, carbon, all those particles there, independently, the high temperatures you can map these cells and study the dynamic of these cells. However, you cannot create the microgravity as in space. Things are going to be different. Things are going to be different in the human body. Things are going to be different from the human body exposed to the same radiation amount. So we are trying to understand and manipulate those kinds of data. So very quickly, if we're going to go to these next 2 slides here, I think next one. This is an experiment on the space station itself. So the Japanese scientists, they came with this great idea with NASA space in Houston. They worked for 10 years. They placed the embryonic stem cells in the freezer there, frozen ones, for a longer period of time. Some of them are short periods, some of them are long periods. there as well. And we study various other things as well. And those are some of the results you see here. With the non-H2A examples here, you can see the one cells left on the ground. In the red color, the works on the space station, and blue color you can see as we go number of days of space exposure. Things are going to be more complex and complicated, but they have found that in this fish as well. When we expose the radiation particle that we think that should be there, similar energies with similar particles here on the ground, you can actually see this red one is an iron particle, and then you got a space station, and of course the proton also over there, and you can see the green and this blue very, very close what we expect to be our space station. So space station must have seen very, very close to the proton beams and particles at the 85% right there. And we got that one. But when we expose the iron particle, the level is significantly more significant. So we'll move on very quickly on this one here. And now all these wonderful things start to go what good work we have observed here. And this part of that one. So I would like to add a little bit more, not this radiation part to the space of mind, which is going to be protons and helium and all the area and particles and radiation, 85, 15, and 1%. But we can also think about the space itself that produces neutrons and all these particles. The secondary neutrons are going to be a lot more complex and complicated. So long time ago, we said in our neutrons. I think I have certain slides here. And we did notice that with this young fish model approach, we have a lot more interactions of this whole aberration. And the rings of all these things and various models there, we can see that one, and they notice that. But I would like you to pay attention to this part of the graphic here. The neutrons are going to be significantly higher than the iron particle at the same level too. The reasons are yet to be decided more a little bit. Right now we know that these neutrons can cause more damage by the time we can be able to spend in the trajectory or in the transition of these cells. So we'll just go the same point here. Neutrons will cause more these aberrations here, and the more complex the combination of these the higher particles here. Now we want to add the question: if we add the microgravity to the system, how the regulatory mechanism is going to challenge the cell structure itself? And that's going to be complex and complicated as well. We have one simple example here, and I will show you this one. This was presented a couple of years ago by Dr. BUDDA. And she did do a lot of wonderful experiments in this microgravity area. There is a synergetic effect of both microgravity as well as the radiation environment there. And I think that I have a little part here showing you very quickly here. And I will show you all these damages we have seen just by exposure to the neutrons there. And we can go and talk about those things and complex damages. Even, of course, the large size of the chromosomes 1 and 2 and 3 and 4, that's very good. But even the lower end also we're able to see that one. And I have some of those things here. You can actually see on this map here the static microgravity, standing microgravity, and so on of various things, control, X-rays, and carbon ions here. And I would like you to keep that in mind. And of course, carbon ions produce a lot more things under microgravity. They are on the static version there slightly, and then we can see that one. These are the various things compared to here. I have a control path, and then 0.5 lane, all these things are X-rays. And when we have carbon ions, things are going to be a little bit different there. And both those static and microgravity particles are also shown here. That would be significantly different as well. So let me take you to the final aspect of this part of this information. If you can pay attention to this one, the moving one here is the one that is going to create the microgravity environment on the moon, which is about 1/6 of the gravity of the Earth. The same thing can be changed in terms of rotations per minute, and then we can also create the microgravity environment on the Mars, which is 1/3 the gravity of the Earth. And now we have this Californium there, and that gives the neutrons there. And the cells are exposed in this microgravity environment now with the same neutrons there. The experiment we initiated in 2006, this is the 2022, 23, 24 time frame from Los Angeles to this part of the story here. And we are able to notice that there is a significant difference there when we change the microgravity environment in terms of the chromosomal aberrations in the way they can look together as well here. You can actually see on this right side of the chart here, and you can see the control at 1 G is on the ground, and then you can see 3/8 of the G on the surface of the Mars there, and 1/6 G on the surface of the Moon. And you can actually see that one in the microgravity environment where neutrons are exposed to these cells, the same cells we are talking about here, and the aberrations are going to be even significantly more, and we need to study and we need to understand these things as well. So human body is always challenging, and probably we can do much better on the ground. When we go to space, it's going to be different. And we have other aspects too, including bone loss and other things there, muscle loss, and talking about the cells exposed radiation and challenge there. So this is one contribution we did recently, and this is with some of the collaborators in the Srinivas and the NASA Space Center. And we have a sensor, and this sensor is capable of looking at 1.67 microns per pixel. So that is the highest resolution. So we're looking at 10 million pixels in a 1 centimeter by 1 centimeter sensor here. And we developed this sensor so that we can get pixel by pixel data from the radiation environment penetrating through. And we can actually place our chamber slide with the 8 wells here. And one of them will be exactly sitting on this structure there. And the physics part is collecting data. The biological part is trying to find if that is true. If that's what we are observing, then in this as well. So if you go further down here, and this is where I need this machine, I think it is giving me a hard time if you can help me. To go to the next slide. And very quickly, yeah, I'll say next slide and I'll show very quickly. Yes, yeah. Okay, very good. These are the experiments we did in Japan with the carbon and Brookhaven National Labs in the US as well. And we're able to see the impact of the particle actually penetrating through vertical, in this case, edge on. So if we turn the system around, okay, now the particle is penetrating through along the cell line, and we are able to image this one through this confocal microscope and so on. So now combining the data with what we have seen on the sensor itself, with these things here, we can actually see that we are able to interpret some of the data as well. I'm going to show you the sensor data now, and some of you might have seen this one. If you expose the sensor to the same radiation environment, this is how we're going to look at this particular part here, and I'm looking at two different LED values, that's 13 and 25 keV per micron there, and this is how it's going to look like, all the particles penetrating parallel to the detector here now, and then when we go to the next one here, I think I'm going in the wrong direction. This one. I'm just magnifying the same image there for you. So I would like you to see that one. And this is our 13 keV per micron environment, the LED value. And you are actually seeing the pixels right now from the sensor. All of them are 1.67, the bright one. There's some variation there. That's how the particle is going to have impacts on that one. So I'll take you to the next one, which is 25 keV per micron. And then you can actually see these cells here very quickly. And all these tracks are particle tracks. You can see they are much thicker, much broader, and much involved in other parts of the area as well. There you can see all those things there. So now we're trying to understand not just the damage to particular cell area, we're measuring the damage, but also other parts of the cells will be involved in that as well. Apart from the other signaling mechanisms that are going to change and alter these things as well there. So now I'll need to move on to the next one here. Comparing these two, 13 and 25 kilovolt per micron, that's all the differences. They may be just doubled, but the energy imparted at the cellular level is going to be a lot more than that one, exponentially more than what we have there. So this is my favorite picture again, and one more favorite picture. And we are showing you all the pixels there, and in a small area magnified. And the trajectory is not just one straight line there, but some of them are a little bit higher, some of them are lower here, and also the other parts of the areas are also. That's how the track structure is defined for carbon ion, and that's how they model that one, that's how they interpreted it as well. But now we can actually see that one and use for other parts there. I will bring you back to the earth now, if you are with me so far. And now I would like to show you very quickly the two examples of the proton beam particle therapy and carbon particle therapy in the world, and where we stand very quickly, so that Dr. Rao suggested that I need to bring that part of the story to this part of the presentation here. So far, the blue line indicating the number of patients we have treated with proton beam, starting with in this case 2007 all the way to 2024. It is increasing rapidly. The number of facilities are there, more number of patients are there, more being treated. And the red one is the carbon ion. Though we have patients in 2007, very slow with few carbon facilities in the world, and now we are increasing. Maybe one day it will be more and more in the next 5 to 10 years time. So we'll see here, and this is where we'll see most number of patients treated with carbon beam from Loyola University, the top one in the US. A lot more patients there because they started a long time ago, 1997 and so on, and going on. And then we have some of the patients here treated in the lower number 200 and so on, all these places. These are the number of facilities that we have. When I put this chart together, I was wondering myself, how come if you take the equator, all these facilities are above the equator? Now, thank you very much. I will be concluding in 2 minutes. And this is what we have. The blue ones are the purple ones are the carbon beam, and the rest of them are proton beams around the world here. And I'm also pleased to note that in India we have two such facilities there. One on the west coast and one on the east coast. And the nearest one from west coast, Mumbai, is going to be this one. The nearest one from the east coast is going to be Thailand or other places here there. And then we have both of them are proton facilities like 230 MeV and so on. From 2023 on the west coast and 2019 from the east coast, that's what the data says. We have those things as well. So if you can go to the next one here, typically proton beam is used to treat prostate cancer, head and neck and liver. And the carbon beam also seems to be similar to prostate, head and neck and liver. There are some advantages for the carbon beam, both the physiological changes as well as the protecting of the other organs there, and we will see that one in a minute here. So you're all welcome to go to this PT.com page, and then you can get all these details as well there. If you can look at this one, most of the energy for the carbon ion is going to be between 250 and 430. Most of the energy for the proton beam is under 250 or 230 most cases. That's what we have. So we have to do more energy. The deeper tumor can be treated and so on. The challenges are going to be accelerated. You cannot generate the carbon ion to treat patients with a simple one that you can do for proton beam. You have to do synchrotron and pencil beam scanning and raster scanning. All these things are possible as well. So let me show you one other thing here. And here, what we have. I hope this one comes through. Bring both of them together. The advantages with the carbon beam, the radio-resistant historically can be overcome, or we can take the challenge on that one. Near critical structures in organs, probably they are better protected with the carbon ion if you can plan well than the proton beam and other parts there. And then we have high cost, large area footprint, that's another problem, and needs sophisticated modeling, including the RBM modeling and so on. And it's not available yet. We don't have anything like carbon beam in the United States yet. But one day maybe we'll get that one. I'm going to show you that in the last one. Japanese have been doing this carbon therapy for a long time. They started in 1994. We worked in the same place around our experiments too. And then they're expanding constantly. Just as they're expanding with the proton beam around the country, the small country, they have this carbon ion also in various places there. So if you go to the next one here, Germany and Italy, they started in 2009, much later, and they're also expanding into other parts of the areas there, one in Italy there, and the other one is in Germany, two, Italy is one, Austria is one as well. And now China is also expanding from 2014 to 2019. They have plans for future as well. These are some of my last charts here very quickly. And this is a list of things here where India is included in this A, so I countries, India, two places there. And you can actually see these are the carbon ion facilities there. There used to be 14 of them until 2024. In 2025, we expect to have operational 17 of them around the world, and they're going to expand as well there. So now they have treated about 100,000 patients in this category there. So if you go to this one, and I'll show you in Japan alone, 150,000 patients and more being treated with the proton, and you can see more number of carbon ion cells there. These are all in the Japan there. So now we have here in the Europe area, there are only two carbon facilities, about 55 to 60,000 patients being treated as well. So if you go to this part of the world, most of them are USA, the last time for me. And this one about 140,000, I thought it was much lower number, but that's why this. The total number of facilities right now for protons about and carbon ions about 142. 17 of them are at carbon area in the 24-25 frame, and we've treated close to 400,000. So these are the things coming up in future. You have 30 facilities, out of which we can see 3 of them are going to have a beam. If everything works in the US also, we're going to have one here. South Korea is going to have one more new one. France is going to have the new carbon facility as well. So that's going to be my last chart for you, and I will stop now. If you have any questions on the space radiation or the ground treatment facilities, particle therapy, please let me know.
Wonderful presentation, sir, and I open up especially for me. Questions? Also open for the question.
Very nice presentation. You touched upon several aspects of it. I have just one aspect question on the presentation. Is there systematic healthcare profile on the surviving astronauts in case they neurological disorders, cancer?
All astronauts will go to, the question is any systematic profile for these astronauts. And what they call is longitudinal studies. Once they come back, they will be released into various studies as long as they are part of the NASA program. If they retire and go to different jobs, they are voluntarily asked to come back and give their blood samples and things. They do have. And one such thing that a wonderful question that one more related response came out was, astronaut members seems to have cataracts developed 10 years earlier than a regular normal population of the same height and same quality and same height. The reason is attributed to space radiation. When Apollo astronauts were going, they actually have seen the flashes in their eyes. They did not know in 1969, 70, 71, 72. But now we know if we send the radiation through the eye, it's going to cause flashes. And that's going to create the greatness for this cataract formation. So that is one of the good observations that we have. Thank you, Doctor.
I always say no, but the organization say yes. I'm going to ask the question. Extending to the doctor's question, are there evidences to believe or predict that the LND doesn't hold for space radiation, and therefore the consequences on long-term sequelae like cancer, or we don't have any clarity?
Well, the good answer is we don't have clarity. Thank you very much for that question. I think that question is, standing here listening with this noise in the background is challenging for me. I think you're asking about the LET values, right, Dr. Varma?
Linear non-threshold for the cosmic
Okay. LNT1, okay. So, on this one I will say one thing. NASA emphasizes are the RBE calibrations. And the RBE are much more reliable for us in the space. And they say that anything about 350, for example, 350 and above X-ray parts, when we bend it on the cell lines, and that's a good one, is equal to the gamma. The RBE is also not for X-rays, but the gamma values as a basis there. That is the best one that we can believe can work for us. So over the past 20-25 years, Dr. Kuchnat and others have established that we will go with the RBA values based on the gamma. Thank you, Doctor.
Thank you, sir. I request our chairpersons to felicitate our speaker. Thank you, sirs and ma'ams. Thank you, sirs and ma'ams. We now move to a scientifically rich and highly relevant session that highlights one of the most promising areas of modern cancer treatment, novel small molecule inhibitor of PD-L1 for cancer immunotherapy. We are privileged to have with us Professor Lakshmi. To preside over this session, I request Dr. Vijay Vittal Shetty and Dr. Raghuraj to chair this session and introduce the speaker. Chairpersons, kindly note, the first bell will be rung at 15 minutes, the second bell at 20 minutes, by which time the esteemed speaker is requested to conclude the talk to maintain the conference time.
It is my privilege to welcome Dr. Lakshmi to give a topic, to give a talk on the topic on PD-L1 inhibitors in cancer immunotherapy. This is the hot favorite of all oncology therapy right now. Brief introduction about our speaker. Professor Lakshmi is a distinguished academic leader, currently serving as Professor and Dean at University of at GAUTHAM University. And prior to her role in this university, she has served as Chief Scientific Officer at RANA Life Sciences. Also, she's headed the Discovery Biology Unit at Union Therapeutics, contributing to innovative biopharmaceutical solutions targeting unmet medical needs. She has got more than 25 oncology discovery projects. She has delivered quite a few projects in the US-based biotech companies, demonstrating strong expertise in drug discovery and also collaborating with a lot of universities in the United States. And also she's got her PhD licenses from JMU, Delhi. And her research contribution include over 30 publications in international peer-reviewed journals and several patents she has for her name. And over to you, ma'am, for your talk on cancer.
Thank you for the kind introduction. A very good afternoon to one and all. It's my honor and privilege to be here today among all of you. So thanks to the invitation, Dr. Rao, and also thanks to Dr. Sucheta Kumari and the organizing team for the wonderful hospitality that we have been receiving here throughout. So this is just one of the beautiful pictures of our campus, GAUTHAM University. So today's presentation, actually I've structured it in parts. So I'll initially introduce you a little bit on cancer drug discovery, and then I'll talk about, how we came about developing small molecule inhibitors for this particular protein PDL1 for targeting cancer immunotherapy. You all have, sorry, here. Can you change to the next slide if So, okay. So you all have heard a lot about cancer from morning. So it's nothing but a disease of unregulated cell division, which initiates by a single mutation in a single cell, and over the period it accumulates a lot of genetic as well as epigenetic changes, and to finally progress into an invasive cancer. You all heard about the statistics about cancer. Dr. BUDDA spoke about the staggering number of 600,000 people dying in the US. And if anything in India, the number is much more than that. And unfortunately, even the mortality rate in India is somewhat higher compared to what we see in the Western countries. And we also saw Dr. Rao speak about the treatment options and what are the different combination treatments that are available to cancer patients. So I quickly go through what I will be talking today, which is on targeted therapy. So targeted therapy is targeting one particular protein in the cancer cell that is responsible in some way for cancer growth and progressions. So, and even if you look at the oncology drug market, it is a whopping number of 135,000 million. In 10 years ago, and in 5 years it's just going to double. So it's going to be the market is growing infinitely. So, but why do we need innovative therapies when we have so safe and efficacious for cancer patients? Okay, so like I said, how do we discover drugs, especially cancer therapeutic drugs? We started with natural products, and Taxol-based drugs is one of the most commonly used chemotherapeutic agents, and there are many other examples that have been developed from natural products. And there are accidental discoveries also. Dr. Nishita mentioned in the morning about the nitrogen mustard that was used in World War II, which is now used in lymphoma and some of the leukemia patients. And the other approach is, biosimilars, where you modify the existing drug to, get a better property or one novel property so that you use it for similar cancers. The last approach that I will be talking about is targeted discovery. One example I have given is, use of HER2 antibodies, again somebody mentioned in the morning. So for targeted therapy, you can pick any protein that contributes to the several hallmarks of cancer that has been represented there. And you can either make small molecule chemicals or antibodies. And there are many derivatives from these two also that can be used. So, like I said, there are biologics, which in the form of antibodies or mini-bodies, and there are small molecules in the name of chemical drugs. And there are many, novel approaches that are coming up, which are in between these two. They are, bigger small molecules or smaller antibodies. All are available now. Some examples are antibody drug conjugates, theranostics, as well as something like PROTACs, where you make the protein undergo ubiquitin-mediated death of the protein by targeting it to ubiquitin lysosomal pathway. Okay, this is probably familiar to some of you, where we look at what is the journey of a drug being conceptualized to actually becoming a real drug. So this funnel, as you see, it has many different phases of drug discovery it represents. So as it goes to the advanced stages of discovery into development, although the funnel is narrow, this is where the most of the resources in terms of money and efforts have to be put in the clinical stages. So from the clinical candidate. So these are the various different steps involved. I will go into some of them in more detail. So in each stage we also define criteria as to how we can move the drug from one stage to another, which is very important for success of any drug discovery program. So in the hit stage, we either do virtual screening or high throughput screening, and then we identify molecules that have some binding to the target of interest. And we also set up experiments or assays to assess or validate the potency of those molecules. The hit stage is just to identify chemical space that has any affinity for a given target. And as you move it, you also assess and optimize the potency of the particular molecule. You make it more potent, and also you look at the drug-like properties, which is a very, very important aspect. I hear a lot of people talking about drug discovery, like in terms of bioinformatics, we talk some molecule, maybe few molecules, and assess it in the biological assays and compounds. And that is not how actually discovery works. So it is much more involved and looking at a lot more aspects to actually do better. So this optimization of drug-like properties is very, very important. We're looking into the anti-scenes. What is the cytochrome P450 mediated effect, and stability, protein binding, and whether it is soluble, whether it is orally bioavailable, can it hit the molecule orally, and how many times we should actually take. All these are determined in this stage, in the earlier stage. And then later the lead optimization stages, we already have a potent molecule, but we want to optimize the properties. So you look at safety of the molecule, and then if there are other issues like your molecule is not orally bioavailable, can I modify the molecule to make it more available? And can I make the molecule from 2 times daily dosing to once daily dosing, which will be much easier than the beginning. So all those aspects of the molecule are looked at the lead optimization stage. And finally, we go into preclinical candidate, which is mainly about safety of the molecule. So we do what is called as a non-GLP tox or an exploratory toxicology study to identify what is the maximum tolerated dose and what is the dose which is non-observable efficacious levels and highest non-toxically severely toxic dose. And all these things, these are different terms that are used in toxicology to understand the safety of the molecule. This is very, very important to even determine your clinical dose. So because before you get into clinics, you need to understand, what will be the dose I will start in the beginning. So all those understanding comes from the later stage of drug discovery before it goes into development. And finally, GLP toxicology, which is very, very important. It's a highly regulated toxicology study from which you identify what human dose prediction, and then you go into see that also gives us an indication of what are the targets of toxicity. So all that you need to watch for in the beginning. So it is a clear indication of how the molecule should be taken into the clinic. And although I showed it in a linear fashion, it's not really a linear pathway. It's an iterative cycle. So the molecules are synthesized, it is screened in various aspects, and then the information goes to the medicinal chemistry and computational chemistry, and the molecule is modified again. So several cycles happen like that before you finally come up with this lead molecule. I think I kind of already talked about virtual screening and high-throughput screening. This is all in ways how you identify the initial lead molecule, and then validate that this is actual hits that are actually binding. Or sometimes if you already have a own inhibitor, you can modify the inhibitor and then come up with novel inhibitor also. So that's all starting from prior art. And the next, I don't expect anyone to understand this whole thing. This is just to show that if you have a molecular core like in your center, in the phase of lead identification and lead optimization, you kind of get a thorough understanding of this molecule. Looking at its, how by which substitution it makes selectively EGFR, what substitutions make it, add additional activities, how can you increase solubility, where is the hydrophobic pocket, and all this kind of information we get a thorough understanding of the molecule. So that's what And then finally, you come into the preclinical candidate stage. And like I said, it's a highly involved phase and a lot of different groups are involved in this phase. And then this I spoke about preclinical studies focused on toxicity mainly. So what should an ideal drug be? You should have it initially efficacious. Obviously, you should have very good on-target potency, and it should be selective. In the sense, at least the majority of the activity that you see should come from the primary target, and it should be safe and well tolerated. Obviously, so you should know what are the toxicity, whether it is manageable, whether it is reversible, and how I can manage it. You should have an understanding, and also you should have acceptable drug-like properties in terms of whether I can dose it orally, even in terms of whether it is easily synthesizable, ease of administration, all that comes with the drug-like properties. So ideally, the drug should provide maximum benefit to the patient with minimal off-target effects. Okay, just to give you an idea of, we talk about personalized medicine, just to show you how complicated it is when using personalized medicine to come up with targeted therapy and make it actually personalized. Okay, so in cancer you have 100 different cancers, and if you just take lung cancer, again it has non-small cell and small cell. And if you take non-small cell, if you just take there are several ones, if you just look at adenocarcinoma, that has again several mutations, CGFR, KRAS, there are all driver mutations. So if you are developing a drug against one, it's going to work in that particular patient only and not. So we cannot make a drug for lung cancer. It has to be against a particular mutation. And in KRAS itself, there are so many different mutations that we see, they are all present. So against which one you are making a drug, that matters. And then, in addition, there are all co-mutations present in each cancer that makes it even more complicated to see which one is actually going to work. Okay, now I am coming to the second part of my talk, which I will try to finish very quickly. So, if you look at immune checkpoint inhibitors, see these molecules act like brakes. In the sense, immune system gets activated in response to any stimuli. So there are unique proteins that control that. So they act like brakes in the system, and there are some proteins that act like accelerators to activate the immune system. Both are present in our system. So today we are talking about the PD-1 pathway. So this pathway, actually this PD-1 is programmed molecule which is present on T cells, and the PD-L1 is a protein present on cancer cells. So when T cells try, the function of T cell is to recognize the cancer cell and kill it through its T cell receptor, which recognizes the new antigen on a cancer cell that is represented by antigen presenting cells. So that's what usually happens. But when the cancer cells have this PD-L1 protein, they don't recognize the PD-1. So when they recognize each other, there is a signal to the TCR to not divide. The T cell receptor gets an inhibitory signal, so T cells stop dividing. So this makes it an attractive target. If you can target the PD-1 PD-L1 pathway, then we should be able to activate the T cells again. So that is the hypothesis behind going after this. And there are many monoclonal antibodies that have been approved already for various cancers. So why do we need a small molecule inhibitor? See, the half-life of the antibody is much higher, so it stays in the system for longer. So that also causes immune-related adverse effects on immunogenicity, which is a problem that is, everybody is facing in the clinic. And the other problem is that the permeability of an antibody inside the tumor or into the blood-brain barrier is very poor. And also, the production cost is very high for antibody compared to a small molecule. And every time it has to be administered intravenously, so patient compliance and ease for patient also comes into the picture. So all these reasons, it makes it the perfect case to go for a small molecule inhibitor where the half-life is small and we have a flexibility of combination therapy. And even if there is adverse effect, because the half-life is smaller, it can easily be managed. So these are all the advantages, and it has very 100% inhibition of PDL1 and PDL1 binding, and the molecule is very, very potent. It is 1 nanomolar as the potency. And once the PD1, the antibody or the inhibitor binds to the PDL1, the mechanism by which it inhibits this, it dimerizes the PDL1 protein. So the other thing we measured is in the cells, we overexpress PDL1 with two different enzyme components in acceptor and donor. So if the dimerization happens, you will have an anti-enzyme. So that is what this assay is measuring. And you can see that with the increasing concentration of the PDL1 inhibitor, the dimerization also increases. So the stimulant actually binds and dimerizes PDL1. And not only that, we actually looked at the actual crystal structure of the molecule. So this is the representation of the crystal structure, where you can see that two PDL1 molecules have come together, and in between the small molecule is bound inside. And what is more interesting is if you look at the area which the PD1 occupies on the PDL1, there is a significant overlap with how the small molecule binds. So it is telling, and it is also comparable to how the antibodies are binding. So it is telling that it is binding the same way the PD1 binds to PDL1, thereby inhibiting the interaction between PD1 and PDL1. And this is again another functional assay looking at if you inhibit the pathway, you will see an upregulation in interferon gamma, which is one of the markers of T cell activation. So this is a co-culture assay. On your right side, you see there are the cells overexpressing PDL1 with co-cultured human PDMCs, and then that leads to the inhibition of interferon gamma, and which is reversed by the compound treatment. So functionally also it works. I'll just finish it. Okay, this is another experiment which I did, again showing the PD1 and PDL1 interactions inhibited in the cells. I see this also again more co-culture studies, all of which are clearly telling that functionally this small molecule works like the antibody inhibiting PD1 PDL1 interaction, and it is highly potent also. And again this couple of slides I go through. See, we want this molecule to be, now we know that it is potent, and it is one more thing potent in the cells of the in vitro system. Now we orally administer the molecules to mice bearing syngeneic tumors. Syngeneic model is where you have the immune system intact, and here also it shows potency similar to the antibodies that we administered. These are clinical antibodies that are approved antibodies actually that we have compared in two different models. You can see it shows similar efficacy. And this is another orthotopic model where we injected the tumor cells into the cranium of the mouse and then looked at the survival. Again, here also you can see there is a statistically significant increase in survival when you administer the compound orally. So this molecule also crosses blood-brain barrier, which is very clear because the molecule was orally administered, and we are looking at efficacy of the brain. And it not only shows efficacy, you also see increase in some of the markers of cytotoxic T cell, CD8 positive cells and CD4 positive cells in the brain also are increased. So now we know that it is potent, it is efficacious, so it has to be also safe. So we did some safety studies in non-human primates. From these studies we know that it is highly well tolerated even at higher doses beyond the efficacious dose. That's what you see, there are no systemic toxicities. And also we looked at the brain levels of the compound from this study, which is also you can see a dose-dependent increase, suggesting that it crosses the blood-brain barrier also. So finally, like I said, we have developed a small molecule inhibitor that works just like the antibodies that have been approved. So potentially this would be used in combination approaches for treatment of immunotherapy. Thank you. All the work was done in immunotherapeutics, and this is again one of the views of our campus. Thank you so much for listening.
Thank you. It was an excellent talk. We were participating in all, which are really molecules are game changers, and the future problem is resistance to these media inhibitor. Maybe these molecules will help work on the resistance also.
Yes.
So, if there are any questions from the audience for Madam? Thank you, ma'am. That was a very good talk.
Thank you, ma'am. I request our chairpersons to felicitate our speaker. Thank you, sirs and ma'ams. We truly appreciate the chairpersons for their exemplary guidance and seamless coordination of the session. I request Dr. Ravi Makalini to do the honors for our chairpersons. Thank you, sirs and ma'ams. Moving further to a profoundly scientific and impactful session that delivers into the mechanistic core of the cancer treatment, targeting molecular cell signaling and reprogramming of metabolism for improving cancer therapy. Our distinguished speaker for this session is Dr. GAUTHAM. To chair the session, we are honored to have two eminent academic leaders, Dr. PAPINENI sir and Dr. Ph.D. I request the chairpersons to kindly arrive near the podium. I request Ms. Rashmi to introduce the chairpersons.
Dr. Ph.D. has pursued his MBBS from K.S. Medical Sciences, Nitty University, MD in Radio from Vaidhi Institute of Medical Sciences, Bangalore, and FRCR, UK. He is Associate Professor in the Department of Radio Diagnosis, Srinivas Institute of Medical Sciences and Research Center, Srinivas University. He is also serving as the examiner and member of the Board of Examiners for the Royal College of Radiology, United Kingdom, for final FRCR exam. We also have among us Dr. PAPINENI. He is an accomplished biochemist and translational medicine scientist with over 20 years of industry and academic experience. He serves as an adjunct associate
I request the chairpersons to kindly introduce our speaker, requesting Mr. Ashish Alwa to do the rapporteuring for the session.
Namaskar again. Professor GAUTHAM is a distinguished expert in radiation biology with extensive contributions to metabolic rate program, chemoradiation installation and radiation coordinators. He is currently associated with Indian Academy Degree College, Autonomous, Bangalore, serving as its research advisor. Dr. GAUTHAM completed his postgraduate training in NIMHANS, Bangalore, and earned a Ph.D. in biophysics from Bangalore University in 88. He undertook prestigious fellowship in Bowman Gray School of Medicine, Wake Forest, North Carolina, working in the lab of Ken Wheeler, a renowned radiation biologist. Back to India, he joined UNIVAS, Delhi, and where he served multiple scientific and leadership capabilities. In 2015, Dr. GAUTHAM joined Sri University as professor and contributed to various research programs. In 2017, he moved to Shanghai Proton and Ion Center in China, focusing on cutting-edge particle therapy and clinical radiation research. His career is marked by strong international collaboration, impactful translational research, leadership in developing novel therapeutic strategies to enhance cancer treatment. And on my side, Dr. GAUTHAM has been a good mentor for several students and postdocs who I know in US, and a great friend and a good speaker. Dr. GAUTHAM, it's 20 minutes, 15 plus 5 minutes. Thank you.
Thank you, Dr. Rao, for that very generous introduction. I hope the time starts now. Without much ado, let me just go. Dedicate this talk to my mentor, Dr. Jay, with whom I was associated for a very long time. Contributions from various places that I spent over the years, including the current affiliation as well as support from many places and collaborators across the world. I guess my talk is very simple. At several places I will skip through because that has been alluded to in the previous talks. One of them, I think, is just saw this cartoon a while ago with progress. The only thing I want to draw your attention is as the cancer progresses, it undergoes both metabolic as well as signaling changes, which actually become the target for therapeutics. Therefore, targeting the phenotype, the dysregulated proliferation of death, had occupied a great deal of time. They had all the non-specific drugs that somebody talked in the morning. That then brought us to targeting signaling, which Dr. Dhanalakshmi alluded to, a number of targets and the drugs, including the proteins, only mentioning. In the last about a decade and a half too, we have paid attention to strengthening the body defense mechanism in the immune system. That's the primary recognizing the tumor and mounting a response. I'm trying to fine-tune using one of the approaches that she talked about, down-regulating the negative effects of the ligand from the tumor that imports and the cells, the epithelium, So the signaling, which is multi-regulatory, that includes various components like the phosphatase, GTPase, kinase, and the secondary regulators, all play a role, and they're all altered due to a number of reasons like the mutations, genetic or epigenetic changes, as well as changes in the activation of regulatory pathways that regulate them. Finally, leading to the consequences of dysregulated proliferation, as well as survival, migration, invasion, and so on and so forth. I guess this is. So with this as the backdrop, because a lot of coverage has happened, I only focus on a few pockets. Some of the things that have not been discussed. One is the non-signal. Can I say something next to that word? Because you see it's jumping on its own. I'm not even. Pardon? No, go back 4. Because it's just. Okay, no, next. Okay, I'll say next. Okay, stay here. Wait, don't have to stay. The only attention that I want to draw, many of the things have been missed. There are innumerable therapies which have evolved over a period of time, and some of them which are under various stages of development. Both the established standard of care therapies as well as the emerging ones are continuously upgraded, continuously enhanced for their efficacy, and becomes standard of care at any point of time. Unfortunately, in spite of the refinements that have taken place over a period of time, both the therapeutic resistance offered by the tumor as well as off-target effects of the normal tissue toxicity continues to haunt the biomedical scientists, challenging the availability of an ideal successful cancer therapy. Therefore, we still continue to look for novel approaches. Next, please. And I'm going to focus only on a couple of focal points. One is the ordered signaling, again, 1 or 2, and reprogramming metabolism that has shown some promise. I have already done. Next, please. So there are a number of approaches to modify this signaling. Some of them are already in practice, some of them already in clinics, some of them already developing. Dr. Dervish may also talk about the PRATHAP, which we think probably will have a great deal of promise, particularly for the undruggable targets. The idea is to degrade them in situ using PRATHAP. Next, please. Next, please. So I'm going to talk about non-signaling the prolyl isomerase signaling under the program. Go to the next one, please. Now, this is one of the development signaling pathway, the co-signalings are wheat and the HR, and this plays a great deal of role in the intracellular interaction, shaping both the stemness, the proliferation, as well as the differentiation. Therefore, as one can see, will have a very important role in the tumor because after tumor develops similar to the development of an organ with some similarities as well as dissimilarities. NOSH happens to be an important signaling upregulated notch-weakened signaling influences the regulators of the cell signaling pathway, thereby conferring resistance. Equally, if not more importantly, therapeutically induced, the right side as you see, therapeutically induced upregulation of these signaling pathways leads to the recurrence by creating stem cells in the remaining cells. Therefore, the endogenous status as well as therapeutically induced status become an important issue or a challenge in targeting this signal. Next, please. So we then asked a question, Dr. Secretary was talking about carbonine, which is one of the particle therapies. And carbonine, although not highly accepted as a magic approach as compared to widely used photon therapy, has shown good clinical responses in few of the malignancies, although much desires to be done. The method of non-signaling, especially in case of radiotherapy, what is well established is radiation and photon therapy induces non-signaling that not only leads to resistance but also recurrence, particularly in gliomas. We also question, would carbonine, which has other advantages, would also be advantageous for photon therapy in not inducing non-signaling and therefore inducing stem signaling. With a bunch of gliomas cell lines, we investigated this. Results show that carbonine, unlike the X-rays or the photon-based therapy which is widely used from the granite, does not induce stem phenotype because it does not stimulate the non-signaling pathway like the photon therapy. So the extrapolation would be some of the better performances in the clinic by the carbon would also be partly due to the downregulation of non-signaling pathway which is associated with the photon therapy. Of course, what needs to be done next is. The other small piece of work that I'm going to talk about is proline isomerase. Most of us know that the protein, especially kinases, which play a role in a number of factors, including the oncogenesis and therapeutic response, involves many kinases. But many of the kinases are regulated further for their activation through a cis-trans conformer switching by an enzyme called proline isomerase. Many of the enzymes that are involved in proliferation are targets of PIN1. So, one of the questions that we asked was, can PIN1 be targeted as a therapeutic or as an adjuvant? Next, please. This is a cartoon showing how the PIN1, the proline isomerase, alters the cis-trans conformation at the phosphorylated proline and the proline peptide bond and changes from active to inactive and inactive to active form. So enzymes which are PIN1 activated are targets for some of the drugs, particularly the tropopoisons like etoposide, which is widely used in the anti-cancer therapy. Next one, please. This is a cartoon which summarizes the role of PIN1 in oncogenesis and many of the phenotypic characteristics of the tumor involved in several enzymes in the whole process. This level amongst the human malignancies are quite variable. Nevertheless, there is always an inverse correlation between the level of PIN1 and the prognosis. And therefore, PIN1 appears to be a target that needs to be recognized. Next one, please. We opine that since many of the most damage-causing response pathways are now modulated by kinases, can we, by inhibiting proline isomerase after causing damage, enhance them, and in some of the chemical chemotherapeutic agent which requires activation of the enzyme like I mentioned, topoisomerase, if we pre-treat cells with topoisomerase, can we reduce the efficacy? Would that work? Next one.
proliferation. That's how it works as an anti-cancer drug. If we pre-treat with etoposide and then come back, treat with prolyl isomerase inhibitor, that's what you know, then you will find that the fourth bar from the left, there is a great deal of cell. If you switch, if you pre-treat cells with PIN1 inhibitor and then come back and treat with poison etoposide, then the survival is phenomenally higher, suggesting indeed Topo 2 activation requires prolyl isomerase mediated conformation and change. However, the same thing is not true with gamma rays. We do know that conformation of any of the molecules for damage reduction is not a requirement. So this validates the fact that indeed PIN1 under appropriate conditions can be developed as a therapeutic target by designing specific drugs. Many drugs are in the pipeline, none of them have reached and stood in the clinical trials as of now. Next one, please. Now switch over to metabolic program and quickly browse through a few slides. Next one, please. So the reprogramming of metabolism actually which is known as enhanced aerobic glycolysis, altered lipid metabolism, and altered anaerobic metabolism. Primarily supports macromolecular synthesis, counters the redox balance that the emerging tumor faces, and also confers, most importantly, to the right you will see resistance to a variety of therapies. This phenotype is also known as the Warburg effect, that is enhanced aerobic glycolysis, has been exploited in the diagnostics, that is FDG PET scan. Since the enhanced glucose metabolism was well established, the idea was to see if there can be targeted using for therapeutic resistance could be enhanced DNA repair as well as alterations in the immune stages. Next one, please. Next one, please. This was transient. We then created an isogenic line from one of these cells and created a stable line which has a elevated glycolysis and moderate phosphorus. Then asked the question, what we saw with transient elevation of glycolysis would hold true for this one. The answer to that question is yes. This is almost replica. Go to the previous one, please. Stated. This shows the resistance to chlorogenic cell death that you will see in the past. Reduce the process, facilitate the DNA repair. You will see that the H2 kinetics is faster and also reduce more damage, reduce certain damage. And this is also true when we look at the FDG PET scan versus the clinical performance. What's the question? Would the conferring of resistance that we have widely seen against photon-based irradiation, which is the widely used therapy, also hold true for carbon ion radiotherapy or carbon ion irradiation? The answer to that question is no, as the title, which is showing that both the clonogenic survival as well as the other phenotype, like the migration, which is an important aspect in the diagnosis, because they don't metastasize but they locally invade, or not increase when you stimulate with glycolysis. For the migration. So both the local innovation as well as stemness is probably compromised. That could be contributing to somewhat a clinical better effect in some of the malignancies. Go to the next one. So the logical question is, if glycolysis is enhanced, should we be using glycolytic inhibitors? Go to the next one, please. People jump with this information way back in the 50s and 60s, used the glycolytic inhibitor 2-deoxyD-glucose as a therapeutic. Fair enough, they failed because the conditions under which you have to realize the benefit, that is continuous infusion, created very many off-target effects, and that had to be avoided.
So we then suggested, should we be using inhibition of glycolysis as an adjuvant rather than a therapeutic? Next one, please. That came from our understanding, in-depth understanding of the processes that are involved in damage response regulation in tumor and normal cells, both for radiation as well as a number of fatty acid drugs, whose primary action is both DNA and non-DNA damage. We then suggested appropriate design of a regimen of damage causation and glycolysis inhibition should improve the therapeutic efficacy. Next one, please. This summarizes the work from many of our labs, our work, and also our collaborators. A number of monolayer 3D models that the repair is compromised, mitotic as well as interface deficit cancer. And in case of animal tumors, the tumor regression or the local tumor improvement as well as animal survival is equal. So this validated the fact that inhibition of glycolysis coupled with primary anti-therapeutic like radiation and chemotherapy should be good. This is at the cellular level. That's what this is. The complete mechanisms underlying this is also addressed in great and is available as reviews at all the several places. But in case of 2DG, I'm stressing again, not all the glycolytic inhibitors, but in case of 2-deoxyribonucleose, there is also a non-glycolytic link contribution of the efficacy. You see on the right side, its ability to modify end-link glycosylation and therefore alter the UPR, the unfolded protein response. Therefore, in case of combinational therapies using 2DG as a glycolytic inhibitor, you have the advantages of glycolysis link alterations as well as glycolysis independent actions leading to loss of chemotherapy selectively increases. Next one. We then asked a question, what would be the scenario from all the evidences that we have in vitro? So we took note of the TME, which has several cellular components like the fibroblasts, the adipocytes, and a variety of immune cells. We, from our own work and from some work of several others, particularly Jeffrey Rathman from Bill, show that there's a great deal of metabolic cooperation and competition for the immune state, for the energy as well as metabolism in the TME. This was summarized in that. So with these, especially the imposition on the MRP would then lead to implications on the T cells, which are a major anti-tumor active immune component in the TME. Therefore, we could 2DG influence the immune system when we combine anti-therapeutic, that is radiation or chemotherapy, that would contribute to enhance local tumor control. Next. So I'll summarize all this with only the points Abdullah showed. Indeed, it actually enhances the anti-tumor immunity by altering several components of the immune system, selective depletion, and TH2 to TH1 switching, TH17 to TH16, and reduction of the Tregs, which is an active influence. And then went on to show that under the conditions of focal irradiation of the tumor and the glycolysis inhibition with 2DG, you also have a M1 dominated phenotype that would also contribute to the local tumor control. Yes, please. Then also a question. All these things were done by a bolus administration of 2DG to the animal following irradiation of the tumor or addition. Then also a question. If we administer 2DG through the diet and maintain a very low circulating level
Professor PhD, and its metabolite might be what are the consequences? Such showed that animals on PhD as a component to that have reduced granuloma injection by DMPA, reduced 3-beta-glutamine-induced as well as radiation-induced leukemia, suggesting that altered metabolism during osteoporosis will lead to reduced tumorigenesis. Next, please. And this is contributed among several things in reduced angiogenesis under these conditions. Even more impaired clearly the angiogenesis that contributes to the tumorigenesis. Next, please. This we summarized just a few years ago as to how 2DG systemically administered along with radiation to the tumor radiation alters the immune system that contributes to the local tumor control and transport. It actually obviates the immune suppression that is caused by the T regulatory cells which are all increasing the TMP leads to depletion of the immunosuppressant network. We have presentation of this type, these type, Tregs, PSCs, they're all reducing the suppression and that contributes to the local. That's the macrophage polarization part of it. That's what listed. And it is the putting of those is in. So our clinical trials with the phase 1, phase 2, and phase 3 show that 2DG as an adjuvant in the radiotherapy of glioma does lead to tumor necrosis coupled by the preservation of the normal tissue. This is some evidence from one of our earlier clinical studies where Dr. Venkatram was involved. Dr. Nagaraj, who is here, is Dr. Venkatram now, has also been a part of this clinical trial. And interestingly, this was the first IND drug, but not first IND application, but not the first IND approved. We got it approved much later, thanks to a number of hurdles that we had. And the whole summary of this is, if you target the glucose metabolism appropriately, both in terms of the dosing as well as regimen design, you could have the tumor control as well as reduced fermentation toxicity. This concludes the topic, but I want to show one slide before I get up. Next one, please. Next one, please. Currently, we are back where I am associated. We are in the process of actually developing optical biosensors using approach the source from animal waste and citric acid the source from biological waste. We have quantum dots which are coupled with Christian doping and are amenable to analysis by absorbance, fluorescence, Raman, and plus surface plasmon measurements. This is patented as of now for doing the installation. We are very happy to collaborate with anyone, especially those who like to request that will make the product for them. We got no right to go to the last slide. Next please. Thank you for your attention.
Thank you very much. Questions will be taken during the meetup. Because the thank you again. Over to.
Thank you, sir. I request the chairpersons to felicitate our speaker. highly insightful and clinically significant, titled Advanced Diagnostic Facilities in Radiation Therapy. Our speaker for this session is an eminent radiologist, Dr. RAGHAVENDRA. I request Dr. PAPINENI and Dr. Manish Shetty to chair this session and introduce the speaker.
It's my privilege to introduce our next speaker. We have with us distinguished and well-renowned speaker and radiologist, Dr. Raghav, who will be speaking on the topic of CT scan in oncology imaging and radiation dose reduction techniques, an increasingly crucial topic in modern day onco imaging as we go on integrating highly sophisticated diagnostic tools to improve patient outcomes and care. Dr. Raghav is an MD in radiodiagnosis, a senior radiologist and academician currently serving as a professor and head of the department of radiodiagnosis at SINGH Medical Academy, Mangalore. With an extensive academic and clinical career spanning 17 years, complemented by 16 years of administrative leadership, he has significantly contributed to medical imaging education, departmental development, and professional radiology practices. He completed his MD in radiodiagnosis in the Medical Council of India and has since established his expertise, particularly in the field of head and neck imaging. His research contribution includes a growing portfolio of publications comprising of 2 international papers, 11 national publications, and 5 additional scientific works, reflecting his commitment to evidence-based radiology and clinical problem solving. Dr. Raghav has been an active participant and resource person in scientific forums, delivering invited lectures in national conferences, higher state conferences, and numerous institutional academic programs. His professional leadership activities include serving as a vice president of the IRA Dakshina Kannada chapter and heading the acclaimed Department of Radiodiagnosis at SINGH. At present, he is a member of the Shema Center for Genetic Services. He is also a radiological consultant at DLG Clinic and an external expert for faculty recruitment of Mahé University. Additionally, he serves as an external board of studies member of the Department of Radiology at Edinburgh Medical College, further contributing to the curriculum development and academic quality. Throughout his career, he has actively supported interdisciplinary collaborations, mentored residents, and enhanced diagnostic radiology care. His academic contributions, administrative roles, and commitment to clinical excellence continues to advance radiological science and medical education regionally and nationally. Over to you, sir.
Good evening. Thanks so much for the wonderful introduction. Also, I thank Dr. Professor Sajita Madam for giving me this opportunity and her team for this wonderful organization of the CMA. So without wasting much time, my talk is very simple, and I'm just going to tell the role of CT in oncology, most of us know, and what are even techniques which can help in reducing the radiation dose to the patients. So it's of most important because of the growing imaging sense and the clinicians. So every time when I'm asking for the CT scans, so we should be actually aware of how much radiation we are giving to the patient. Now, so with the oncological imaging, what we have to answer is, first it has to be a good screening tool. We need a CT for staging, and we need a CT for again to see the treatment response, the tumor reduction, cytoreduction. So again, the patient comes back with the recurrence. Again, the CT is the modality most commonly used, and to some extent we can also predict the prognosis based on the biological behavior of the tumor, which is seen as the contrast enhanced lesion or involvement of surrounding structures, which can tell us the clinicians can tell about the prognosis of the disease. Now, so with this, the detection of tumor in metastasis, CT has a major role. So staging I have already told. It has also role in the guided biopsies, where earlier the biopsies used to be blind biopsies where the tumor used to be missed And now the most of them are more precise biopsies either by ultrasound or CT guided, wherein you take the proper tumor tissue and the tumor cannot be missed. So that is the advantage of CT guided biopsies. And as we know, it is also helpful for planning a radiotherapy as well as a roadmap before the surgery. Now, so it's a CT is a suitable modality for early detection. So it is capable of distinguishing between the normal and the tumor tissue. So that is why CT is very helpful. And the most widely available imaging modality and also used more commonly for the follow-up. So we all know the physics behind the CT. So we'll have the gantry which has the X-ray view and the data row, and the console is the operating console which actually plans and executes and reformates or brings up the images. So the basics all of us know. It's an X-ray beam which rotates around the patients, developing multiple slices and reformatted into develop a final image. And there are 3 steps, wherein first step the X-ray beam passes through the body, and the second step is converted into the digital image, and finally the grayscale image is produced based on the attenuation of the tissues. So if you see the development where from the first generation of CT to now, we have moved on to now it's here of multi-slice CT, wherein you can see that the beam of the width of the X-ray is also increased and the number of detectors have increased. So basically, the exposure of patient is increased, but the image quality is much improved. So the meaning is that we have probably advanced much in terms of the image quality, but compromise a little bit on the radiation exposure to the patient. And later I am going to tell about multi-phase as well. So one more thing is the contrast CT, wherein we inject the solution containing iodine particles into the intravenously and then to the CT. So the plain CT is the one which is done without giving any intravenous contrast material. Following the contrast, we do usually 2 or 3 stages, that is called phases. One is arterial phase, when the concentration of iodine is maximum in the arteries, and second, when the concentration of the contrast is maximum in the veins, and lastly, it's a delayed phase, usually following 3 minutes or more than that. So this contrast study is usually multiphasic. So you can imagine the amount of radiation given to the patient. So with a single lane study, and it is more 3 or 4 times more than that when you do the multiphasic study. So that is where we have to judiciously use the contrast study and the phasic studies. So just for an example to show how the plane and contrast study differs, the contrast study usually helps to show you the vessels which are supplying the tumor, and it will show us the tumor biology, where the tumor is increasing, growing, whether it is going to the surrounding organs or there is a central necrosis developing. All this we can make out after giving the contrast. So that's the difference. So in case of tumor imaging, the contrast study is a must, and most of the time we end up with doing the multiphasic study, arterial, venous or a delay. So this is how the contrast helps. You can see that the tumor is seen better, the surrounding structure are shown better, and only the problem is that when patient is allergic to iodinated compounds, we can't use that. We have to see for some alternative modalities, and there is a high chance of getting allergy, but even the contrast materials, the chance of allergy is very less. So those individuals we can't use the contrast study. So the advantages of CT are that I have already told is widely available, and it gives a very good resolution to distinguish from the surrounding tissues. So we can do the volumetric assessment of the tumor size and to actually to the follow-up scan where we can see whether tumor reduction has taken place or not. And the whole body imaging is possible. The whole body CT is now not commonly used because we have other alternative techniques, because we can do that with either MRI or ultrasound part by part. Because in CT it was a lot of radiation. What we usually from the radiology side we suggest is that the region of interest should only be subjected for the CT scan. Suppose a lesion is there in the liver, then for all that multiphasic study we should involve only the liver. So rest of the body, either rest of the abdomen or chest should be done only once, should be imaged. Either in the venous phase or only once when you want to see the metastasis. One venous phase, taking entire the cuts from thorax to abdomen is more than sufficient. But these things are not standardized. If you see most of the scanning center, what they do is from beginning plain phase to the delayed phase, they take from top to bottom, which is totally wrong and unethical, exposing the patient to a lot of radiation. So you can just see here, just an example, how good the CT scan shows the tumor invasion, and we can change the window just to see the bone, where the bone is eroded, it's going through the sinuses. So all these informations are better seen on this is an oral carcinoma, where you can see that the cancer growth is going to sinuses, then also it is eroding the bones. So that's the advantage. So this is another case of CL larynx, where you can see the airway is totally obstructed here. The patient has a tracheostomy tube and very nicely showing the tumor obstructing the airway. So one more case of lung cancer. You can see a large tumor in the right lung there, and this is the lung window where we can see the metastasis nodules. And this is the brain lesion which has metastasized to the brain. So just for this example, I would say that this patient actually requires one arterial phase and venous phase just to see the thorax. And you want to see the rest of the body, abdomen, liver or a brain we can include in a venous phase. That is more than sufficient to tell us that lesion is there. And sometimes you see a lesion in the arterial most of the time in these lung carcinoma patients. So if you go back and see that lesion in an adrenal or a plain CT with the contrast, we can actually, what we check is the density of the lesion. And on that plain study, if the density has a more of fat density, we can see that it's totally a benign lesion. It is not a malignant lesion. So we should not run another contrast phase through the abdomen. Once we are convinced that it is probably a benign one, we should not over-investigate or overexpose the patient for the radiation. So this is another advantage where you can bring up the vessel supplying, the relationship of vessels, everything can be shown very well on a CT study. Now, so this is the virtual colonography. So you know how much it's invasive when patient wants to undergo either a bronchoscopy or a colonography. So all the process which is involved. So the same thing can be derived from the CT. So it is least invasive or non-invasive procedure to the intraluminal lesions in the colon or in the bronchial. So all can be shown. Now the CT guided biopsy, as I told you already, an excellent modality where you can precisely needle the lesion, take the core from the center of the lesion so that you won't miss the diagnosis. So that's another advantage. So because if you do the blind biopsy, the patient might go for the normal report might come to be negative, or if patient develops a complication, that also we can make out. Now coming to the disadvantages. So I'm going to focus a little bit on this in 5-10 minutes. So we know that CT involves the ionizing radiation. So we should look for alternative modality, especially when patients are pregnant, the pediatric age group, where we can make out the lesion with the other modality, we should go for that. I'll give just a few months back, one child, about a 1-year-old child, came for an ultrasound with a large abdominal tumor. So first instance, we had no other way, we have to do a CT. But subsequent follow-ups following chemotherapy and the surgery, actually from the surgeon side, they wanted a CT. So we actually, till date, we have done 4 follow-ups, and without even doing a single CT, we could manage it only with ultrasound and MRI. And we could see the tumor reduction on both these modalities. And that is how we can totally avoid the radiation. So there should be a close discussion between the referring physician and the radiologist, and to decide which is the best modality so that patient gets the least radiation. And the interdepartmental discussion is most important in these cases. So the contraindications I already spoke about that. And now moving on to the, just to show you that how much radiation it can give. So you can see that just a chest X-ray, the very least, and you see the CT abdomen or a coronal CT where you can see the maximum exposure. So this is how compared to the background radiation. So you can see that abdomen and pelvis about 10 millisieverts and accumulated dose over 3 years. So this is how we should be very careful when we are looking for a repeat imaging in the cancer patients. So especially because other patients we don't do follow up so much. So all this, the malignancy patient, they require again and the repeated imaging. So we should be very careful in subjecting them for a repeated CT. Now moving on to the, so the dose exposure. So there is something called, most of you might be knowing, the volume computed tomography dose index. So nowadays, with all the newer machines, we get this information at the end of every study. Though the radiation factors are calculated on a phantom, but it is very important to look at them. So it is basically reported in the units of milligray for either 16 cm or 32 cm acrylic phantom. And for the same CT technique, CTD volume reported for 16 cm photonics twice that of 32 cm. So you can imagine a smaller body parts when subjected to get more radiation. And so that is what this says. And there's one more called dose length product. So this gives you the exact the note on how much of radiation the patient would have received. So DLP is a product of length of irradiated scan volume and the average CTD volume over that particular distance. So we have to, the end of the examination, so this report will come, and most of the countries like US and UK now have made it mandatory at the end of your CT report, you are supposed to document what was the cumulative dose patient received. So this information is most important because this should be shared with the clinician, this should be known to the radiologist who is exposing him again, or patient also should be aware of that. Now moving on to the, so this is how it looks. So at the end of the study, last page, you will get this report of how much exposure patient has received. Now, the CT radiation exposure, you can see that globally there is a twofold increase in the CT from 2006 to 2016. And concerns regarding the radiation exposure, patients undergoing repeated CT, loss I told you. So CT and nuclear medicine imaging together accounts for about approximately 75% of cumulative effective radiation dose. That is why the justification for the investigation and optimization of the technique where we can use a single phase study or a selected phase of study, all these things are, and guidelines adherence for a proper protocol, all these are very important. Now, so how we can reduce, because there are a lot of inbuilt technology in the CT itself to reduce the radiation, like adjusting the tube voltage and current, using automatic exposure controls. Then we have faster table speed, increasing the pitch. Suppose I am not looking at a very small lesion, this is something but it is a larger lesion, so I can do with a larger coverage, and the area covered can be large at a short time so that exposure is reduced. And you can shape the X-ray beam to reduce the exposure, the accurate patient positioning, and limit the phase. I am just going to that. So there are some more things which can be done. The dual energy CT is another thing which has come up very largely and which helps in reducing the CT dosage. Against the conventional detectors, we have the photon counting detectors which are much more effective than the routine detectors which are used nowadays, and they can be more precise and more accurate, more clear image compared to the conventional detectors which are being used. And protection of sensitive tissues is again a major concern. So we have to do this methodically. Dose tracking and dose management software. So as I told you, at the end of the study, we get that dose report that has to be endorsed in the patient's CT report, and the clinician also should have that knowledge, and there should be a software system to track the dose of the patient where it can be limited. Now, this is how the automated exposure control reduces the tube current. So you can see certain body parts are very thick, the bone is very thick, so those areas will require more exposure, more tube current, whereas thinner parts require less current, so that it automatically modulates the current and reduces the dose. So once the current is reduced, the radiation exposure is also reduced. So this is just to show you the smart image, where you can see that the position 1 and 4 shown there, there's a difference in the exposure. The part 1 and 3, those areas you require less radiation, whereas 4 and 2 you require more radiation. So that has to be modulated. And also there are something called as organ dose modulation, where in the anterior 120 degree it reduces the radiation dose by reducing the tube current, so that the vital organs like thyroid, breast, gonads are saved, or they protected from the extra exposure. Now this is how you can see the two techniques similar, but you can see that the 120 kV voltage and the 100 kV voltage. So less voltage, less radiation, but see the image clearly, not the deteriorated. So the many studies have shown that reducing tube potential can reduce dose while maintaining the image quality. So we have to see or calibrate at the particular center where we are doing, and then we have to use the judicious use of the energy voltage. Now this is how the pitch and the radiation goes. The faster the table movements leads to the low radiation dose. As you can see, pitch is more to the exposure is less. As the pitch decreases, there will be more overlap of the X-ray beams and more exposure of the patients. So when required only, suppose I have a lesion in the liver, so that area should be subjected to the lower pitch. And I'm interested to see the metastasis in the lungs, I can use a larger pitch so that the entire area is covered. Same time I won't miss the lesion. Now this is how the pitch affects. So we can see that the pitch increases, patient dose, and CTDA as well as DLP reduces. Now ultra low dose CTs are available, wherein you can use very low dose CT, especially for the lungs. When you are suspecting some metastatic lung nodules, or a malignant patient who is undergoing treatment as developed pneumonia, our interest is to just to confirm that he has a pneumonia. So we should not go for a routine CT, we should go for a low dose CT, which can manage the work which is required. So it can reduce a lot, and this is about the patient positioning. As you can see, that when the patient is very close to the tube, the exposure is more. You can see that 25 CTDA. If the patient is at the correct center of the gantry, this all out based on the technician positioning. So, if the radiological technician is aware of this, then he will do that. Others will not do that. So nowadays, what we have got is the companies are coming with the camera and AI assisted position, where it will tell you exactly whether the patient is in the ISO center, and that is very helpful. The fast meaning fully assisted scanner technology, wherein it actually helps in the AI-based camera, which helps you to place the patient in the ISO center. So again, these two things are also important: image and phase grip. The image grip means, suppose there is a patient has a lesion in the kidneys. So there is no point in exposing the patient for all the four phases from diaphragm to the pubic symphysis. Our area is to look for the kidneys. We have to restrict all phases to the kidney. The rest of the organs to be covered once in one phase, so that we can significantly reduce the dosage of the patient. And the same with the phase. I told you that when we want to evaluate the primary tumor, yes, we need to look for all the arterial phase, venous phase, plain, delayed, whatever we require. But we will not evaluate the metastasis in the entire body. There is no point point in exposing entire body for the all four faces. So those things should be covered. So that is what actually mean to say image and face clip. We have to restrict to the region of interest. We have to restrict number of phases of study that can reduce the radiation significantly. So this is the dual energy CT, wherein it will help in enhancing the contrast between the tissues, and it also gives the less radiation. And this is what I told you, photon counting detectors. You can see that the efficiency of the detectors are much more signals are obtained, and less distortion, more crisp images. So that is the other thing which is there. And iterative reconstruction, earlier we have something called the back projection, now we are using iterative, that again reduces the dosage of the patient. So you can see that from compared to the previous, there is a 50% reduction in the radiation dose with the iterative reconstruction. And the use of shields, nowhere it is done. I'll just take one more minute. So this is the most important thing. If the technicians are not aware, you yourself must insist, especially in a pediatric case, when the imaging is taking up for a CT chest or an upper abdomen, the gonad should be completely covered, wrapped. The lead sheet should be wrapped all around the pelvis so that the gonads are protected. We also have this whisper shielding, which is available for the legs as well as for thyroid and the breast, which are the most sensitive organs for the radiation, especially very useful patients who are undergoing repeated CT or follow-up. Now, dose tracking, this I have already told, so there should be a system wherein all the CT reports should endorse basically how much dose the patient has received. The information should be shared with the clinician, referring clinician, and also the reporting radiologist. And there should be a software which gives the trend of the exposure of the radiation. So, to conclude, of course, the CT is the ideal modality in terms of tumor detection, early detection, the metastasis workup, also for guided biopsies and planning of the radiotherapy or the roadmap for surgery. At the same time, the concern should be given to the radiation exposure as well. So the technical innovations are going on, but along with that, practical techniques which I told you, with the responsibility of the radiologist and the technologist who is performing the CT, and patient dose tracking and education of the staff as well as patient regarding the radiation exposure is most important. Each and every practitioner can't just write CT head, CT chest or CT abdomen. There should be a justification for that, and there should be a justification for the repeated surgery. Thank you. Any questions? Thank you.
Thank you, sir, for an insightful and informative session on CT principles and advances in ongoing aging, and more importantly, dose reduction techniques. Due to time constraints, we'll have the Q&A session in the tea break. Thank you.
Thank you, sir. I request the chairpersons to kindly felicitate the speaker. and ma'ams, a sincere note of appreciation to our chairpersons for their expert guidance and smooth coordination of this session. I request Dr. Mithil S. Acharya and Mrs. Sushmita S. Kotil to do the honors for our chairpersons. Cardiovascular medicine and computational science. The topic for this session is unveiling the pathogenic impact of mutations associated with cardiovascular diseases using computational approaches. We are honored to have with us Dr. Rajas M. Rao. To preside over this session, we are privileged to welcome two esteemed chairpersons, Dr. Satish Chitneni and Dr. Nagaraj Muliu. I request Ms. Rashmi to introduce the chairpersons.
Dr. Satish Chitneni is an associate professor in radiology, basic sciences at the University of Chicago, specializing in the development of molecularly targeted radio tracers for non-invasive imaging and radiopharmaceutical therapy. His research focuses on creating advanced probes for PET imaging and targeted radionuclide therapy using diverse molecular scaffolds such as small molecules, peptides, antibodies, and radioisotopes, including fluorine-80, radioiodines, and zirconium-89. His research involves close collaboration with clinicians, chemists, biologists, physicists, and pharmacologists. His work appears in leading journals such as the Journal of Nuclear Medicine, Bioconjugate Chemistry, Bioorganic and Medicinal Chemistry Letters, and Clinical Gastroenterology. Overall, Dr. Chitneni is a prominent researcher in radiopharmaceutical development and molecular imaging, advancing precision diagnostics and targeted therapeutic strategies through innovative radiotracer technology. We also have with us Dr. Nagaraj Muliu is a highly distinguished radiation oncologist with over 43 years of extensive experience, currently practicing at Nanavati Max Super Speciality Hospital, Mumbai. His qualifications include MBBS, MD and DGO. He is widely recognized as a leading expert in advanced radiation therapy and hypothermia oncology. Dr. Muliu has made substantial research contributions with published papers in areas such as diagnostic markers for HNSCC, spatially fractioned radiotherapy, head and neck cancer outcomes, breast tumor SAR analysis, and clinical hyperthermia applications. He has been honored with national awards including the Haldar Memorial Oration from the Association of Radiation Oncologists of India. With this brief introduction, I welcome you both, sir.
I request the chairpersons to introduce introduce our speaker, requesting Mr. Abhishek to do the rapporteuring for this session. The speaker is to kindly note that the first bell will be rung at 15 minutes and the second at the end of 20 minutes, by the end of which the esteemed speaker is humbly requested to conclude the talk.
So, good afternoon everyone. Good afternoon everyone. I'm Rajas. I'll be talking about unveiling the pathogenic impact of mutations associated with cardiovascular diseases. We've had a lot of illustrious speakers giving a lot of informative and interesting talks about oncology and cancer therapy, but we'll be changing gears here and we'll be talking about cardiovascular diseases in this talk. So cardiovascular disease remains one of the most serious health challenges in India. It affects more than 5 crore individuals. Of course, lifestyle is a major risk factor here, but however, there are numerous genetic factors also contribute to the disease, meaning there are many individuals who have certain mutations, certain single nucleotide polymorphisms, where the presence of those mutations and single nucleotide polymorphism is strongly associated with the development of cardiovascular diseases. So, however, how exactly these mutations contribute to the onset and progression of cardiovascular diseases has not been studied so far. It is quite unknown today. So this comes to the objectives of our project, which was to understand how certain selected mutations in certain proteins which are responsible for maintaining the cardiac homeostasis, how mutations in these proteins contribute to the onset of various types of cardiomyopathies. So to this end, we utilize computational approaches, we utilize different computational techniques to map the molecular mechanism that is associated with the mutations and their contribution to the onset of cardiovascular disease. Next slide please. Yeah. So before I take you to the methodologies, I would like to introduce you to the technique of molecular dynamic simulations. So MD simulations is a purely physics-based technique. So what happens here is we take a system of particles, we solve Newton's equations of motions where we assign velocities on the system of particles using the Newton's second law of motion. It undergoes a certain acceleration. Now when it undergoes that particular acceleration, we solve the Newton's equations of motion, which gives rise to new positions of our particle. So here our particle is the protein in the question, and we do this millions of times over and over again. So in the end, we ultimately get what is like almost like a movie of the protein, as you can see in the right part of the slide. So now we do the same thing for the wild type of the protein, wild type variant of the protein, as well as in the mutant variant of the protein. So this will enable us to really see what is happening in the wild type variant of the protein and what is happening in the mutant variant of the protein. So having that in mind, of course there are many proteins which are involved in cardiac homeostasis, and there are hundreds of mutations which are documented in individuals, and many of them contribute to the cardiovascular disease. But then comes the question, which proteins to choose, which mutations to choose. So for that, we used a certain criteria where we selected the proteins where the mutations documented have high association with the pathogenicity. So to judge what is the pathogenicity of the mutation, we used a type of previous slide please. Yeah. We use a type of measure called as CAT score and qualifying score. Both of these scores tell me the likelihood of what is the chances a particular mutation is pathogenic or not. So we focused on 3 particular proteins which are very essential players in the process of cardiac homeostasis. One is the titin. Titin is basically the protein which interacts with the sarcomere proteins, and it enables the contraction of the muscle. And the second protein is the VAV2 protein. It maintains the cardiac homeostasis by regulating the angiotensin-renin cascade. And the third protein is a protein called as KCNQ1, which is basically a potassium voltage gated ion channel. So this this regulates the heartbeat and cardiac cycle through conductance of the through transport of the potassium ions across the membrane. So we selected these the three proteins, and these three proteins have three mutations. One is D60Y for the titanium protein, I818M mutation for the VAB2 protein, and P448L mutation for the KCN1 protein. So another reason why we choose all these proteins and mutations is that all of these mutations have been documented by previous studies that they have high association with various types of cardiovascular diseases. For instance, titin has high association with the cardiomyopathy. KCNQ1 protein has high association with the long QT syndrome, which is a type of cardiac arrhythmia. So now we model the wild type variant as well as the mutant variant structure of both the proteins. And once we do that, we selected these proteins based on the mutations and pathogenicity scores. We modeled the proteins. We performed the molecular dynamic simulations as how I explained in the previous slides. And once we did the molecular dynamic simulations, we performed analysis of the simulations to try to find out what's going on in the wild type protein and the mutant protein. So first we focus on the titin protein, and when we looked at the simulation trajectories of the wild type versus mutant titin, we noted that the wild type titin is much more rigid, while the mutant titin protein is much more flexible, or it is the mutant titin protein is much more destabilized. So what does this mean when this gets destabilized? One of the important features for the titin protein is it contains numerous proline residues which are evolutionarily conserved. So the role of these proline residues is since the titin is involved in muscle contraction through interaction with the sarcomeres, those proline residues, they sort of act as a spring. So once the proline residues, when it's able to flip between the different orientations, so that flipping mechanism gives rise to a spring-like action, which results in the muscle contraction. So now when when those residues are destabilized, it won't be able to do that particular flipping dynamics. So the same thing we observe here in the mutant form of the titin protein. The proline 52 residue, which we can see in the red peak over there, is highly destabilized compared to the wild type protein. So this suggests that this particular destabilization, which is induced by the mutation, results in the suboptimal contraction of the muscle, which would further lead to the development of cardiomyopathies. Next slide. So next we move on to the next protein we checked it, which was the VAB2 protein. Like the titin protein itself, like the titin protein as well, even in the VAB2 protein we found that the wild type protein was much more stable, while the mutant variant of the protein was highly destabilized, the I1818 mutant. Particularly if you look at the second figure, the VAB2 protein has numerous regions which has different types of activity. Particularly the second region, which is colored in the yellow, which is colored in orange, which is called as GEF domain, is the region that is responsible for catalytic activity of VAB2 protein. So we can see that compared to the wild type variant of the VAB2 protein, the mutant variant of the GEF domain is much more destabilized, where we can see the fluctuations as high as 7.5 angstroms. So again the mutant in the mutant variant, this particular domain is destabilized in the VAB2 protein. Now what is meaning of this destabilization of this particular domain? So to further understand that, we calculated the cavities in the VAB2 protein, in the wild type protein versus in the mutant protein. So why did we focus on the cavities? Because whenever a protein performs a function, it's usually whenever, let's say, a protein is performing enzymatic catalysis, it requires certain cavities where the substrate can go and sit on the protein. So if we have a big enough cavity, then the substrate can easily go and sit on the protein. It will perform its function smoothly. Now if the cavity is much reduced in the size, then the substrate won't be able to sit on the protein and the catalysis will be suboptimal. So this is exactly what we see in the VAB2 protein. So we can see the wild type protein, which is in the top two figures. in the MD simulation trajectories, we see that the cavity is quite large, sufficiently large so that substrate can easily go and sit on the wild type protein. So where we can see that the cavity size is around 8,000 cubic angstrom in the simulation trajectories. Now when we compare this with the mutant, we can see that there's a significant reduction in the size of the cavity. So when the cavity size is reduced, then it means the substrate will find it much more difficult to sit on the protein, and as a result the enzymatic activity of the protein will be reduced. So now in context of the cardiovascular disease, what does this mean? So basically VAV2 regulates the cardiac homeostasis through inhibiting PD activity. So what happens if the PD activity is not inhibited? The PD activity will upregulate the renin-angiotensin system. So it will overexpress the renin-angiotensin cascade. Now VAV2, what it does is it controls this renin-angiotensin cascade by inhibiting the activity of PDE. So when in the mutant, if the VAV2 is not able to inhibit the activity of PDE, the renin-angiotensin system is hyperactivated, which ultimately leads to increased hypertension. So this is how this particular I818M mutation leads to the reduced activity of the VAV2 protein, which ultimately results in the increased renin-angiotensin cascade and ultimately results in the development of hypertension. So then we move on to the try to find out what's going on in the third protein, which is the KCNQ1 channel. So like I mentioned before, KCNQ1 is a membrane protein. It's a potassium ion channel which transports the potassium ions across the protein, which this transport mechanism ultimately leads to the smooth functioning of the heartbeat mechanism. So here we try to find out what's going on in the wild type protein versus what's going on in the mutant protein. So we found that again to find out if the potassium channel is able to transport the potassium ions or not, we measured the cavity size. So we found that in the wild type protein, the cavity size is sufficiently large. You can see that the cavity size, which is in the blue surface, is much larger than which amounts to around 2,600 to 2,700 cubic angstroms. Now in the mutant, initially in the simulation, we found that the cavity size is slightly larger than the wild type, but as the simulation progresses further, we found that the cavity size is significantly reduced in the mutant form. Now what does this mean? When the cavity size is reduced, again in the potassium channel, the main role of potassium channel is to make sure the potassium ions pass through smoothly through the potassium channel. In the mutant form, because of this reduced cavity size, the efficiency of the ability of the potassium ions to pass through this channel is greatly reduced. So this reduced ion transport efficiency ultimately contributes to the onset of long QT syndrome, which ultimately is the form of cardiac arrhythmia. So to finally conclude, we chose the three proteins which are important parts of the cardiac homeostasis, and for the first time we proposed the atomic level explanation about what exactly is happening in these mutations, which ultimately lead to the onset of different forms of cardiovascular diseases. So ultimately the results from these work offer important insights into how the pathogenic role, what are the pathogenic roles of these mutations. So these results, we hope that these results will further make way for the development of precision medicine based approaches which can be used for diagnosis of the cardiovascular diseases. Perhaps we hope that these mutants can serve as biomarkers for early diagnosis of these cardiovascular diseases, and we hope that this will also help in the early screening of disease as well as their therapy. So with this I conclude my talk, and these are the organizations and people I would like to acknowledge. I would like to thank the Srinivas University for giving me an opportunity to present my research here. I would like to thank my parent institution, Inagwa University, for providing the financial resources, as well as the CDAC facility provided by the Ministry of Information Technology. I would like to thank my collaborator, Dr. Ranjit Das, as well as the 5 students. So I would like to mention that all of this work was done by the undergraduate MSc students, which goes to show that if we have students who are enthusiastic enough, they can actually do quite wonderful job. So finally, I would like to thank all of you for listening, and I would be happy to take any questions.
Thank you, Dr. Rao. That's very interesting and impactful research. Given the scale of the ideas and the analysis. We have a few minutes for questions. Any questions from the audience? Okay, I'm sorry. So it seems like we are out of time. Thank you again.
Thank you, sir. I request our chairpersons to felicitate our speaker. Thank you, sir and ma'ams. We now move to the most pressing health challenges of our time. The topic for the session is underconsumed or The topic for this session is underconsumed or underappreciated essential nutrient, a hallmark of metabolic syndrome. We are privileged to have with us Dr. Suresh Babu. I request Dr. Satish Shipneni and Dr. Nagraj Muligor to preside over this session and introduce the speaker.
Hi again. So it's my pleasure to introduce the speaker, Dr. Suresh Babu, SV. Yeah. So Dr. Suresh Babu is an experienced biochemist and clinical research professional with about 3 decades of expertise across clinical biochemistry and diagnostic research education and mediation academic leadership. He's currently serving as head of bioinnovation functions at SSA Innovation and Innovation Council, and he's also a PhD chartered as scientific research laboratory to start medical college and Rizal Academy of Higher Education. So with that short introduction, I give the floor to Dr. Suresh Babu for
living out our association with go at the thought of our
resistance, ultimately leading to the development of equivalence. But still, what is the reason which you are not knowing whether you are taking a case to find a new list? That's what is happening. There are various strategies to treat the disorders, but still we are not able to overcome the problem. So that's the reason. Thinking about that, what are the nutrition supplements? Specifically, we have given appreciated under the nutrition. Most important. So WHO estimates that 65% of the deaths worldwide are associated with three leading causes: ischemic heart disease, stroke, respiratory disorders. But still, as I indicated, Indian report says that 7% less and 26% deaths in 2020 when compared to 15% globally. So we ask that the sufferers are more in India and not country. That is the investigation we have concentrated and look for something better than finance solution. So we know that all of us know that only we have studied about it, like a Prof. Always incorporated related question. All the teachers used to ask, so but still, always we neglected it. And always there are debate that whether we include in a vitamin category, but still it has not been discussed or severe understood in severe diseases. We know that nowadays all the experience are changing eating patterns. So we can see that region to region varies. So Kerala we eat and Andhra state rice, but still they are not able to that much diabetes. Since you could see that. But so what is the reason? So there may be something you have seen that long-term observation studies which are all the habit of lifestyle, eating habit, something you have seen that don't something like that. So how I plan is, let us say, if you are eating rice, element of proportion, rice, protein and lipids. But now let us say to the pizza, it is almost you are eating cheese, or not eating enough stuff, you are eating it. That is the problem. Whether the nutrients, supplements are sufficient to take care of the metabolism, that is the most important. So that is why we talked about only to study as we made it as another study. We know that the fascinating and interesting that this is most of the time, you are all refined food, all refined food. Naturally, this is something that is responsibility. What is to take up the responsibility? What level of bleaching? How happens these stuff related supplements? So, there is the objective of the study was assess the effect of the diet, deficiency, substitution, only saturated and unsaturated on animal model, and to evaluate the effect on weight gain and other biomarkers in animal model was studied. And to investigate the observation tests by analysis of fitness model was also evaluated. So we have taken the rats, which is another and the study was conducted in Bangalore, and the study was and what it was initially started with the 30-40 cases of rats was taken by age part and corresponding cases to identification of the and under for the age group 60 to 3 groups, then was study released, and then the numbers were placed for days, and then the study was started, the level was available, and the route of administration per oral oil as well as oil was supplemented with different categorization. So I'm going to detail about that.
OECD everything is maintained, and also we took the animal ethical clearance also to take the study. So what are the study being conducted from 28 days, from the 7th day to 28 days study was being conducted. And afterwards, we collected the blood specimens and the anticoagulant EDTA blood specimen was collected, and all the serum was centrifuged, plasma separated and preserved as and when the test being conducted. So statistical analysis, we have subjected to the one-way ANOVA statistical analysis procedure using PRISM software. And p-value less than 0.05 considered as significance. So coming to the point of methodology, animal group considered for the study as group 1 as control only or add little normal diet. Another the group 2 was normal diet plus choline, the normal diet plus saturated fat supplement, and then normal diet saturated fat supplement plus choline, and normal diet unsaturated fat supplement, and then normal diet and unsaturated fat plus choline. So that means that they are 1, 3, 5 or a control like that. They are on the diet, normal diet and on supplemented fat, but not on supplement choline. They are 3, 5, 2, 4, 6 mean 4, 6 are on choline supplementation. So coming to the analytical methods, whatever we have done, we have estimated the glucose level by as per routine testing parameters. Cholesterol, healthier cholesterol, triglyceride, amino thiols by Elman's reactions, and then total antioxidant status was done by PRATHAP. So you can see that the result. So the 28 days old rats, you can see that the blue color of control and fat diet, unsaturated, and then the red color were supplemented with citrulline. All these groups indicated weight gain. Coming to the weight gain, normally you see that the rats were nearly about 15 to 23% weight reduction seen in choline supplemented animals. So this is the same thing, but there was no change in the normal glucose levels. Again, the same repeat pattern would be able to see in total cholesterol and triglyceride also. All the groups which are all fed with choline, whether it is saturated fat or unsaturated fat, there was a remarkable significance or found in total cholesterol reduction as well as triglyceride level. Again, the same pattern you could see in healthier cholesterol also. Healthier cholesterol, it was reversal. Healthier cholesterol has increased in choline supplemented animal model, whereas in healthier cholesterol is decreased in animal model. So this is certainly good that choline certainly helps the decrease the lipolytic factors of the. So again, the total aminothiols, as you all know, that aminothiols is actually a endothelial derived relaxing factor nitric oxide. Actually a reserve aminothiol, nitrosothiols are normally stable for more than 30 minutes if it is bound to the aminothiols. Otherwise, it is a fraction of a millisecond, the nitric oxide will destroy and maintain the vascular tone as a result by. You can able to notice that also. Here also, the nitrosothiols and aminothiols are increased dramatically compared to other only fat and controlled diet. Whereas total antioxidant also increase in the normal to the structurally choline supplemented animal models. So, what are the study outcome? The study program emphasis on choline supplementation model, benefit fat diet load, scale down the serum lipid parameters. The finding from both analyzed direct test parameters were related to the final outcome, and an attempt was made to arrive at the effective choline supplementation. supplementation may be the factor to decrease the lipid profile parameters. So that's all. I'm not going to be able to explain about all these things. We'll go to the last slides. So certainly as I will explain all the details about the LDL cholesterol, it is increased, LDL cholesterol decreased, and total cholesterol triglycerides also decreased in choline supplementation. And the typical body weight recorded and sustained 40 and 35 and 20 a day. Body weight of group A, group 1, group 3, 5 and statistics significant. Increase was observed and subsequently the body weight of group 4 and 6 showed statistics significant decrease of the mean of 21%. So that was really significant when compared to group 1 and 3. So hence weight reduction. And body weight animal showed statistical significant decrease when compared to group 1 model. And HDL cholesterol concentration, animal showed statistically significant increase concentration when compared to group 1. And there were no abnormal gross pathological changes during external and internal observation during necropsy of the animals. And from the present experiment, it can conclude that choline had beneficial effect in reducing the body weight, increasing HDL value, decreasing the concentration of cholesterol, triglyceride, LDL, and VLDL parameters. So, in conclusion, recognition of growing evidence related to inadequate intake of health consequences, overweight, obesity, metabolic syndrome are common feature observed in 36% of school-going children in US. On high risk of developing fatty liver infiltration, cognitive development, atherosclerosis, possibly neurological disorders. It is also essential during pregnancy, lactation, early childhood. Hence, it is highly warranted to improve the public healthcare recommendation for choline as a nutritional supplement. So, current research suggests that failing to achieve the average intake likely detrimental to quality of health, particularly in regard to liver and muscle function as healthy population, as well as cognitive function in developing fetus and infant. Adverse neurological consequences due to suboptimal maternal choline intake may be identified in future human clinical research. So this is the result pattern all these data obtained. This is my team who worked, Mr. Mohammed Aligari is there, and my team Ms. Mamata K and Mr. Mohan. Among all those people also working on serum choline level, we have in-house prepared the kit and we have estimated there are promising results we have seen in obese and non-obese healthy individuals, and we are also working on other parameters then that will take up the matter. And also I want to tell you that the recent article, even clinicaltrial.gov, we know that clinical trial register of India, we register all the clinical study results, even for the same effect of betaine and choline metabolic health. Recruiting is going on, the study is going on, obesity is certainly definitely nutritional supplement deficiency. So that's why why not we have to take up this responsibility as researchers, we have to bring it to the government regulatory levels. Thank you. Any questions?
In the interest of time, we are moving forward, but one quick question. So if you want to naturally enrich foods from choline intake, what are some of the food items that we can focus on? So quick question, if you want to increase our choline intake in natural food, right, what are some of the items that we can?
Some of the items is certainly if you are a non-vegetarian meat diet, meat in the sense fish, as well as even yogurt is rich in choline level. But otherwise, you all aware that South Canada people eat about bamboo shoots. Bamboo shoots are rich in choline level. So we are really, that is also, and also in Karnataka, in other part, avrekai, that is also rich in choline level. So these are all, because many people they go in for bleach it, and you see in Bangalore they open the cover and they keep it in market and they sell it. As and when they wash it, it don't have any value on it. Whatever you give a nutrition supplement, cost for whether choline or any other naturally it goes.
Thank you, sir. I request our chairpersons to felicitate the speaker. To our chairpersons for their expert guidance and coordination for the session. I request Dr. Ph.D. and Dr. Divya Rani to do the honors for our chairpersons. I request Dr. Ph.D. and Dr. Divya Rani to do the honors for our chairperson. On the long-lasting consequences of nutritional imbalance during early life. The topic for the session is targeting perinatal undernutrition induced adipose dysfunction in adult life. A prototypic approach, as we are privileged to welcome our esteemed speaker, Dr. Damodar AM. We have two distinguished chairpersons, Dr. Vrinda J. Bhatt and Dr. Mithun S. Acharya. I request Rashmi to introduce the chairpersons.
Dr. Vrinda is a senior academician and specialist in forensic medicine and toxicology, currently serving as professor and head of the department at Simsic RC, Mukka, Mangalore. Dr. Vrinda has actively engaged in research throughout her career and has several national and international publications to her credit. She has also presented several papers and posters earning awards for Best Paper and Excellence in Academic Service. A dedicated medical educationist since 2001, she has conducted lectures and training sessions on medical education technologies. She is also a Fellow of Famer. Currently, she serves as the Editor-in-Chief of the Journal of South India Medico-Legal Association, indexed in Scopus. She's recognized as an NMC observer, a Ph.D. guide at Srinivas University, and the MEU and Curriculum Committee Coordinator at Simsic RC. She has delivered numerous awareness sessions for police officers, lawyers, medical officers, school children, and corporate employees on medical, legal, and social issues. We also have with us Dr. Mithun S. Acharya, who is an Associate Professor of Psychiatry at Srinivas Institute of Medical Sciences and Research Centre, Mangalore. He holds an MBBS from Kempegowda Institute of Medical Sciences, an MD in Psychiatry from St. John's Medical College, and a diplomate qualification from the National Board of Examinations. He is currently pursuing his Famer Fellowship at TSG Coimbatore and PhD at Srinivas University. Dr. Mithun emphasizes his passion for integrating fiction with mental health, a unique scholarly interest that has resulted in his receiving intellectual property rights from the Government of India in 2023.
We welcome you both. I request the chairpersons to introduce our speaker, requesting Mr. Krishna Kumar to do the rapporteuring for this session.
Good evening, everybody. It's a pleasure to introduce Dr. Damodar Gowda, a distinguished professor in the Department of Physiology at Siddhaganga Medical College and Research Institute, Tumkuru, Karnataka. He has advanced qualifications with MSc, Ph.D, MS, MRSP UK, FIA, BMS, and has built a strong academic and research-oriented career. He is an active researcher contributing significantly to medical education by guiding numerous undergraduate students in projects. His research leadership includes securing major external grants from ICMR, DST, JSPS, and VRNS, along with intramural grants to support various institutional studies. Dr. Gowda maintains active membership in several professional bodies which reflects his strong engagement with national and international scientific committees. With a prolific publication record of nearly 60 research articles in reputed international journals from Elsevier to Springer Nature, including scientific reports, molecular neurobiology, and learning and behavior, Dr. Gowda has made noteworthy contributions to contemporary biomedical research. Over to you, Dr. Gowda.
Thank you, ma'am, for the introduction. So, I am here to discuss on the topic targeting perinatal undernutrition-induced adipose tissue dysfunction, proteomic approach.
Dr. Gowda, sorry for the intrusion. You will have your first bell at 15 minutes and the second bell at 20 minutes.
Okay.
Thank you.
Yes. Okay, so if you look at the portion of a map here, so we have a small region which is occupied by the German, the part of Netherlands. Almost by the end of the Second World War, by the year 1944 or 45, the Germans completely stopped supplying the food for the natives. So that caused the Dutch famine during the year 1944 to 45. And at that time, the epidemiologists were keenly interested in finding out the long-term effects of this winter hunger. And later, they were recorded or they followed up the children who were born at that time. And they recorded the mortality and morbidity of the patients after for about 50 years. They reported that. This famine caused around 22,000 deaths. And this was popularly known as the Dutch famine or the winter hunger. So this is one of the natural experience for the epidemiologists to find out or to investigate the long-term health impact, long-term effects of prenatal undernutrition on the children who were born at that period of time. So the work was followed for about 50 years, and that provided the first human direct evidence for the lasting consequences of the prenatal undernutrition. And the various lessons learned from this study was the effect of undernutrition was on the timing during the gestation. So there is a specific window period during the gestation which caused the lasting consequences. And the undernutrition during gestation affected the structure, function, and entire physiology and the metabolism of the fetus. But what they observed was the birth weight at the time of birth was not reduced. The size of the birth remains same. But the report says that
the prenatal undernutrition causes the long-term health effects, but as per WHO, it states that both the prenatal as well as the postnatal period, that is mainly first 1000 days, that is from the day of conception for up to 2 years, is the critical window. So that is a period where the tissues were more active and more dividing, and the organ development takes place at that time. So that is considered as the perinatal period. So and this perinatal period is critical for the organ development. Any changes taking place during this critical window or the critical time which causes the adaptation in the fetus, which may cause the disorders in the later life. So accordingly, after 50 years of the Dutch famine, David Barker put forward a thesis or the hypothesis called the fetal origin hypothesis, which states that any alterations in the nutrition, fetal nutrition and endocrine status results in developmental adaptations that permanently change the structure, physiology and metabolism, which predisposes the cardiovascular, metabolic as well as the endocrine disease in the adult life. So this hypothesis is also known as the developmental origin of health and disease, and this is what started or initiates what we call the fetal programming. So we thought of, next slide please. So we thought of working on the fetal programming. So what it states, it is nothing but the nutrition inserts during the pregnancy which cause the nutritional programming leading to the adult disease. But the nutrition interventions can be reprogrammed. So we thought of developing an animal model to find out this fetal programming or to investigate the fetal programming, and we, by various trials, we could able to develop an animal model. Next slide please. So wherein we reduced 30% of the actual food consumption, which becomes the perinatal undernutrition model, and in which we thought of investigating the expression of brain-derived neurotrophic factor in the perinatally undernourished animals. So here the mothers were undernourished both during gestation as well as during lactation, but the data was collected from the offsprings. So where we investigated the level of BDNF in hippocampus, cerebral cortex and the cerebellum, and that we observed it was decreased in case of perinatally undernourished animals when compared to the controls. So this we have published in the journal called Nutritional Neuroscience. Then we thought of using the interventions using a potent antioxidant by name astaxanthin. Astaxanthin was found to be around 200 times more, has more antioxidant capacity than vitamin C, and about 1000 times more potent than vitamin E. So we used astaxanthin to find whether it has got whether it can reprogram it. So we could able to find the nutrition efficacy of astaxanthin, which can modulate the orexin peptides. So orexin peptides are nothing but the one which causes the eating behavior, or it has got an orexogenic effect which makes the human to eat more. So that leads to obesity. So then we switched our interest towards obesity. Next slide. Okay. So here we found both orexin A and orexin B was increased in case of the perinatally undernourished animals compared to the controls, but it was modulated by or mitigated by the astaxanthin and DHA supplementation. Next slide please. Okay, so if you look at this map, so this shows that obesity is one of the most important public health concerns across the world. And if you look at the map, here the USA ranks number 1, where 52% of the population is obese. So the World Obesity Federation says that 3 billion people are living with overweight and obesity. So we wanted to reprogram this, and we wanted to do an intervention with astaxanthin and DHA during the perinatal period. Next slide. Okay, so next slide. So for which we used astaxanthin. So we used astaxanthin, which is a potent antioxidant, followed by DHA. Next slide. Followed by DHA. So this DHA we used because we were interested in looking for the neuronal or the cognitive development as well. Because the DHA, though it is present in the body, even in the neural tissue, because of the development of the reactoxin species which will degrade the DHA, so we wanted to supplement the DHA along with astaxanthin. So we used both astaxanthin as well as DHA to find out its effect on the long-term health consequences. So we questioned ourselves whether the perinatal undernutrition stress-induced adipose tissue can be programmed. So for which we used a proteomic approach, and this is a study design where the animals were undernourished during during gestation as well as lactation period for 21 and 21 days each. And so we have taken one control group, and the other one is perinatally undernourished, and one more group perinatally undernourished plus both astaxanthin and DHA treated. And we collected the sample, the blood for the estimation of biochemical parameters. We used the scalp hair for the estimation of cortisol, and we used the white adipose tissue for the proteomic analysis. Previous slide. Okay, so here the biochemical parameters, especially previous one. Biochemical parameters, especially here the cortisol, the last slide there, last bar diagram, where the cortisol level was increased. So we assessed cortisol just to show whether the undernutrition has caused the stress or not. So we found a statistically significant increase in the cortisol level in the perinatal undernourished animals, which was mitigated by astaxanthin and DHA supplementation. Next slide, please. Then we went on studying the proteomic analysis, where we used LCMS, where we found around 10,926 peptide spectra matches. Out of it, the 1,230 peptides were filtered, and from finally we selected 390 proteins which were related to the adipose tissue. And again we filtered, and we carried forward these data into the statistical analysis. Next slide, please. So when MSMS data was subjected to compared to the database of RAT, we found around 4,82,393 tandem mass spectrometry data, out of which only 10,926 PSMs were related to the adipose tissue, and when we filtered it, we got 390 proteins which were selected for the further study. So this was selected depending on the fold change. Fold change of say more than 1.3 shows overexpression, and the fold change of less than 0.67 indicates underexpression. Next slide, please. Okay, so here the one which is shown on the left side, which indicates the proteins which are expressed in the presence of astaxanthin and DHA treated, where we found around 17 dysregulated proteins, which is due to the undernutrition stress. And this undernutrition stress showed 26 differentially expressed protein. So so this is the bubble graph which shows it separated the various proteins depending on their function,
depending on their compartmentalization, and we could able to find 21 differentially significantly overexpressed proteins and 5 downregulated proteins. Next slide, please. So out of them, the 3 important proteins like the fatty acid synthase, which was overexpressed, which plays an important role in fatty acid metabolism in the adipose tissue. Also, aldolase A, which is a key proteolytic, key glycolytic pathway enzyme responsible for developing insulin resistance. Also, we found one important protein which was underexpressed, which is phosphoenolpyruvate carboxykinase, which is involved in regulating the triglyceride fatty acid cycle. So these three, finally, we found out of so many proteins expressed, we found the fatty acid synthase as well as the fructose phosphate aldolase, which got overexpressed, which are responsible for fatty acid metabolism, as well as the PCK1 cytosolic enzyme, which gets downregulated. Next slide, please. So this is the heat map, which indicates the intensity of the color, indicates the expression of the various proteins. Next slide, please. So then we went on finding out the pathway enrichment analysis, and we found mainly the pathways, because we were interested only in looking at the pathways which are responsible for dysregulation of adipose tissue function, and we found the pathways related to, especially the pathways which link to fatty acid synthase get overexpressed. Next slide, please. And this is the network analysis, which shows the both downregulated as well as overexpressed proteins. Next slide, please. So coming to the conclusion, so we found 2 major proteins which gets overexpressed. They are fatty acid synthase and aldol A protein, and 1 protein which gets underexpressed, which we call it as a PCK1, which is cytosolic form. So these proteins which are responsible for fatty acid metabolism get altered in the adipose tissue. So which indicates that the perinatal malnutrition cause adipose tissue dysfunction, and with the available data we can say that the astaxanthin and DHA could mitigate the expression of these proteins. Thank you. So next slide, please. So this work was conducted mainly by the Ph.D. scholars, Meghan and Prof. Thanks to them and the funding by ICA.
Thank you, Dr. It was a very comprehensive presentation and brought about a very important aspect of perinatal nutritional value, and brought about a very nice comprehensive description about the component. Thank you so much. Whatever questions are there, it will be discussed in the upcoming cultural event in one-to-one level. Thank you so much.
Thank you, sir. I request the chairpersons to felicitate our speaker. responsibility. The important topic will be delivered by Professor Dr. Divya Rana. We are honored to have the session chaired by Dr. Vrinda J. Bhatt and Dr. Nitul S. Acharya. I request you to introduce the speaker, requesting Mr. Akash D. to do the rapporteuring for the session.
It's my pleasure to introduce all the faculty friends in this meeting, Dr. Divya Rana, who is an accomplished professional with 15 years of industry experience and 7 years academic experience specializing in organization behavior, human resource management and international academic collaboration. She holds a Ph.D. from Opitindra Global University. Ma'am has earned Masters in European Studies through a joint India-Germany program. Her diverse background includes a BBA, D-Pharma and extensive global exposure to Erasmus Mundus scholarship. She has worked in leadership roles including as founder and head of Sarlata IT Solutions. She was administrative manager at Siemens Middle East, managing international events, training administration for healthcare professionals, logistics, HR processes and compliance functions. Dr. Divya and Pradeep has published in ABDC and Scopus journals, presented papers at national and international conferences and participated in global higher education workshops. She also holds several honorary positions, including memberships in government committees and leadership roles in community organizations. Her achievements include multiple entrepreneurship and professional excellence awards. Over to you, ma'am. Just a time reminder, you will get a first minute 15 minutes and second minute 20 minutes. Thank you.
Thank you and a very good evening. A long day and I'm extremely honored to be here in this event. Thank you for the organizers and thank you each and every one. So firstly, now from the perspectives of organizational behavior, that is my specialization, I would like to bring the menopause in the workplace, a public health imperative and ethical responsibility. There are a few things to understand before I proceed to this subject. The firstly, that growth of any country is recognized by the growth of its industry. That means the economic activities or employment generation or social contributions that the companies are doing, right? And secondly, the growth of organization is recognized by the employees present in the organization. So when we say the recognition of the employees means the responsibilities towards the companies to keep the well-being ahead of the employees. So on this regard, I am pleased to present the topic menopause in the workplace, a public health imperative and workplace risk and ethical responsibility. As a background, now when we check upon some, women and men face different risks and health problems. As I said, HR, there are only two gender exist in the organization, that men and women. So looking into that, the women and men face different risks and health problems. Women's and men's bodies interact differently with working. So especially for women, reproductive health factors, that is pregnancy, menopause, significantly influences women's decision in the workplace to continue or to exit from the workplace. So these natural aspects of female, reproductive health are frequently overlooked in the workplace structure and also in the policies. So support from the system, if you see, the pregnancy and even menstruation now is supported by the organization, but there is absolutely no talk about the menopause that we are seeing in the organizations. So based on this, just to give a few glimpse upon the menopause, that the menopause has 3 stages: perimenopause, menopause and postmenopause. In each stages, there are various different difficulties, there are various different problems, there are various different supports that is required by the environment, from the organization and even from our loved ones for we can see here, headache, mood swing, hot flashes, muscle, joint pain, weight gain, hair, skin losses, dilation, intimacy, bone hair. There are so many things that we can talk about when it comes to the menopausal issues and the problems. So when we look into the literature as well, it says a lot of things in terms of the problems that women face in the menopause, but a very few points that I would like to highlight here. Menopausal symptoms affect work, well-being and daily functioning. Heat, sitting long hours that intensifying symptoms are troublesome for women. Menopausal-related symptoms can lead to reduced job satisfaction, poor well-being, anxiety and professional withdrawal. This is the main problem that we are facing today. As if you really see, 50% of the world population are women, as well as in India, almost 50% of women are, the population is women, but only 23% of women are in employment, and also the literature says that a lot of attrition happens, especially during the mid-age or post-mid-age. The reason could be many. The reason could be work-related issues or household issues or lack of accessibility to so many things or caregiving responsibilities to our elder parents or elder in-laws. There are so many things. But also the literature says here, menopause could be one of the reasons where women try to exit from the employment in an early stage before their retirement. So this we would like to stop, because as I initially said, our country's growth is, it is completely dependent on with the organizations, and the organization dependency is high in terms of their human resources. And we would like to retain those women who would like to exit from the employment due to menopausal issues. Also, more on the literature, menopause is silenced due to socio-cultural belief associated with it, impurity, aging, loss of femininity, taboos that limit the discussion to only female colleagues. Open communication is hidden in the organization due to taboos or worsening women's well-being. Taboos lead to also misunderstanding, reputation of gender stereotypes, as well as it creates a gap, menopause-related awareness. So women, they keep it on themselves. They don't discuss with anyone in the organization. So the research gap, this is a research that we have conducted at Global University. The research gap we found here is, in India, the woman menopause is hidden behind the culturally bound taboos around women's bleeding bodies, and menopausal concerns in the Indian workplace are unknown and seldom addressed in the extent of the literature. Menopause is a natural phenomenon that we should not neglect. It is natural. It is not something that it is, woman has invited. It is our body, right? So that needs to be addressed in the organization. The research gap that I am going to talk about here is the lived workplace experiences of female employees undergoing menopausal transition, which is not seldomly expressed in the extant literature. So as I said, the first question, what you can see, we have here investigated basically 3 questions, but today I'm going to only talk about the first one. What are the lived workplace experiences of female employees undergoing menopausal transition in Indian organization? So we have chosen as a research objective to explore the lived experiences of female employees in undergoing menopause in the workplace or in the organization. So we have chosen a method of qualitative methodology due to the exploratory nature of the research. That a qualitative methodology was chosen here as you can see, and we have here a descriptive phenomenology is a methodology, a qualitative methodology that we have chosen here. Edmund Purcell is the one who developed this phenomenology, and I'll be going to explain how this phenomenology was in terms of the analysis was put forward, and how we have analyzed the data in terms of bringing the lived experiences of women at the workplace. So some of the very qualitative things that we have implemented here is a bracketing in phenomenology, which is very important. So bracketing is applied in this methodology to keep away the researcher's exemption. Maybe different way, and we put forward this question to the women who are undergoing menopause. And in terms of the sampling, the criteria sampling was applied in this research. So what is the criteria sampling? We have selected only those samples which come under those criteria. The criteria here was followed. A working woman experiencing menopausal transition, age ranging from 41 to 52 years. So this is a menopausal age now confirmed in Indian context, performing white-collar job, working in the sectors technology, banking, healthcare, telecommunication, fashion and textile. The geographical area is Karnataka state, and people who can communicate only in English are the samples of our study. And why we have chosen these samples? There is a clear indication here. According to the Pan-India survey, the menopausal transition age of the woman is clearly saying from 40 to 51 years. And white-collar job, 35% of increase in women's job who are in the white collar. So we want those candidates to be examined. And then in India during the last decade, there is a significant growth of participation in women in the sectors that I showed earlier. Textile, communication, all those are the sectors. And Karnataka state is one of the top 5 states where women are employed in the organization. So that's the reason Karnataka was chosen. And to minimize any error that we have kept English language spoken, in our sample. This is the criteria that we have kept. And coming to the sample size, if you see that homogeneity is a practice in the sample. We are only dealing with people or ladies who are going through the menopause or who have just gone through the menopause in the workplace. So that is how. And in this research, in this methodology, there is it says that it is not necessary that we have to, do hundreds or 200s of samples. No, until you achieve the saturation, you collect the data. So we have achieved the saturation at the 17th sample, and that's until that the data was collected. So that's how the sample size was also, chosen in this research. As you can see, there are 17 samples of different age group and different industry and different departments they are working in. So data collection, again, it is a semi-structured interview, that individual independent interview, respecting, their privacy, and by taking, their consent, that interview was conducted here, and step-by-step analysis was done. So now going through what my analysis says. So as I said that colysis descriptive phenomenology is a methodology that we have used here in this research. This colysis method has 7 steps of analysis. The step 1 is where you are transcribing your script, then you are extracting the significant statement from the script, then you are formulating a meaning from the script, and then after that aggregated and formulated meanings are grouped in clusters. And once the clusters are formed, you are developing an exhausting statements from the clusters and fundamental structure phenomena. And finally, you are validating the finding of the study, by getting back to the participant and asking them whether this is what they felt. So this is the entire structure of the, methodology that shows here. As you can see, this is a transcript, and we have transcribed here the step we have done here. Step 3, I will show you something. So you can see here, extracting significant statement. In one interview, we have collected maybe more than 50-60 statements. So some of the statements, I used to love my job before. I used to love giving customer service. But during this phase, my life, whenever I see my customers, I get angry. I hold it. I hide behind the screen. This is a statement. I told him, my manager, that, I'm going through the menopause. But he asked me, what is menopause? Is it menopause? So these are the answers that we are getting, as you can see. I moved from that place and I started working in another place. I felt like quitting the job immediately. I had my problems. I had my, my children. I had to pay my children's fees. I had to pay my old mom's bills. Then I could not leave the job, but I felt like I should immediately quit my job because of the responses that I received from in the workplace. So these are some of the really concerned statements that we received from the people around, in the interviews. I used to walk. So these are some of the statements again I have and it made a formulated meaning. There's entirely a slide which I can quickly move on to that, and then we will know how the formulated statement. See, as you can see, formulated meaning relying on supplements. Somebody says that I take medicines, I take treatments, all those relying on supplements. So all of the grouping up for the problem finally came into the theme as employing coping strategies. And then organizational emotions, organizational load control. Somebody is not coping up, somebody is saying that what is menopause, is it menopause? What is it? This is an organization, it's an organizational gender inertia, right? So we found the theme of economic gender inertia. The third one, the detachment, the exclusiveness, the insecurity, all the emotions, including emotional, again we found. And finally, the playing up and experiencing the vicissitudes of menopause as a problem. The problems, the tiredness, everything that put together, experience the vicissitudes of menopause as a life. So at the end, we have come out with the beautiful things here, experiencing the vicissitudes of menopause as a life, and conquering institutional gender inertia, and including emotional responsibility, and employing coping strategies. These are finally 4 keys which gave us a lot of input, lot of findings in terms of understanding how women are confronting the deluge of problem where their daily functioning was constantly challenging. As you can see, encountering institutional gender inertia, this thing revealed how organizational structures, attitudes, failed to support. There was no, if our lady is using the AC, she was taught she is a kind of alive in the organization, but she should not take that. So this kind of thing, there is no proper bathrooms, there is no proper sanitation facilities, which really troubled. But the doctor was really telling us that her clinic was on the 3rd floor of the hospital, her consultation, and she had really walked down 2 to 3 floors down to use the washrooms, and the washroom was completely messy, and she was always very much afraid to wash that, use the washroom because the hygiene was a matter of order. Similar, the third one here, enduring emotional disposal, this is emotional. Your body changes, your weakness, your efficacy, your growing old, all these are concerns that employing coping strategies. Some said that they wanted to quit, some said they went for some vigilance and other things, some said they started practicing yoga. These are the coping strategies that women started exploring. As you can see, this is also of one's life. There are many statements that are given here, how each one has told us, and how this is comparing with every statement that has been covered. Similarly, conquering institutional gender inertia, and then after that, enduring emotional despondency. As you can see, the statement is over there, and employing coping strategy. So finally, that what we want, organizations. So let's come to the last slide here. It's important that the organization realizes that menopause transition is not an illness, but a natural biological process. It is very important organization to realize. Absence of menopause policies for women's welfare is a distinct workplace disadvantage for mid-age employees as well as organization, with the risk of losing capable women employees much earlier to their retirement. Organizations must move beyond gender neutrality to implement gender responsive policies that can introduce and target health and well-being of the woman. This is what we have come up with a statement through our research here. Implement a gender responsive survey and also benchmark the progress with ensure continuity and improvement in the organization. So finally, there are many things which the research says that how you can contribute to practice, how you can contribute to society, enhance employee well-being, productivity gain, how one can make through flexibility, fostering workforce diversity and innovation can be brought in. This is very interesting. It reduces absenteeism. When you start implementation, it can reduce absenteeism, it improves mid-life career, mid-career retention, strengthen employer brand. Now we are seeing many big organizations do come up with the menopause policies, and yes, they are recognized through their brand as well. The brand recognition also do happen. It is necessary that organizations understand menopause as a natural, life-changing, phenomena and create a cooperative workplace for women leveraging their contribution to business as ethical and social responsibility, which is on a broader scale. It is, at the end of the day, it is a social responsibility for the organization, outreaching, right? Develop society, develop nation, develop country. So how do you do that? You have to enhance, improve your employees so that they can contribute you better. A healthy employees, isn't it? A happy employees. So target for their well-being. And one small segment here, I should not say small, a big segment here, 23% today, but now the gap is now actually decreasing. Education gap, tomorrow it could be even equal to 50%. And we can see our India also flourishing when the economy grows, right? So that's where this research can definitely contribute in terms of, and there might be many researchers sitting here. There are some open areas here where you can do the further research as well. The study proposes the following research for the research students here. So you can have a study on blue collar, employees. You can study on multiple regions across, and also you can have a cross-sectional and cross-cultural study in terms of the workforce. There are so many openings here. So that's how, with that I would like to, and I hope I have also kept up the timing. So last one, ensuring quality. Since it is a qualitative analysis, it is very important that we ensure quality in our research. So we have definitely ensured the quality in terms of ethical rigor and standards, bracketing and reflexivity, credibility and conformity, triangulation and uniqueness, and transferability. That is the qualitative, equal into the quantitative journalism. We are doing in the quantitative, right? Apart from that, we also have the other, qualitative measures, in terms of ethical and other statements. So, thank you so much.
It was a wonderful presentation, and I'm really stunned that in the 21st century, we women have to shout at the top of our voice that, even at the white collar and English speaking and, even at this age, we have to shout at the top of our voice saying that, please give us a space. And I hope you will be able to bring about some changes out of this study into this esteemed university also.
Yes, ma'am, sure. So firstly, now we are planning to make a small, a booklet kind of a thing by putting all our, study findings and sending it to the organization.
No, we will discuss this at one-to-one level because I have some points to tell.
I'm very glad and I'm happy to collaborate.
Yeah. Thank you so much for this wonderful presentation and truly an eye-opener.
Thank you, ma'am. Thank you so much.